या ऑन करके रख ही दो।
On.
रूम पे कौन आ गया? रूम पे कौन आ गया? रूम पे हाँ समझाने नहीं देखे अभी तो वही बताएगा उनको तो कोई नहीं पर उनको अच्छा से बोला था मैं दबा दबा मैं आगा गाड़ी भेजूंगा सुबह फोन उठा लेना क्या बोले अभी लोग डरते हैं आने से मुझे लगता है बोलना पड़ेगा कुछ।
Good morning and welcome to all for Ignite AOICON 2023, a live ENT surgical workshop which is being held at Mahatma Gandhi University of Medical Sciences and Technology, Sitapura, Jaipur. The purpose of this workshop is to ignite you all along with us for the magnanimous and one of its kind AOICON 2023 Jaipur. It is the National Conference of Association of Otorhinolaryngologists of India. The National Conference AOICON 2023 promises to deliver a never seen before academic event along with beautiful cultural experience. AOICON 2023 is committed in delivering holistic experience in terms of science, accommodation, culture, food, and social interaction. Kindly register yourself for the same at the earliest if you haven't as of now. The registration details and the details of the conference AOICON 2023 Jaipur are available on the website www.aoicon2023.com. The organizing chairman of the conference is Dr. Manprakash Sharma sir, and the organizing secretary is Dr. Tarun Ojha, who is also the organizing chairman of today's live surgical webinar, which is held at Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. We also have a very dedicated and committed team of working members to make this event a grand success. Now, I would also like to invite Dr. Satish Jain sir, who is an esteemed host for AOICON 2023 Jaipur and will also be performing the live surgeries today in Ignite AOICON 2023. To begin today's session, now I will request all the residents who are the cornerstone of our ENT department, just like every other resident in every other department of ENT, who aspire to learn, work hard for developing the future of ENT, and for whom we have dedicated this Ignite AOICON 2023, a live surgical workshop. So kindly come, light the lamp, seek blessings along with Dr. Tarun Ojha sir and Dr. Satish Jain sir. I would request all the residents and sir to kindly go for lighting the lamp. Thank you.
आएगा 11 बजे।
Thank you, sir. Thank you, all the residents.
चलो मैं बोल
Thank you, sir. Thank you, all the residents. Now, I would request the organizing chairman of Ignite AOICON 2023 and the organizing secretary of AOICON 2023 Jaipur to kindly come and speak few words on this occasion.
Good morning. Firstly, I would like to extend my gratitude to all my seniors, my colleagues, my juniors who have taken their precious time out on a Sunday to be here with us for this live surgical workshop. I truly appreciate your presence here with us. I would also like to take this opportunity to invite you all for the AOICON 2023 Jaipur to be held from 2nd of Feb to 5th of Feb 2023 at BM Birla Auditorium, Jaipur. We as organizing team are putting immense efforts in making this conference a huge success. We are in the process of inviting the most renowned and experienced faculty, both nationally and internationally, to put together a perfect academic event to boost and update your skills and knowledge. We have taken special care to make your stay a very pleasurable and memorable experience, along with local, that is Rajasthani delicacies to savor your palate. I would request you all to kindly register for AOICON 2023 Jaipur at the earliest to avail maximum benefits and to not miss out on this opportunity. Looking forward to hosting you soon. Also, we will be hosting similar live surgeries and hands-on workshop. Therefore, do stay in touch with us. Also, for regular updates, kindly visit our website, that is www.aoicon2023.com. Wishing you a pleasant learning Sunday. Thank you. Be with us. Thank you.
Thank you, sir. Thank you for those kind words and telling us about the National Conference AOICON 2023 Jaipur. So the today's program, Ignite AOICON 2023, is workshop which is solely dedicated to ENT from basics to advanced. Satish Jain sir will discuss the preoperative evaluation, surgical techniques, and the post-operative rehabilitation. Also, I would request all the delegates, as they are most welcome, to post their queries, which will be answered by Satish sir. To begin, we have a list of 8 cases lined up, and the details of all will be explained before each case. The cases range from cochlear implant, nasal surgeries, otosclerosis, parotid, and so on. Now, I would request Vaishali, my colleague, to talk about the first case in detail. Thank you.
Let's start this marvelous day with the first demonstration, which is the cochlear implant surgery, which will be demonstrated by Dr. Satish Jain sir on a patient named Baby Shivya, who's 2 years, 7 months old, female. Sir will talk about the prerequisites to surgery, the surgical techniques, and various factors to be considered during the surgery and after the surgery. The moderators for this session will be Dr. Satish, Senior Professor and former HOD of SMS Hospital. He has a past of 27 years in SMS Hospital, Jaipur, and is a pioneer in otology and neuro-otology, and has multiple publications under his name.
Hello, you are not audible.
Chota karo. Continue karo tum yaar.
And has various talks at national and international level. Next is Dr.
Dinesh, she is not audible.
Hello, hello.
Hi, sir.
Yeah, it's slightly better now.
Okay, sir.
Sir, can you hear us?
Yes.
Yes, sir. She is audible, sir. Okay.
Bolo
Sir,
yaar.
second moderator is Dr. Kapil Sikka, who's additional professor of ENT department in AIIMS, New Delhi. His fields of interest is otology, neuro-otology, and cochlear implant. And he's also a member of the Cochlear Implant Group of India and has published many research work in cochlear implant. And third is Dr. Monish Grover, who's done MS ENT from AIIMS and is presently as an associate professor in SMS Medical College, Jaipur. His areas of specialization are cochlear implant, endoscopic skull-based surgeries, and has demonstrated various live surgeries and cadaveric dissection. And he's also a joint secretary of Cochlear Implant Group of India. Now I would hand over to Dr. Satish Jain, sir, for the demonstration. Thank you.
Good morning, all. Am I audible?
Yes.
Good morning, all. So first of all, I invite you again on the behalf of the organizing team of AOICON 2023. This workshop is, aimed to ignite the scientific activity for the upcoming mega conference. And for this conference, our organizing team, led by none other than our organizing chairman, Dr. Man Prakash Sharma sir, and the most dynamic Dr. Tarun Oja boss, who is the secretary for the upcoming organizing conference, and they are doing everything to make it a mega successful conference from the academic as well as many other angles. So, thank you once again for joining us to be part of this scientific activity. And I can see on the screen our own teacher, Dr. Sunil Samdani sir, who has been my favorite teacher since my residency, and I've been learning from him time to time whenever I get opportunity to interact with him. Thank you so much, sir, for being with us. And I believe Dr. Kapil Sikka and Monish are going to join us soon, who have been, instrumental in initiating and propagating cochlear implant program in India. Monish, especially in Rajasthan, has done number of implants and trained many surgeons in Rajasthan. So hoping to have them soon with us. So this upcoming AOICON 2023, you can imagine the enthusiasm from the organizing team for organizing or announcing to organize multiple academic events before the mega conference. And I can see on the screen the most dynamic AOI secretary, Dr. Kaushal said, hello. Hello, Kaushal.
Hello, sir. How are you?
How are you? Good,
morning.
good to see you. So
Yes,
the
sir.
team
All the
AOI,
best for this.
thank you.
Ignite,
The team AOI
AOICON.
is doing
Yes.
everything to take the academics in the otolaryngology at a different level, and we can see time to time activities from the AOI, some innovative, surgical workshops and activity from the AOI which we have never seen before. Thank you, Kaushal, for doing all this. So regarding 23 conference which Jaipur is hosting, the organizing team, as I said, as we heard just now, our organizing secretary, Dr. Tarun Oja, has been doing tremendous efforts to make it something, something never before kind of a conference for the AOI. So we invite you with our both hands folded for the upcoming AOICon 2023 to the Jaipur. Today's workshop is, the beginning of the upcoming series of workshops to ignite the scientific activities for the upcoming national conference. And this workshop, wherein we are going to discuss some basic to advanced situations, we are going to have number of cases to start with the cochlear implantation first case, with many other rhinology and head and neck procedures. Hopefully till 5 or 6 o'clock this evening. Then, as our Dr. Tarun Oja boss has announced, we'll be having series of hands-on workshops also before the AOICon 23 to make it memorable for the junior colleagues to give them hands-on experience in Jaipur. So thank you, boss, for all the efforts. And for this case today, there's a young child having bilateral profound sensorineural hearing loss and has been chosen as a candidate for cochlear implantation today. Though, of course, we are doing unilateral implantation, we all know bilateral implantation is the state of the art now in the present scenario. So as far as the cochlear implant is concerned, we all know ever since it started, it has gone, tremendous development, not only in the development in the surgical technology, but in the development of instrumentation, better understanding of the anatomy of the cochlea and further higher auditory pathways, better development of the technology in terms of various, innovative electrodes and implants, more and more options for the different category of patients who are candidates for the implantation. So this science is developing like anything. One of the fastest developing field in the medical science, I would say, in the past couple of decades. You can imagine when this cochlear implantation started few decades back, the indications were very limited for selected children, prelingual deaf children with certain degree of hearing loss above 85 degree or so, with certain criteria for to be candidate for cochlear implant. But with the advancement in the technology, advancement in the development of this science, the indications have been expanded, and now by and large, any candidate, irrespective of the age, irrespective of prelingual, postlingual, whatever scenario, any candidate which is not benefited by hearing aid for the sensory neural hearing loss is by and large a candidate for cochlear implantation, provided the basic functioning unit is intact. This is very important for everybody to understand the indication, the basic functioning unit for the cochlear implantation. And for cochlear implantation, this basic functioning unit is what we are implanting. We are implanting the electrode to stimulate the nerve endings in the cochlea, wherein the cochlea has become non-functional. So, in order to for the implant to be successful, what all we need is a intact fluid-filled cochlea and an intact eighth or the cochlear branch of the eighth cranial nerve. That is very, very essential for an implant to be successful. And a fluid-filled cochlea and the intact cochlear nerve. These are the two important prerequisites for a cochlear implant to be successful, functional, and effective. So this is very important. So for choosing the candidates for implantation, as I said, the indications have been expanded. Not only for the prelingual deaf children, adults, even the elderly patient. Age is no bar in the present scenario. Even the 80-plus-year-old people have been implanted who want hearing. Provided the basic functioning unit is intact, they are fit for the from medical side and all that. So anybody can be implanted where the hearing aid is not working, provided the basic functioning unit is intact. For this, a lot of other workup is required for this implant to be, optimally effective. For children, we have more, selection criteria as compared to adult. For prelingual children, where the speech is the main, factor, the development of the speech is the most important factor. In the parents' involvement, their medical workup, their audiological workup, their radiological workup, there's so many, immunization workup, and all these things are important for carrying out a successful cochlear implantation. So, as far as the workup is concerned, as I discussed, you can see the CT scan on the screen. The radiological workup is very important. Similarly, audiological workup is very important in order to choose a good candidate for the successful cochlear implant. Then, as I said, immunization workup is important, particularly for children, to prevent post-cochlear implant infection, particularly pneumococcal infections, which are dreaded infection, can lead to meningitis and even life-threatening. So everything is important, and particularly for the children, the parents must be committed for the overall better outcome for the implant as far as the speech development is concerned. So a lot of sessions are spent with the children, their parents, in order to prepare them for the surgery and the post-operative rehabilitation and the overall outcome. So it's overall a teamwork wherein audiologist is a prime member or the most important member, I would say, besides the surgeon for this overall successful program, cochlear implant program. So before I go to the radiological part, anybody, Sunil Sandani sir, if you want to say anything or any questions or anything before we proceed to the important radiological part.
Yeah, Satish, I just wanted to add, when you say that all the candidates who are not benefiting out of the hearing aid are the candidates irrespective of the prelim or
by and large, yes.
So I would just like to add that the hearing aid quality should be a top quality hearing aid, which has a proper gain for the severely or profoundly deaf children or moderately severe. Because appropriate fitting of the hearing aid and the trial of the speech therapy perioperatively is important to eliminate unnecessary cochlear implantation in some cases. So it should not be a just routine hearing aid and speech therapy. It should be a properly fitted, appropriate hearing aid.
Yes, that's a very important message from sir. See, cochlear implant cannot be a replacement to the hearing aid. It cannot be anywhere close to the quality of hearing what we get from a good hearing aid. See, cochlear implant whatever hearing it provides has a narrow spectrum. The dynamic range of hearing what we get from the cochlear implant is very narrow as compared to the acoustic hearing we get through the hearing aid. So hearing aid cannot be replaced by cochlear implant. So as long as the hearing aid work means the best available hearing aid, if the patient is happy with the hearing aid, with the quality of hearing, cochlear implant is nowhere indicated. So that has to be very, very clear. Now coming to the radiological part, why it is important for the surgeons? The radiology is important for the radiologists. Why we surgeons are so concerned about the radiology? Because we want to extract the maximum anatomical details, which is useful in carrying out a successful and the safe surgical, operation for this particular patient. So from radiology, if we take the the kind of radiology required, what all we need is both a CT scan and MRI for the different indications. CT scan is important to give you anatomical details of the temporal bone, particularly bony details, which are important to know in carrying out surgical operation in that area. You need to know the three-dimensional anatomy of that area, particularly the anatomy of the cochlea and the surrounding structures, facial nerve, facial recess, so many things, vascular anatomy around. All those things are important in carrying out a proper operation. Similarly, MRI is important. As I said earlier, we need to know the basic functioning unit intact for a candidate to pass, eligibility for a cochlear implantation. That is the cochlea, which should be fluid filled, and the intact eighth cranial nerve or the cochlear nerve for the cochlear implant to be effective. And that is best seen by the MRI. MRI is known to give the best soft tissue details, and CT scan is known to give best, bony details. And both have investigations complement each other to get the maximum information before surgical planning. This is very important because many of these patients, particularly children, have malformations, congenital malformation leading to profound sensory hearing loss. Though many of the patients' malformations are not visible even on the radiology, because what we see on radiology are bony malformation. The malformation at the membranous level cannot be picked up by radiology, and still many patients looking like normal on radiology, we may face complications, what we face in malformation. So we have to be in any situation prepared for all those complications, but still a good radiology can give you a proper pathway for a good surgery. So CT scan is important, MRI is important, and we need to know how to read and how to get the maximum information out of which. Otherwise, radiologists are, either you have to make a team with the radiologist to know what all information you know from cochlear implant perspective. If I send a CT scan to a radiologist to report, they will report in single line the normal anatomy of the temporal bone. That is of no use to us when we are planning a cochlear implant surgery. What all is important to us when we are planning a cochlear implant surgery, to know the anatomical details in relation to the surgical procedure of the cochlear implantation, in order to know the anatomical abnormality which can pose difficulty during surgery. All those things which can pose difficulty during surgical procedure, we must know beforehand to plan our surgical technique accordingly. We may have to change our surgical technology according to the the radiological information. We'll discuss during this details of the CT scan. So
Satish boss, good morning. Kapil Sikka here.
Hi, good
I'm
morning.
sorry I joined late. Yes.
We are waiting for you, man.
I'm sorry, sir. Sorry for delay.
So for everybody, the Kapil Sikka has come in, the most dynamic, who has been committed otologist and one of the pillars in taking this cochlear implant program ahead in the All India Institute of Medical Sciences, the prestigious institute of our country. And Kapil has been always been academically oriented and committed to teach each and everybody. So Kapil, we would like to have your comments.
I have been listening to you, sir. I think
of everybody.
I have been listening to you, sir, and Samdani, sir, for some time now. I just wanted to ask you and engage in discussion. Many patients, they come to you with a CT scan that is 1 year old or 1.5 year old, and they come to you for implant now. Do you repeat it, or do you take it at the value, the old CT scans?
Yes. See, I have already mentioned the CT scans are, ordered to get the anatomical details, 3D anatomical details. So if somebody is holding a CT scan in hand, what all I will request him to have a digital information. I want the CT scan in digital data to extract 3D information, because in digital data, I can convert to 3D and get three-dimensional anatomy. But sometimes what happens, the patient brings the CT scan printouts. To me, those are not adequate to get best information related to my surgical procedure, because that's what I'm going to put forward, the kind of CT scan we need and kind of CT scan, person should order to get the maximum information. So your point is valid, Kapil, and that's what I'm, starting, that what all is required to know from CT scan. If the patient is carrying CT scan with all that information in hand, why to repeat unnecessarily? The anatomy is not going to change at all. But what we want to know, whether the CT scan is adequately, done, whether we have complete information from the patient what is having CT scan in hand. So
Right.
that's why we order always CT scan in digital format, and with our software we can reconstruct to all planes to get maximum information. That's the information. That is why the onus is on surgeon to read CT scan on our own rather than relying on the radiologist's information. We want anatomical details. With this, software, we can measure the anatomy in some millimeter, fashion, which is important sometimes, very, very critical from cochlear implant point of view. So I would like you to interrupt me any point of time. You want to add on anything? I know anything, a single word coming from you is going to be very, very important for everybody. Thank you, Kapil. And I can see on the screen Dr. Markande Tiwari with us, who is the head of department at the prestigious Government Medical College, Goa. Thank you, sir, for being with us and enlightening us with your experience today. Thank you so much. So before going to the CT scan, as I said, we want a digital format so that, and where I am running my CT scan on this, Radiant DICOM viewer, wherein I can get the maximum dynamic three-dimensional information, which is useful from cochlear implant point of view. CT scan, a high-resolution CT scan temporal bone, has to be read from different ways, from different perspective when you plan different surgical procedure. For example, if I am planning otosclerosis surgery, we have a case of otosclerosis today to demonstrate. In that scenario, I will be reading the CT scan from different perspective to touch upon or to look at those important information which are more relevant from the otosclerosis surgical point of view. Here, I will be reading the CT scan more importantly from the cochlear implant perspective. Anything which is related, any anatomy which has an impact on the cochlear implant surgery, which can change the overall, outcome of the cochlear implant surgery, which can change the procedure of the cochlear implant surgery required. Anything which has an overall impact on the cochlear implantation surgery, we are going to discuss. So, what all to be discussed on CT scan? We need all axial, sagittal, and coronal planes, where our radiologist, shoot the CT scan in the axial plane always, and you can see it is fine section, sub-millimetric 0.6 mm at the left lower end. You can see 0.6 mm sections. We have 196 images. You see the area scanned by this, and with this software, I can convert this to three-dimensional now. This is a very important teaching tool for the junior colleagues as well. If you are reading the CT scan this way, and you can read the anatomy in all three planes. For example, if I take my cursor in the axial section on the basal turn, you can see in all planes where the basal turn is, and this improves your overall understanding of the CT scan in three planes. So this is an amazing teaching tool, number one. Number two, it gives you dynamic information. For example, what do I mean by dynamic information? If I want to see the facial nerve course, if I want to see the cochlear turn, I can see dynamically the CT scan through this, DICOM format. See the facial canal, the vertical facial canal, right from the, the foramen, the external foramen, the stylomastoid foramen. I can see the entire course of the facial now, how it is traversing through the temporal bone, how it is in relationship with the various important structures like lateral semicircular canal, the round window, how it is important to all these structures. And this is important from cochlear implant perspective. So we need to know what all to be seen on CT scan during cochlear implantation, though I'm not going to be in very details as the patient is, being prepared. So I will touch upon quickly the important things to be seen on CT scan from cochlear implant perspective. So this is axial section. I will mention every time what all to be seen on axial section, which gives best information, what all for information which is gathered best on coronal as well as sagittal sections. So we need to know all that information. Now, so I am running my CT scan from top to bottom. Kapil, am I audible to you?
Yes, sir, perfectly.
So feel free to interrupt me anytime, dear.
No issues.
See this. I am running from top to bottom, and every time I move, this is 0.6 mm slices. Every single movement, I will be moving by 0.6 mm. That is beauty of fine section. If suppose I have a 4 mm, 5 mm CT scan, with every slice I will jump by 4 or 5 mm. That will be too inadequate, in terms of giving information in temporal bone, wherein a sub-millimetric anatomy can change the overall scenario. Now see, the first structure to be seen is the superior semicircular canal, the non-ampullary end and the non-ampullary end of the superior semicircular canal. You can see here. See this again. The superior semicircular canal to begin with, then this ampullary end, non-ampullary end. You can follow the ampullary end. This is important. Though the superior semicircular canal per se is not important from cochlear point of view, this is more important, we will see in a otosclerosis point of view. But for everybody's information, this is best seen on coronal sections. Let me show you. The lateral superior semicircular canal is best seen on coronal section. Can you see my cursor? That is the vestibule. See all the three canals, the lateral canal going laterally here towards the mastoid air cells. This is superior canal going towards the middle canal fossa. And if I want to see the dynamic superior canal, the full course dynamically, see this. See the bone over the superior canal which is intact. That is important to know if there is any superior canal dehiscence. I told you that is more important, more relevant from in otosclerosis surgery than in cochlear implant. But any malformation of the semicircular canal is very important in cochlear implant surgery. If there is any malformation in the semicircular canal, we must be prepared to see the abnormal course of the facial nerve. That is important. Facial nerve is an important, anatomy in cochlear implant surgery, and to protect the facial nerve is a very important part of the surgery. And facial nerve malformation, abnormal courses are common once there are malformation of the semicircular canal. So in CT scan, the first thing we see any malformation of the semicircular canal. See, this is superior canal and forming the vestibule here. This is vestibule. Now coming back here, what all we see here during this course, what is this? This is round window. This is round window here. This is round window. That is the cochlea. That is round window. That is the facial nerve here underneath the lateral semicircular canal. So best thing to see the semicircular canal, all the three canals together dynamically. To see any malformation, we need to look at the coronal picture. That is one important thing we can make it. So this is one thing to point out, and we should not miss any malformation of the canal, particularly lateral canal. Lateral canal malformation are almost always associated with facial nerve malformations. Now coming down, see this. This is superior canal. I'm coming quickly down. What we see here is the vestibule. This is the vestibule, and from the vestibule, both the ends of the lateral canal looking like a signet ring. Can you see this? That is the ampullary end of the lateral canal. That is the non-ampullary end of the lateral canal. And this is very important anatomy here. This is vestibule. That is lateral canal. We need to see all the canals together. This is posterior semicircular canal. See, this is vestibule. Looking at the orientation of the cochlea in the body, this is lateral, this is anterior, this is posterior. And what we see, this is the posterior semicircular canal again emerging out from the vestibule. This is the ampullary end of the lateral posterior semicircular canal emerging out of the vestibule. Another thing to be important and looked at is the vestibule. The dimension of the vestibule is very important. See, many a times in many of the malformation of the inner ear, the enlargement of the vestibule is one of the associated malformation along with the cochlear malformation, and we need to be very careful not to overlook this anatomy if it is enlarged. An enlarged vestibule and an enlarged vestibular aqueduct. Can you see this? This is the vestibular aqueduct. Can you see? This small. See this, this is vestibule. From the medial wall of the vestibule run the vestibular aqueduct, which houses the endolymphatic duct, which opens at the posterior petrous surface. This is the vestibular aqueduct. We need to see in all our CI patients very carefully if there is any enlargement of the vestibular aqueduct, like which is common, in Mondini malformation, wherein there is an incomplete partition of the type 2 of the cochlea and vestibular aqueduct enlargement. Vestibular enlargement is seen in IP1 as well. And the importance of the vestibule and the vestibular aqueduct enlargement is maybe associated with, gusher, not gusher, but at least oozer, because this endolymphatic duct or enlarged endolymphatic space is responsible for transmitting the CSF pulsation, which may result in sensorineural hearing loss and which may result in pulsations of the perilymph when you open the inner ear, when you open the cochlea, and can result in some sort of oozing, sometime even in gusher as well. Uncommonly, gusher is most commonly associated with abnormal communication of the lateral end of the canal with the cochlear base. So what we have seen so far, the semicircular canal, the vestibule, the vestibular aqueduct, everything is important. Now, as we go down, the another important thing we need to look at this point of view, this is internal auditory meatus. A normal size internal auditory meatus is something which is safe for the cochlear implant patient, safe and important from different point of view. Let me change what do I mean by normal size. With this software, I can measure the dimension. See, the dimension is 4.4 mm, which is normal dimension of the intra-auditory meatus in a mid segment. Now, what happens? Sometimes this intra-auditory meatus may be bulbous, dilated, and should warn the surgeon of having abnormal communication with the cochlea to give a gusher. See, all these things which can give rise to gusher, one must be prepared with to deal with it, because gushers can have impact on the surgical procedure. In overall surgical planning, there are many situations wherein the gusher is imminent, and which you can pick up by the radiology, like in IP1, common cavity, IP3. Those are the situations which are more likely to give gusher, wherein the stopping the cerebrospinal fluid egress is very, very important. And many a times in high risk individual, we change our surgical technique to a subtotal petrojectomy implantation, which gives us the best technique to tackle the CSF gusher. So all this anatomy, all this CT scan has a relevance on choosing the surgical technique as well in difficult situations. So the role of the CT scan, as I said in the beginning, is to know any difficulty one can encounter. You can preempt by the CT scan if somebody is going to encounter any difficulty which can have a significant impact on the overall surgical procedure. Now, besides the cochlear implant, now the other important thing, once we look at the intra-auditory meatus, see, if I look at the intra-auditory meatus here, there are so many things which are emerging from the intra-auditory meatus. The first thing, see here as well, this is intra-auditory meatus. If I come from top to bottom, the first thing coming anteriorly from the superior part is the facial nerve. See, this is the facial canal. That is the labyrinthine segment of the facial nerve. If it is clear to you, hope it is clear to you.
Yes, it's clear.
That's the labyrinthine segment, and you can see dynamically that is the first genu. That is the horizontal segment. As I go down, that's the horizontal segment of the facial nerve here. And if I go down, you can follow with the second genu and then the vertical segment. This is best seen on a dynamic CT scan where you can relate three-dimensionally everything. Kapil, you asked me in the beginning, if patient is carrying a CT scan in hand, would you repeat? If the patient is carrying a printout, I will definitely ask for a repeat CT in digital format. But yes, if the patient is carrying already in a digital format, there is no point in repeating a CT scan, and the anatomy is not going to change. But we need a complete in-depth three-dimensional information of the anatomy, which can only be gained optimally by a digital information, a digital, data of the CT scan. Do you agree with me?
Yes, sir. Totally agree.
So this kind of, this dynamic information is required where every structure you can relate dynamically to each other. So this is the level of the CT scan. In as I said, in abnormalities of the semicircular canal commonly, and sometimes in the inner ear abnormalities like common cavity, in a cochlear hypoplasia, and sometimes in other abnormality, this facial nerve location may be abnormal, and one should be prepared to look at it by a preoperative CT scan and accordingly deal with it intraoperatively to prevent a damage to the facial nerve. So this is important to look at the CT scan, the anatomy of the facial nerve, the entire course, right from the labyrinthine segment to the labyrinthine segment here to the this is horizontal segment here, that is on the right side, that is second genu, and this is the facial nerve here at the vertical segment. Now, there are a lot of discussion about, looking at the facial nerve in view, as the commonest technique of the cochlear implantation is posterior tympanotomy. And people have described n number of ways to see the visibility of round window through the posterior tympanotomy, whether it is a favorable round window or not, because the anatomy of the round window, orientation of the cochlea is different in different individuals. There are a lot of, publication describing the orientation of the cochlea. Let me tell you what exactly we mean by the orientation. See, this is the sagittal plane, and if I make a line traversing the basal turn of the cochlea, the length of the basal turn of the cochlea here, see, exactly that is the angle we want to know. That a lot of people have described this angle. More the cochlea is obtuse, more the angle is narrow, both the ends give you difficulty in visualization of the round window. Difficulty. With experience, you can overcome easily all these difficulty, but this is important to, as far as the teaching is concerned, these are important discussions so that you can be more prepared in dealing with difficult or unfavorable round window. Unfavorable means, by and large, to be very precise, we want to see the round window through the posterior tympanotomy, through which we can, by round window or extended round window or whatever approach, we access the scala tympani of the cochlea, basal turn of the cochlea. Now, if the round window is unfavorable, it is not visible to the posterior tympanotomy, is a difficult task then how to approach the cochlea. One can get disoriented, or one may implant the the cochlear implant outside the cochlea somewhere, or misplace the implant into different locations. So in order to know the surgical difficulty, whether the round window will be favorable or not during surgery, the simplest way, there are hundreds of ways, you can see, and see, one of the ways you can easily see. Let me show you, take you back to the facial nerve. See, this is the facial nerve again, the horizontal segment of the facial nerve. And if I am going here following, see my cursor is following the facial nerve here in the vertical segment. That's the vertical segment of the facial nerve. Can you see this? Can somebody remove this? Boss? Dinesh ji?
Yes.
Yes. Yeah. See, this is the vertical segment of the facial nerve where my cursor is. I hope it is very clear.
Yeah.
So this dynamic CTs can take you directly to the structure which you want without disorienting you. That is another beauty of having the CT scan in a dynamic way. Now, this is the basal turn of the cochlea. In the long axis of the basal turn, you are supposed to implant. Now, how you are coming in the posterior tympanotomy? Suppose, let me tell you the angulations of this is the long axis of the basal turn of the cochlea where we need to implant. Okay. This is the facial nerve. In posterior tympanotomy, facial nerve is a medial anatomy. Posterior tympanotomy is a triangular space between the lateral canal, the extraordinary canal laterally, and which is demarcated at the medial end by the chorda tympani, and the facial nerve medially, that triangular space. Now, if I draw a parallel line through the anterior wall of the facial nerve, see this? My facial nerve, this line is the medial limit of my visualization, which I am looking from laterally here. And the second line, the anterior line of the visualization is the extraordinary canal. Look at the extraordinary canal here. If I draw another line parallel to the extraordinary canal, in the way I am going to see from behind. See this parallel line? See those two lines. Imagine surgically where you are doing a posterior tympanotomy, wherein my lateral limit or the anterior limit here is going to the chorda tympani demarcated by the medial end of the extraordinary canal. This is the medial end of the extraordinary canal here. And my medial line, my medial limit is going to be the facial nerve, which is the second line here. Through this visualization, through this, I need to seek into the long axis of the cochlea. If the long axis of the cochlea falls between these two lines, by and large, your round window is going to be visible through the posterior tympanotomy. Got my point or not? Agreed or not? There are hundreds of ways to, there are so many angulations, so many, formulas have been described by various people, making it more and more difficult for everybody to understand the accessibility of the round window, visualization of the round window or the favorable round window through the posterior tympanotomy. This is what we need to know practically between the line of the extraordinary canal and the facial nerve, the lateral part of the facial nerve. If through this axis laterally, I am going to see here from laterally between these two lines, if my long axis of the basal turn happens to fall between these two lines, my round window is going to be accessible. Kapil, any comment, or you look at it differently?
No, sir. We more or less use the same method of assessment. Basically, it's the cellularity and the thickness of mastoid bone between posterior canal wall and the vertical facial nerve. And
Yes.
You are very right. If your round window is seen within that triangle, then the access will be easy.
Absolutely. So this is one of the practical ways, I would say, to look at the round window. Now see, I can show you, if you see very carefully, let me enlarge where the chorda tympani is. See, to tell you everybody how to look at the chorda tympani. See this, follow the facial nerve. This is horizontal facial nerve. I am going down. This is vertical facial nerve, vertical facial nerve. Vertical facial nerve, vertical facial nerve. Can you see some nerve is joining here? Chorda tympani emerges from the lower part of the facial nerve just before the stylomastoid foramen. And see this nerve which is emerging. Can you see this? This small nerve where my cursor is going. I am following it up, following it up, following it up. Can you see this small nerve? Yes or not? Can you see this small nerve where my cursor is? Very small nerve. That is the
Yes,
chorda
we can see.
tympani. That is the chorda tympani, and where it is going? To the medial end of the extraordinary canal. See, this is your chorda tympani, this is your facial nerve, and in between is your long axis of the scala tympani or the basal turn of the cochlea. So that can tell you exactly. See, in the CT scan, I'm looking from laterally between my both limits, the facial nerve and the chorda tympani here, to the long axis of the basal turn of the cochlea. This is what we need to see intraoperatively in cochlear implantation. That is what my submission to look at, how to look at this, important aspect to see the feasibility of round window visualization. Now, coming after this, the another important thing, once you look at the cochlea, see this, the cochlear anatomy, we must know in all the three turns whether the cochlea is normal in terms of, morphological development. See the apical, middle, and the basal turn all together. Can you see? And this is the section, I would say, the mid-modular section you can see wherein all three turns of the cochlea are visible. And this is the modulus, and this is the cochlear aperture. See this. This is the intra-auditory meatus again. This is the intra-auditory meatus. And from here, the cochlea is, related to the lateral end of the, intra-auditory meatus. This little bright and ossified, this is porous bone that forms the modulus, and that is sitting at the cochlear aperture, closing this cochlear aperture. In situations where the cochlear aperture, the modulus is deficient, what you can imagine, what is going to happen simply is going to be a gusher. So gusher is totally attributed to the abnormal communication of the lateral end of the intra-auditory meatus to the cochlea. When the cochlear aperture is deficient, the cochlear aperture is widened. When the modulus is deficient, when there is through and through communication of the base of the cochlea with the intra-auditory meatus, the gusher is likely. No single case of gusher has been attributed so far to the abnormal cochlear aqueduct. That's a misbelief. It has been, studied as one of the potential source of, gusher in the cochlear implant surgery or stapes surgery, but the role of cochlear aqueduct is different altogether. We'll discuss in stapes surgery in detail, but we'll need to know where the cochlear aqueduct is and how important it is as far as the, gusher is important. So cochlear aqueduct has practically no role in contributing to the gusher. It is almost always the lateral end of the intra-auditory meatus, which is in abnormal communication with the cochlea because of deficiency at the base of the cochlea at the level of the modulus. When this deficiency is there, the cerebrospinal fluid is in direct contact with the cochlea and it flows freely. Once you open the cochlea at the round window of cochleostomy, and you're likely to get the gusher. And this you can preempt quite effectively by means of a CT scan if any of these abnormalities you may find. Sometimes we have seen in a couple of cases wherein there was direct abnormal communication of the cochlea with the intra-auditory meatus with modulus deficient, and yet there was no gusher because we can't pick up the membranous, limitation, the membrane which is separating the cochlea from the intra-auditory meatus, which cannot be picked up by a CT scan. So there could be one of the, fallacies you can see because the CT scan, MRI, whatever we are doing, are not going to give you the details of the, the membranous labyrinth at the cellular level. So this is important. This cochlear, see the base of this is cochlear aperture. You can measure with your software the size of the aperture. This should, if it is too big, then can lead to gusher. If it is too narrow, this looks like around 2 mm. If it is too narrow, less than 1.4, it is assumed that could be cochlear nerve hypoplasia or deficiency. There are many other ways to look at that, and the decision making is altogether different. That's a different field. I'm not going in detail, but this is one of the way we must look at the CT scan to rule out all those, possibilities of cochlear nerve hypoplasia or deficiency. So CT scan has to be, seen differently from cochlear implant. Now, the another important thing that the basal turn of the cochlea and immediate anterior structure to the basal turn. See here, what is this? That's the cochlea, that's the carotid artery. See, look at this. That the basal turn of the cochlea and immediately anterior to it is the carotid artery. That's the horizontal carotid artery. That is the vertical genu of the carotid artery, which is in millimetric distance from the cochlea. Sometimes this bone is deficient, and the literature supports, you will find from literature, some of the people have accidentally implanted the cochlear implant going from here directly into the carotid canal. Can be a disaster if you are unaware of it, or if it happens to damage, or while removing it, pulling it back and tear the carotid artery. All those, are different aspects. We need to be very careful. So this cochlear carotid partition, we must look at before every cochlear implant to see if any disaster which can happen. Another important thing, at the level of the round window. See, this is the level of this is the round window. This is the round window. That is the round window niche. See this, how thick the round window niche is we are going to get in this particular patient. We must be prepared to deal with a thick round window niche. Can you see here the thick round window niche? So these are important information we must know during CT scan. And at the level of the round window, if I go below, if I go below, now you see the jugular bulb. Sometimes the jugular bulb is too high, that too uncovered by the bone. See now, we have gone below the cochlea, no cochlea is seen, and now the jugular bulb is coming into the picture. As I go up, see now, as we see the cochlea, the jugular bulb has gone far off with a thick bone between this. So there is no risk of the jugular bulb injury or anything, or any challenge from the jugular bulb side to the cochlear implant surgeon. Another important thing we must see in coronal sections, there are a few things we must look at the coronal section regarding the facial recess, regarding the favorable facial recess of the favorable round window. First is, look at the vertical segment of the facial now. This is vertical segment of the facial now. See, this is lateral canal. This is the lateral end of the canal here. Lateral end of the canal here, and see the vertical segment of the facial nerve. So this vertical segment of the facial nerve is medial to the level of the canal. See that the lateral end of the lateral canal here, it is medial to it. Sometimes the facial nerve is too lateral to obscure the visualization of the round window. We must be very careful. And this was the classification initially proposed by Telmesani to see the difficulty in visualization of the round window. Second is this round window. That is the round window, the distance of the facial nerve to the round window. Again, see this. This is the facial nerve. Follow me. This is the facial nerve. This is the facial nerve. Here is the facial nerve where my cursor is, and see the distance from the round window. What is unfavorable round window? When the round window becomes too medial, when the round window, the facial nerve and the round window distance is less, the round window is posterior-medially directed close to the facial nerve, then the likelihood of the favorable round window is less. You can imagine, you can measure in terms of distance between the round window and facial nerve, whether it is a favorable or not favorable, unfavorable round window. So all these are important. See, for looking at the CT scan to give the optimum results of the cochlear implant, one must sit with the CT scan at least for half an hour to get the exact submillimetric three-dimensional information, which can complicate your cochlear implant surgery, which can have a significant impact on the overall implantation, surgical aspect, difficulties, or changing the surgical technique of the implantation. Next is the MRI, and I will quickly, our case is ready, and quickly come to the MRI. The sequence we look at the MRI almost always is the 3D CIS or the Fiesta sequence, or the heavily T2 weighted imaging, wherein you can see the fluid of the inner ear as a bright sequence. In heavily T2 weighted, see the CSF signal bright. Similarly, the fluid in the cochlea is bright. As I said in the beginning, for a cochlear implant candidate, one must have a fluid-filled cochlea. Look at the cochlea, completely bright, fluid-filled with the interscalar partition, very, very closely visible between the middle and the apical and the middle and the basal turn. You can see the interscalar participation with the scala tympani and the scala vestibuli, two different segments. The lower one is the scala tympani, the upper one in the vestibuli. Very, very clear on CT scan. That is the vestibular system, the vestibule and the lateral canal. That is endolymphatic sac and the duct. This is endolymphatic sac and duct. The lateral semicircular canal, vestibule, the basal turn, middle turn, and the apical turn, all full of fluid. This is the prerequisite for a cochlear implant to go. In situation like ossification, in situation like post-meningitis, post-traumatic, post-autosclerotic, there are many ways, many etiologies which can contribute to the, obliteration of the cochlea. And in complete obliteration, we know rules out the possibility of a successful implantation, though the surgical technique has advanced now with the advancement in the technique of the, the electrodes, wherein we can implant even the very, very difficult ossified cochlea to certain extent, not optimum, but to certain extent. Otherwise, the ABI is the final answer. And we all know why this is important to know. Even the worst result of the CI is better than the best result of the ABI. Even if we could push some electrode to stimulate, certain aspect of the hair cells in the cochlea, we can get better hearing and speech recognition, better than the best results of the ABI. Now, how to look at the various now? What we need to see from the MRI is an intact cochlear nerve. How to look at it? First of all, dynamically, you can see where the cochlear nerve. This is cochlea, this is modulus, and see from the modulus dynamically, this nerve is emerging. This nerve is emerging and going to the cochlea. This is cochlear nerve. This nerve behind is the vestibular nerve. That is vestibular nerve. See this behind, the fullness behind the vestibular nerve. This space behind the vestibular nerve is the Scarpa's ganglion. The vestibular nerve ganglion behind. You can see very clear. So this is vestibular nerve, very clear. And this is the cochlear nerve. And in order to see the dimension of the cochlear nerve, the best sequence is the sagittal one. How to reach the sagittal section? On the MRI, 3D, go to the sagittal, and in the sagittal view, see this is sagittal view. Now I will tell you how to look at dynamically. It's not the static image which is important. Oh, sorry. It is the dynamic image which is important to know whether the cochlear nerve is adequate in diameter. This is important to know because a hypoplastic cochlear nerve can have a significant negative impact on the overall outcome of the cochlear implant surgery. So here, this is our sagittal view. See this sagittal view I have seen here. Let me show you which is the cochlear nerve, which is the, see in sagittal view, you will see four nerves. Four nerves, the picture is not very great, but here you see that is the cochlea laterally. From here, the cochlear nerve is emerging. In sagittal plane, let me take a better picture of the sagittal view. Yes. Yes, this is a much better picture of the sagittal. Can you see the four dots? Four dots of the four nerves. This is the orientation of nerves in the intra-auditory meatus. Now, which is cochlear nerve, which is vestibular nerve? See this. See, this is cochlea, and this inferior nerve is the cochlear nerve. This inferior nerve is the cochlear nerve. This is anterior-inferior. The anterior-superior is the facial nerve. Posterior-superior is the superior vestibular, and posterior-inferior is inferior vestibular. By and large, how can you make out this is facial nerve? This is cochlear nerve. The dimension of the cochlear nerve is generally bigger than all these nerves, generally by and large. A hypoplastic cochlear nerve is defined if the dimension of this cochlear nerve is less than the dimension of the facial nerve, by and large. Many times you may not find the cochlear nerve separately, yet you can implant with guarded prognosis, and you can find the hearing as the cochlear nerve fibers may be traversing through other nerve. But by and large, if in this particular case, the cochlear nerve dimension is normal. If it is hypoplastic, then you have to take the help of other electric tests. You need to counsel the patient more and more to give a guarded prognosis that in case the cochlear nerve is not functioning, dehiscent, absent, hypoplastic, aplastic, whatever, you may have to change to a ABI, and that can be done intraoperatively as well. So the role of the MRI, by and large, is maximum to give you information about these two information, that is the fluid-filled cochlea and the intact cochlear nerve. Besides, the other sequence of the MRI can give you information about any other pathology in the brain, which can have an impact on the higher auditory functions. So that is another part. You can have a detailed information on the other sequences of the MRI. So our case is ready. Before we move on, anybody, any comment or any questions? Because this was simply how to look at CT scan and MRI from cochlear implant perspective, not getting other information for other surgeries or anything from the temporal bone. So Kapil, Samdani sir, or anybody, sir, please.
Can I add something?
Yes, please, sir.
When a request is made for the MRI, it should be written that preferably it should be 3 Tesla rather than 1.5 Tesla.
Yes, you can get a better information of the inner ear, interscalar partitions, better information of the initial changes into the cochlea from any other pathology. For example, let me give you, many a times we get post-meningitis patients. Early post-meningitis patient and an MRI is, phenomenal in picking up early fibrosis, early changes, which can turn into profound sensory hearing loss, which can turn into cochlear rehabilitation further. So those changes can be picked up by a 3 Tesla MRI with different sequences in a better way. Any slightest change in protein composition of the inner ear fluid should preempt you of the impending cochlear ossification in a post-meningitis situation. And the sequence we take into consideration for that is a 3D flare. In 3D flare, the cochlear fluid signal is dark, just opposite of the Fiesta sequence. In that situation, if you see any slightest change in protein concentration in the cochlea in post-meningitis situation, you can imagine the cochlear ossification is likely. That is very highly likelihood of cochlear ossification. And that is the time to take a call of implanting. If that is the implant is not possible for the patient affording so many things, you can at least stand the cochlea with a a dummy implant to keep the lumen intact for the future. So the MRI sequences are very important. Timing of MRI is very important. What sequences can give you best information in the earliest changes are most important, and that you can pick up in that scenario is by a 3D Fiesta. So your point is valid. A 3 Tesla MRI is more informative than a 1.5 Tesla MRI, definitely.
Jaipur team has been instrumental in bringing out a lot of literature on malformations on radiology. Recently, I saw a book also coming from SMS Monish Group.
Yes.
So it's indeed a proud moment for all there, and very comprehensively discussed, Satish sir. It was very enlightening. I think all aspects were covered in radiology discussion.
May not be all, but yes, important aspect I tried to bring forward.
Almost all, I think.
Radiology is so
definitely
vast because people have worked a lot. This is technology. Technological advancement is much ahead than any advancement. A lot of people has brought in various ways to know the favorable situation of cochlear implantation, round window visibility, so many things, various angles. I am not denying those are important. Those are important, but those are very complex. But we must know all those situations because those can be helpful in difficult situations. So Kapil, we go ahead with the surgical part.
Yes, sir. Looking forward.
We have some online questions here. Yes, please. Yes.
Sir, I will keep asking the questions.
Yes, please.
There are a lot of questions already that we have. So one of the questions is by Dr. Ajay Panchal. Sir is asking, can you please throw light on how to counsel and to take consent in cochlear implant? How to counsel and take consent in cochlear implant? So
the consent is very important. Your question is valid. And our Cochlear Implant Group of India has brought out a very comprehensive consent pro forma for the cochlear implant surgery. Of course, it should be an informed consent. The consent is very important because this surgery is not always a straightforward surgery. The complications are not only intraoperative, but maybe post-operative, maybe delayed post-operative. Some patients even develop infection years after cochlear implant. That should be part of consent. And so this comprehensive consent is proposed by the Cochlear Implant Group of India. You can download from the website, and we must take that comprehensive informed consent from every patient before surgery. Kapil, any other special consent or pro forma from All India Institute?
No, sir. Follow the standard, same whatever aspects you have touched. Cochlear implant is if the standards are not followed accurately, it can be at times a bit unpredictable outcomes results. So I think checklist maintenance, what you have mentioned, is very important. So consent can be classified into two categories. One is the basic surgical aspect, where you take into consideration the surgical part, the mastoidectomy, your facial nerve, your main surgical risks, and thereafter the second aspect is your outcomes. For example, as we have seen that radiology was not well read, you have missed the cochlear aperture stenosis, or you have missed that nerve was not there, and patient is not able to hear. That can have some serious implications on surgeon's career. So all those things, they need to be taken into consideration. I would suggest you divide the consent into two. One would be the surgical aspect, and second would be the outcome aspect. All the patients who are falling in gray areas, as sir had discussed, that their general workup, their intelligent question, their pre-operative language and speech parameters, their age, and other things, they should be taken into considerations, because the parents' expectations should not be very unrealistic.
Yeah, that's very important. So the consent should be an informed consent and detailed, comprehensive one, because up to 2 to 3%, maybe more than that, patients subject some sort of problems with the implant, because there is nothing in 100% in science. You can assume the cause of sensorineural hearing loss from the cochlea. You are absolutely unaware of the behavior of the higher auditory system. Regarding the overall outcome of the implant, you can imagine, and by and large, we achieve the results, the best results, but still there is nothing 100%.
So this is one aspect we need to spend a lot of time on. Sometimes the parents will come to you that child does not perform very well in school. So your implant is maybe not necessarily going to improve on that performance. Maybe after putting implant, the child will not be standing first in class. So that things, they need to be very realistically explained to the parents on what you are going to do and what benefit you are going to achieve.
Yes, that is important. Yeah, are you getting the microscopic picture?
Yes, sir. Yes, we are getting.
So, as I said, Kapil, I'll be going by the traditional posterior tympanotomy route.
Yes, sir.
Many techniques have been proposed to implant with the every technique has its pros and cons, but this is the time-tested technique which we follow. So, first important thing is the incision.
So may I request the organizers, if they can put the questions that they have got in the chat, we can continue discussing them by the time sir goes on with surgery.
So what you can do, Tarun boss, can you ask Dinesh or somebody to send the link of questions to Kapil or Samnani sir? So my incision is a very simple incision, for that matter. Just a small incision, retroauricular incision, with little, superior curvature for our ease, you can say, little superior curvature, because I will create a well and do a lot of things to house the implant above. So this is the incision. This is incision. Incision has a lot of relevance in terms of the wound complications, in terms of vascular compromise and other things. This incision doesn't compromise anywhere vascularity to any flaps. This region is supplied by multiple vessels. From below is the the occipital artery, posterior auricular artery. Above, from anteriorly, is the the superficial temporal, middle temporal artery, and this incision doesn't, violate any big vessel coming in the way. So this is a very, very favorable incision we have been using for years. And then I'm going to the thickness of the superficial tissue. See this? Another important thing is we generally avoid, too much of cautery during this surgery, not even before the implantation. The reason is the cautery results in some sort of tissue loss. And in this surgery, one of the major determinant of the wound complication is too much use of cautery, too much tissue loss, which ultimately calls for a tension suture, which can give way and invite infection. So our aim in this surgery is our recommendation is to use less and less cautery.
That's very, 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 very relevant point, sir. I feel that in any otologic surgery, I think cautery use, especially monopolar cautery use, should be kept to bare minimum, only where it's absolutely required. It raises the temperature of tissues you touch with it to as high as 400-500 degrees, and it is bound to cause some degree of necrosis, and necrosis invites infections.
Yes.
In this operation, the infection is totally unacceptable. It's absolutely catastrophic if you get it.
Yes. And this technique of posterior tympanotomy is one of the ways to prevent the infection coming to this field, as we don't violate the extra-aortic canal with the field. And this is very important to keep in mind. This is the extra-aortic canal. You can see the glimpse of extra-aortic canal.
Yes, we can get an idea where it is. So it should be well inspected and palpated. The anterior limit, don't have to breach it. That's important.
In case somebody happens to breach it, immediately suture it.
Yeah, repair
That's the only
it.
way. So this way, minimum use of cautery, and I can see my anterior limit. Now, my implant is going to be housed here in the skull bone, and I need to protect the implant with some flap, musculoperiosteal flap. Now, for that flap, we need a separate incision and separate planning. What our proposition is not to make the incision lying over each other. Make sure that incision should not lie over each other. And that's what I'm doing here is the undermining of this posterior flap. More and more undermining, so that my flap incision for the musculoperiosteal flap will be at a different level. Let me show you. So making more and more space with a smaller incision with this undermining.
So this, would you make some comment about the thickness of the flap?
Yeah, the thickness should be adequate for that matter. This thickness is variable according to the age of the patient as well. It should not be too thick or too thin, I would say. Both are hazardous. Too thick a flap can interfere with the implant, performance of the magnet and all that. And too thin a flap can lead to implant exposure, the necrosis and implant exposure. So both are hazardous. So that is very important aspect, sir has pointed out. The flap thickness is very important, and that is important in extreme age groups, in younger children and infants, and in elderly patient. Both are different aspects. See, there's more and more undermining.
So Satish, yes, sir.
Yeah, practically the hairline should not be exposed. I mean, if you different manufacturers has given different thickness measurement, instruments, but generally the hairline should not be exposed.
Yes, sir. See now, my lower limit, I'm making a horizontal incision here to make my flaps. I will tell you how my incisions are not going to overlie each other. This is the lower one at the level of the mastoid tip. Then I will make a incision anteriorly on the cortex, mastoid cortex, anteriorly. Just anterior to that is the canal, without violating the canal. This is the anterior incision. I am making the superiorly based flap to cover my implant, so no incision will overlie the implant. That is our preferred incision. There are many ways to make the same incision. Many ways to make the same incision.
It's more of a posterior superior based, isn't it?
Yes. Away from the, little away from the ear, where my BTE processor will be there. So that is according to that.
So Satish was, you have got, I have got a link for questions, and you have got
Yes,
at least 50 greetings from all over the world. There are people who are wishing you from Pakistan, from Bangladesh, I can see, and from other parts of the world.
I am elated to
good
have Kapil Sikka moderating this session to bring in most important scenarios, questions, and difficulties and solutions for the everybody. So I'm
Thank
happy
you,
that
sir.
Kapil is here, and Kapil, with questions in your hand, I believe we'll have more and more interaction.
Thank you, sir. So I can read one question that is general for I think AOI office bearers. If Kaushal sir is there online.
Yes.
Someone is asking, is the registration fee for AOICON 23 in respect of AOI and non-AOI members same?
It is a usual policy to have a different cadre for the non-AOI member, Kapil.
Right, but
As
I think
usual
the
in
things
all
will be
conferences.
known as we approach the conference. They will be put on the website. I'm sure.
Yes. So at this platform, I request everyone to visit the website for all the details.
Yes.
Where the organizing team is requesting everyone to take the advantage of early bird registration for the upcoming AOICON 23, and you can visit the website, and there is some special discount the team has offered during this the next couple of days from this workshop to encourage
That's
more and more
Dr.
people coming
Daroj
to the
from
scientific event.
Yes, sir. That's Dr. Daroj from Solan. I think that answers your question, sir. They might be different. I think you can visit the website while you register, and the information will be put up there by the organizers.
So everybody,
sir,
this is a humble effort from the organizing committee to start or initiate such workshop to promote our AOICON 23, to invite people for registration. That workshop, the AOICON 23, will be a much magnanimous in terms of scientific activity, and here the entire team is inviting you to register for the AOICON 23 and make that conference like never before. So all are requested to go to the website and can do early registration for the benefit. Yes, Kapil.
Thank you, sir. So that's a very interesting and relevant question from Dr. Wahid from Peshawar. Satish sir, if you can take it, how do you check that hearing aid is not successful before embarking on CI? What parameters do you assess? How do you know that in this case hearing aid is not working?
Yes. So I told you in the beginning, one of the most important member of our team, or rather my CI program, our hospital CI program is headed by our audiologist.
Right.
So these patients require a lot of, audiological workup, lot of sessions with the parents involvement session to see the progress of the children with the hearing aid, lot of sessions by the audiologist to finally assess whether the hearing aid is working, whether the hearing aid is resulting in the speech, recognition, what is the overall progress of the hearing aid. So audiological criteria are different and defined by the audiologist, and those are more important.
Yes.
And our
so Dr. Wahid, yes.
Kapil, our audiologist Ranju Verma is going to join us soon.
Right. I think it would be good to have her more relevant comments. So Dr. Wahid, in our centers, few of our centers, we have got separate rehabilitationists. In most centers, the audiologists are sub-trained as rehabilitation specialists who are involved in pre-operative and post-operative speech therapy, language therapy, auditory verbal training, and other things. So they need to be involved. How much benefit in terms of auditory perception, how much benefit in terms of speech improvement, how much benefit in terms of language improvement the child has got with use of hearing aid. If that is not reaching the standard landmarks of what should be age appropriate, then the decision for implanting is made.
Yes, yes. So one more thing here I want to bring to your notice. Once this flap is ready, let me know. Let me tell you what flap I have raised. See this superiorly based flap
Yes,
raised
sir.
from the this mastoid cortex, and see this pocket I have made for the implant to go inside. Can you see this?
Yeah.
And this entire implant will be covered by this flap again, so
Right.
as to prevent exposure. Now, if I reposit my skin flaps, see this, my incision lines are not overlapping each other. Can you see?
Yes.
The skin incision line is falling here on the periosteum flap. See this?
Yes.
And these incision line for the musculoperiosteal flaps are away from the skin incision line. Can you see this?
Yes.
This is very, very important to prevent post-operative, wound complications.
Yeah.
See, one of the major, I would say, dreaded complication of the CI is the wound complication, infectious complications, and prevention of those complications. We need to, we should start thinking from the beginning, even from the pre-operative, workup point of view. We must immunize as per standard guidelines all patients before cochlear implant surgery for the required vaccinations like pneumococcal, H influenza, and other vaccination as per the CDC guidelines proposed by the cochlear implant group as well, and those have to be strictly followed by everyone to prevent post-operative infections to certain extent. Then intraoperatively, we must follow the good surgical technique, optimum surgical technique to prevent infection, as we have been discussing, the flap raising, incision, use of cautery. Everything is important in preventing post-operative wound complications.
And don't
Yes.
forget the sterilization, your hand washing, your OT hygiene, and other things. They are
Everything.
also very, very important and relevant. Very good points here, sir. One point that I would like to highlight, if you talk about failures, then the most common cause for failure of cochlear implant is infection. And yes, as you have highlighted, the finesse in surgical technique, finesse in the surgical hygiene, that's paramount.
And unfortunately, this infection can occur even years after the surgery, because this is a foreign body. There's a foreign body. Even a fault in the surgical technique, a lacuna in the surgical technique, can result into infection long after the surgery. If your implant is projecting unusually into the skin, if your, the skin flap, like Samdhani sir mentioned, is not adequately thick, there's so many reasons which can lead later on to the implant exposure. In your surgical technique, if your implant is not adequately fixed, can lead to implant migration, which can be a disaster. So the proper surgical technique is very, very important, even for the delayed complications after implantation. That's why each and every step is very, very important. What we are doing, this soft tissue part, the implant fixation later on, every step is important in order to prevent complications later on. Kapil.
Very, very true, sir. Very true.
Now,
so there are a few greetings from Peshawar, Pakistan. Greetings from Dr. Mubarak sir. Mubarak sir, very good morning from all of us to you also. And a very, I think we have answered Dr. Panchal's question on counseling and consent in cochlear implant surgery. Dr. Sanjeev Joshi from Abu Dhabi is also viewing his, sending his greetings and saying it's informative.
Sanjeev Joshi is from Jaipur only. Our dear friend, he is shifted to Abu Dhabi.
Yes, sir.
He's part of the team of this AOICON 2023, as he has been part of the Mahatma Gandhi Hospital earlier. The Tarun Oja boss, the entire Mahatma Gandhi team is organizing this conference. And Sanjeev, you have to spare some time to come to Jaipur.
Good afternoon, Sanjeev sir, and good to know you.
See now, Kapil, what I've been doing.
Yes.
That is very important. This is doing some undermining of the soft tissue behind. See this. What
Yes.
happens once we raise this flap and put like this? When it comes to final closure, the
Yeah.
tissue retracts.
So some
Tissue
undermining
retracts.
will facilitate that closure.
Yes, and if you know, if you don't do this undermining now and start this undermining later, can lead to oozing, bleeding, which requires cautery and use of cautery post implantation. We all know we try to avoid. We try to, something. Our message is to avoid use of cautery once the implant is in place. So this kind of mobilization of the soft tissue one can do in the beginning so as to prevent the tension suturing at the end of the surgery. This is very important. This doesn't take more than a minute, but this is so important because a tension suture can give way, can lead to implant exposure, can lead to infection and overall failure. A smallest mistake in this surgery can lead to a disaster. And see, we all know the cost involved in this surgery is important, significant. So taking care of each and every step is paramount for the patient benefit. See this, the amount of, see this amount of undermining I have done. Can you see? Hello?
Yes, sir.
See, this is without compromising anything. So this is important surgical step, undermining in the beginning of surgery to get a good post-operative closure. And here I can do more undermining anterosuperiorly. See this? The tissue is so lax. Without any tension, we'll be able to suture later on. Can you see this? So this is one of the very, very important aspect, I would say, from surgical technique to do this, though it's a very small step, but very useful at times. Okay. So this is our initial part of, exposure to do further bone work inside. Can you put a suture and give me the BT processor? One more thing I would like to show here to mark you. The patient is going to wear the BT processor like this. See this? Can you see? This is going to be a BT, okay, BT processor like this, and we don't want this to overlie our implant. They should not come over each other, overlap each other to give problems. So what we do, we will mark this. We will mark this so that our implant will be, placed behind that. We'll be using a cochlear nucleus implant. Can you see this? This is a mark which I want to make here so that my implant will not come anterior to it. Can I do? Okay. Till there. Well. I am going to make intentionally a crude mastectomy for the reasons I will tell you. So the aim is simply to access the deeper areas. So first, to have an idea of the limits, see, I am operating at the Mahatma Gandhi Hospital, Medical College, and this is one of the state-of-the-art setup here. All gadgets you can think of are available here. Not only in ENT but neurosurgery as well. The neurosurgery department was started and taken a lead forward way back by Dr. Pankaj Gupta. And now the department is much bigger, headed by B.S. Sharma sir, and they have all possible, equipment besides the ENT department here, as they use for the skull-based surgery. So this is amazing, and it's always a pleasure working here in Mahatma Gandhi. Now, see, this is a crude mastectomy I have done. Yes. Yeah. Can you see some landmarks here at this point of time? Hello? Hello?
Yes, sir. We are getting the
Let
image.
me show you the glimpse of certain landmarks. That is the editor. That is the dome of the lateral semicircular canal here. And you can see the glimpse of the incus. Can you see here?
Yes.
That is the posterior canal, which I have thinned out and will do more thinning of it to get a more head-on access to the posterior tympanotomy. So, posterior tympanotomy is the hallmark of this procedure. As far as the surgical details are concerned, one of the most important parts is the posterior tympanotomy. Why it is important? Because a good posterior tympanotomy will give access to the round window, at the same time executed protecting the facial nerve. So the most important determinant of the posterior tympanotomy is the facial nerve. Now, where can be the facial nerve? How can you have, what are the ways to find out and protect the facial nerve? The facial nerve, always in the mastoid, is protected by the incus. Incus protect the facial nerve like mother, always lateral to it. See, the incus has this long process covering the facial nerve, short process there covering the horizontal portion of the facial nerve. You can see the glimpse of the facial nerve there. So as long as you are in the plane of the incus, your facial nerve is always medial to it. You can see. This is the first landmark which we always take into consideration. Second is the lateral semicircular canal. At the level of the second genu, the facial nerve is almost always anteromedial to the level of the lateral semicircular canal. Taking these two things, why I am still using the cutting burr here, considering these two things, see this, I am running my drill parallel to the incus. As long as I am parallel to the incus, not going deeper to this, my facial nerve is pretty safe. Number one. Now, second thing, this posterior tympanotomy is a triangular space between the chorda tympani laterally and the facial nerve medially. So most important thing is to identify and preserve the facial nerve. Now see, at this point of view,
Satish, can I make a comment?
Yes, yes, sir, please. Always.
We at SMS have done more than 600 implants, and I would like to tell that the posterior thinning of the posterior canal wall is one of the important steps for better visualization around it.
Yes, sir. Yes, sir.
And many times with what we have seen, it's since it's teaching and training institutes. So many times there is a small bony defect created in the posterior canal wall while thinning it down. So it should be done under high magnification, and one should take care of not damaging the posterior canal wall or the annulus tympanicus, which has been the cause for retraction and polystrodoma formation, for which we had to revise procedures a couple of times.
Yes,
So
yes, that is very important.
Careful about thinning the posterior canal wall.
Very important point, sir. So this is important to protect the tympanomeatal flap and avoid too much of thinning of the posterior canal wall, which can give way. And many a time this has been described. People have, done this, and the electrode array came out to the posterior canal wall, exposed to the outside. See, I am using the diamond burr in this space. See, still I am parallel to the incus. See this? Normally we keep an incus bar. Can you see the glimpse of the facial now? Hello. Can you see the glimpse of the facial now there anteriorly?
Yes, we can see that.
Could be. Sir,
How useful you find facial nerve monitoring here?
in a regular situation, not really, but yes, in malformation can be extremely useful. Regular case, if you're a beginner, if you want to take, I don't deny.
I think it's important in case you have it and it's a teaching training institute where residents and the senior residents are also
always
part
good.
of it. Then it is
Right.
good to have it.
Right.
Good thing cannot be denied. Now, at this point, keeping sir's point, what Samdani sir has raised, and the previous question about, about difficulty in accessing the round window. First of all, in case somebody happens to damage the canal wall, we must reconstruct before the end of the surgery. Number one, one can damage canal wall, you can reconstruct with a cartilage, with a bone pate, cartilage, whatever.
I will take whole, I am whole going to. Yes, yes, yes. Okay. Yeah. No, no, no. I am a gentleman. Don't worry.
So what, Dinesh? One must be very careful in finding the facial nerve. See, there are many indirect ways people have been advocating the implant, that you go this line, that line, but the best way is first identify the facial nerve. If you identify the facial nerve, everything is safe. So the most important thing is to identify the facial nerve and then going ahead with the implant. Now I'm going to show you something. Changing my direction. See the glimpse of the nerves coming into picture if you see.
We can see the facial, and I think we can see the chorda also.
Yeah, that's why I'm first confirming.
Satish, any comment about the navigation system used in this area? Any experience or what's your review about that?
Not really. Publications are showing some different funny newer techniques, navigation, the robotic system, all those things. Maybe in future they may be useful. I don't deny, but by and large, not needed. Because this technique is all about identification of the facial nerve and carrying out a good posterior tympanotomy. That's it. Sometimes you get a very pneumatized cell in the facial recess that makes your aim very easy. Can you see this?
So we have followed a prominent posterior tympanotomy cell and entered the middle ear there.
Yeah, it was not very prominent, Matlab. It was not very prominent, rather I would say.
Right.
But sometimes, majority of the times in pneumatite situation, you get a prominent cell and then your life is much easier. See now, I am in the retrotympanum. Can you see this?
Yes.
Hello.
Yes,
But
yes, we can see.
I need to expose it more to give you all the landmarks here. I have not seen the round window yet. Let me open up this space much better to give you. Now, let me show you the glimpse of the round window as well. See the round window. Let me widen it. I told you the round window niche is very thick in this case, but I can see my round window there. Let me widen this to the limits. See my facial now behind is in my view. Can you see? See the glimpse of the round window, the niche is too. Let me narrow the aperture. I think. Now to bring you more and more orientation, what I will go little superiorly and show you something. Just for the sake of orientation. I have seen the round window niche. Pick the to show them. No. Oh. Hello. This is my round window niche. Can you see here?
Yes, sir.
Round window is concealed under the niche. I showed you CT scan. The round window niche is very thick. You remember? This is your round window area here, hidden under the niche, and uncovering that is very, very important. That is my cochlea. Let me widen it a little more to give you, orient you from all around. Yes, interesting. एक size बड़ी दे. Can you see this chorda tympani in the edge? Hello.
Yes, sir.
See, this is facial now. That is chorda.
Yes, sir.
Very clear.
Yes.
This is chorda. This is facial now. I'm trying to optimally widen the round window. This posterior tympanotomy.
When you do a posterior tympanotomy, there is a lot of fear of damaging the facial nerve and the fibrous annulus and all those things. So it's better to, apart from cadaveric dissection, you should start doing this posterior tympanotomy exercise in mastectomies before venturing into the directly cochlear implant cases. Because mastectomy number of cases are, huge, and you can start practicing posterior tympanotomy in those cases.
Yes, sir. That's a great idea from a practice point of view. By and large, posterior tympanotomy in a CS1 situation is much difficult than posterior tympanotomy in a cochlear implant where you get a virgin field. But yes, that is the best way to practice. Now, what I want to show superiorly, that is the tendon of stapedius. Just for your orientation, can you see?
Yes, sir. Yes.
See, this is the tendon of stapedius. Just for your orientation, everybody. Hello.
Yes, sir.
That's the tendon of stapedius. You can keep them in your superior limit in view. This is
Yes,
for
yes.
orientation as well. A lot of people use it post implant as to see the electrically evoked stapedial reflex as well.
Yes, sir.
You can see literally the under microscope the muscle contraction.
Yes, we have been doing it.
Sir. So now I'm improving more and more, visualization, lateral exposure of the posterior tympanotomy before going to the medial part. I have seen my round window niche. The moment I drill my round window niche, you'll be able to see the round window membrane as well. So first of all, see this overhang. Little bit the lateral most point I am removing to get more, depth inside. See that? This is important to get more head-on exposure. A simple thing, see, during demonstration, it brings more light inside. Can you see the sudden change in picture?
Yes, sir.
Now, give me the patla. सबसे पतला ये चल रहा है. This वाला. Now, I will increase the dimension again for the posterior tympanotomy before going to that. Once you are doing posterior tympanotomy, according to the situation, take the advantage of maximum widening. एक size बड़ा, एक size बड़ा. See these implant, cochlear implant bursts. We have a set of specific bursts, long tapered bursts. See how much light going inside now. Can you? Simply by reducing this canal wall thickness from behind. Simply. अरे यार बहुत बड़ा दे दिया, इससे छोटा देना. Round window has a thick niche which we need to thin out. ज़्यादा छोटे दिन क्या करते हैं? See what I am doing. बहुत बड़ी दे रहा है यार. Six size. This is anterior thinning of the facial nerve. Could you see?
Yeah, yes.
I am removing this bone anterior to the facial nerve to get more space and more space to work inside, visualize inside at the round window.
Yeah, it's important to, introduce the AOS forceps and the claw. And for that, you need a adequate space.
Yes. Yes.
Sir, any tips if recess is narrow?
Pardon?
If recess is narrow, sir, then any extra tip?
I told you, either transpose this canal wall anteriorly.
Yes, sir.
Go by alternate route or do a subtotal petrosectomy implantation.
Okay.
See, this is anterior thinning of the facial nerve.
Yes, sir.
I am removing more and more lateral bone to make my life easier inside. See the area. This is round window niche. See this thick niche. And I will thin out this niche. I knew from CT scan that my niche is too thick.
Yeah, yes.
For everybody, this is round window niche. See, this is round window niche, thick niche.
Yes, yes.
See, I am just elevating the mucosa from it and show you. See this niche. Now, let me reduce this niche slowly under vision. This especially I noted on CT scan that I am going to encounter a thick round window niche.
Many times when you are drilling the niche, you can tilt the head and see the glimpse of the round window to make sure that you are at the correct place.
Yes. Yes, sir. Patla de bhai. Ye patla de. Can you see the round window membrane coming into picture now?
Yeah. Correct.
Patli de bhai. Just glimpse of the round window membrane now. Can you see that?
Yeah.
Bluish round window membrane. See that? Yes or
Yes.
no?
Sir. Yes. Yes. Sir.
Yes, it's visible very well.
See how thick is the round window niche. See, there are a lot of controversies, discussion, always in the literature regarding round window cochleostomy, which area is better. First of all, this discussion doesn't exist which area is better to me. We must focus on our need, what we are supposed to do for the better implantation. For better implantation, our implant should go inside, creating or giving minimal intracochlear trauma. Now, once you implant through the round window, the most of the procedure is blind, that you have to push the implant inside, and inside are many delicate structures. Many delicate structures. Right angle will do, sir. So, our insertion should be such that it should give, though it is blind, it should give a minimal intracochlear trauma. And what we have proposed, we have done our hundreds of implants and almost propagated that concept, giving least intracranial trauma. And this we have confirmed in more than 50 temporal bone dissections we have done, wherein we drilled out the cochlea and see the inside cochlear structures in detail. See now the round window much better?
Yeah. Yes.
See now. Can you see the round window membrane?
Yes, sir.
The niche has been removed. See this?
Yeah.
We lost the signal, sir.
Hello.
Yes, sir.
Hello.
Yes, Satish, we can see.
Yes, sir.
Yeah.
Sir, what I want to propose here is, this is my round window. Can you see here?
Yeah.
And from here, inferiorly is the scala tympani. Okay?
Yes, sir.
In the roof of the scala tympani, this is outer wall, you can say. In the roof of the scala tympani is progressing like this, antero-inferiorly. Now, this is the inferior cavity, the round window inferiorly leading to this, where we want to push or implant to the scala tympani. This is the area. Now, anteriorly here, in the anterior wall, here is the modulus, around which this scala is. This is the modulus, and around that are the scala. So here in the lumen, you want to push the implant here.
Yes, sir.
Now, this is round window, you are going to push your implant in the scala tympani here. Now, anteriorly here is the modulus. Here is the outer wall of the cochlea. Now, from the modulus to outer wall, see here, from the modulus to outer wall is a bony projection, bony plate which is projecting towards the outer wall. This is outer wall.
Yes, sir.
From here, modulus to outer wall, this bony projection projects and ends here just before the outer wall. This is osseous spiral lamella. All the way in the cochlea, this is like this. Osseous spiral lamella, like in a spiral fashion, all around the modulus, it is extending from the modulus towards the outer wall. And here it is ending before the modulus. From here, a thin membrane connects this osseous spiral lamella to the outer wall. This is basilar membrane.
Yes, sir.
Now, here this is scala tympani, this is basilar membrane, which is limiting the scala tympani below and the scala vestibuli above. So this is scala tympani below the basilar membrane and the osseous spiral lamella like this.
Yes, sir.
From the end of the osseous spiral lamella, another membrane going up towards the outer wall, that is Reisner's membrane, enclosing this scala media. And this is scala vestibuli above. Again, I'll make the diagram, different diagram. See this. This is round window, the scala. From the modulus, this bone osseous spiral lamella is projecting. From here is the basilar membrane, this is Reisner's membrane, this is scala media, this is scala tympani where you want to implant, and above the scala vestibuli. And this is the modulus here in close communication with the scala tympani. This is modulus, all around in the scala tympani. Lower down, this lower floor is scala tympani, the above floor is scala vestibuli, separated by osseous spiral lamella. Then the basilar membrane, scala media, this is Reisner's membrane, this is scala vestibuli.
Yes, sir.
Now what happens? What happens? I hope you got what I'm trying to say.
Yes, yes.
In the scala media, on the basilar membrane is the organ of Corti. Outer hair cell, inner hair cell, and every layer, at the 2 and 3/4 ton, everywhere, this configuration is going on in continuity. And there are 35,000 organ of Corti cells in every cochlea. At different levels, like this, all around the cochlea. So if we consider one, this organ of Corti is the outer hair cells here, row of outer hair cell, pectoral membrane above, then inner hair cell, then the inner hair cell fiber goes towards through the osseous spiral lamella. Every single fiber passing through the osseous spiral lamella into the modulus. See, from here into the modulus, every single fiber is passing through the osseous spiral lamella, through this osseous spiral lamella. Try to understand. Through this osseous spiral lamella, every single fiber is passing into the modulus. This is modulus.
Yes, sir.
So this is how 35,000 fibers are configuring around the modulus. And this fiber, single hair, inner hair cell fiber, passing into the modulus and here into the modulus, in the periphery of the modulus, enter into the cell body. In the periphery, the cell body, that is spiral ganglion cell body. See, like this, everywhere. And the inner axon of the spiral ganglion, axon is the cochlear nerve fiber spiraling in the modulus to go finally into the intra-auditory canal and to the cochlear nucleus. Got my point? Hello?
Yes, sir. Yes, sir. Yes.
So the inner hair cell fiber passing through the osseous spiral lamella, then ending in the modulus, in the lateral wall of the modulus, in the spiral ganglion body. This in the laterally, all around in the periphery, the spiral ganglion body in the Rosenthal canal. That in the periphery and the modulus. And from there, the second order axon starts to go into the forming the cochlear nerve fiber. So why it is important? Why I am saying so? This implant, I need to pass into the scala tympani because that is closest to the spiral ganglion cell population.
Yeah.
In order to stimulate the spiral ganglion cell population more focused, more specific, the implant has to be in the scala tympani. Got my point?
Yes, sir. Yes,
With
sir.
minimal, with minimal current. Now, if your implant doesn't go in the same trajectory, what is going to happen? If your implant go anteriorly like this, if my round window is like this, scala tympani is this, modulus is here. If I don't pass my implant into this trajectory, if my round window is antero-posterior and pass my implant into it will directly hit the modulus. It will directly hit the modulus and curl in the scala tympani. Once it curl in the scala tympani, it can damage the delicate basilar membrane, it can damage the osseous spiral lamella and ultimately go into the scala vestibuli with maximum intracochlear trauma. More the intracochlear trauma, more you are inviting fibrosis, ossification, and everything detrimental to the outcome of the implant. More you implant in the scala vestibuli, if you blindly push the implant into the, suppose this is round window and I am blindly pushing the implant in the round window, it may hit the modulus and go implant anywhere like this, hitting everywhere, and that is not the optimum function of the implant. It will rather damage everything inside, damage the spiral ganglion cell population. Imagine this is modulus, my implant entering through the round window, going around the modulus like this, closest to the spiral ganglion population, staying in the scala tympani is the most optimum part of the cochlear implant surgery one can do. So, what can you expect from the surgeon? Not to go blindly, face the round window. Now, if I go through the round window, my implant is, if it is antero-posteriorly placed, like in this patient, if I pass through this round window, I will be directly hitting the modulus. So what I will do, I have to go in this trajectory. I will remove this bone inferior to the round window. Rather than pushing my implant here, if I remove this bone, my implant will go directly into the lumen, into the inferior scala, lumen of the scala tympani. I will open the full length of the scala tympani of the basal turn in the straight trajectory so that my implant will stay in the straight trajectory without hitting everywhere. This is the crux of the successful cochlear implant. Optimum stimulation of the cochlear implant once it goes in the straight trajectory into the scala tympani. If anything goes blind push, hitting everywhere to the walls, damaging the spiral ligament, damaging the basilar membrane, osseous spiral lamella, and implanting, damaging everywhere, implanting finally into the scala vestibuli or curled implant, tip over, fold over, whatever, is not the implant surgery. So what I want to say, before going in for the implant surgery, we must see round window first. Now see, let me tell you here what I have shown there. I hope you got what I'm trying to say.
Yeah, yes.
Say this. Now look at what I'm trying to say. Can you see the round window membrane?
Yes, yes, sir.
This is absolutely in antero-posterior direction. See that?
Yes, sir.
This is anteroposterior direction. Now, what happens? If I open this round window, push my implant, this will go and hit modulus first. If I remove this inferior bone, just adjacent to it, known as crista, I will have a trajectory like, see my suction tip like this. Implant going in the scala, long axis of the scala tympani. Under vision, I will push the implant in the long axis of the scala tympani, directing inferiorly rather than superiorly towards the osseous spiral lamella. And if you can do it, you can do, from our perspective, believe me, the least intracochlear damage. I will remove this inferior wall and push my implant directly into the lumen. I will show you I have seen couple of times shown that with the, silo endoscope, the entire lumen of the scala tympani, shown in the roof, you can see in our videos, shown in the roof, the osseous spiral lamella, shown in the roof laterally, the osseous spiral lamella, giving attachment to the basement membrane going to the outer wall. So basement membrane is attached here to the outer wall, here. So during this, drilling, we condemn the process, the name of cochleostomy. You're not supposed to go separate from the round window. You can be, deviated from your path of the scala tympani. Just remove the inferior wall. If you go inferiorly here, you can damage the basement membrane and the osseous spiral lamella. If you go in the medial wall, just at the anterior end of the round window attachment in the medial wall is the opening of the cochlear aqueduct and the inferior cochlear domain. So strictly in the sub-millimetric distance, you have to stay just inferiorly. Just extend this round window inferiorly and you will be in the straight tunnel into the scala tympani inferiorly, where exactly your implant should be. You can see through your silo endoscope where the modulus is, where the osseous spiral lamella is, where the basement membrane is, everything in front of you. So that is the understanding we must develop. Understanding we did this, understanding the anatomy of the cochlea, dissected more than 50 temporal bones to understand the variation, and ultimately this inferior extension of the round window gave us the right path into the scala tympani, and you can confirm post-operatively with the cone beam CT scan the exact location of your implant in the scala tympani without going here and there into the scala vestibuli, damaging everything, with the optimum implant in performance. See, one can push the implant inside and come out and will give some sort of stimulation, hearing stimulation, and patient may hear, but that is not optimum, hearing. In order to get the best implant, optimum results, you have to minimize the intracochlear trauma. So here, at this point of time, I will stop here and make the well for my implant, and then come back wide and adjust. Later on, I need to extend it inferiorly and push my implant inside, nothing else. So I am limited here for a moment. Meantime, I have to make a well for the implant. इधर भी डाल दें, नहीं मोटा, and give some small gauge piece. See, I am just covering this to prevent the bone dust going inside. This is gel foam only. This implant program in the Mahatma Gandhi Hospital, believe me, this is a philanthropic attitude of the chairman of the hospital, medical college, to have started this free cochlear implant program. This child is implanted absolutely free of cost from the medical college, and they intend to do more and more in the future as well to benefit these small children. And this is something we must appreciate the hospital management for this free implant scheme. Now, the next thing is to make the well for the implant. Now, I have already, marked these two inferior limits of the processor where I need to fix into the skull.
Okay.
Any question? Meantime, we can take questions. Hello.
Yes, sir.
Meantime, we can take questions, sir, until I make this well. रंजू को फोन कर एक रखेंगे. See now, give me the implant template. So we are going to use the nucleus implant. So the Cochlear company, and this is going to be the template for the, implant. You have seen our marks below. So I have to stay posterior superior to it. Anyhow, can you see this? Hello? बड़ा. Now this is important part for the implant to create a well for the implant to fix it. Some companies have a very slim implant, require less drilling. There are many other techniques also. Periosteal pocket technique is also very good. You don't need to drill all that. There are certain implants which need to be screwed only. Yes. See, the child is a small one, and you can imagine the less thickness of the skull in young children. We still believe in the traditional technique of implant fixation. There are many other techniques, the periosteal pocket and all that, but still we believe in this rigid fixation because implant migration is a disaster. वो दूसरा मुंह लेंगे फिर. So implant migration is a disaster. We must do, I will show you, we must do every possible effort to fix the implant properly to prevent the implant migration. Still I am using the cutting bar with a very light hand. मुझे diamond. I'm just leaving this island of the bone intact in the middle so as to avoid the, too much of direct contact with the dura. And that will adequately keep the implant will adequately keep this dura, this bone press.
Okay, sir.
Satish, can I pass a comment?
Yes, please, sir. Feel free, sir.
When you are creating a well and the bone thickness is not thick enough, then it is a good idea to, keep the island of bone as Satish has already done it,
Yes,
and
yes,
remove the bone all around to expose the dura so that it becomes compressible.
yes,
Because any amount of tension on the skin would lead to extrusion of the implant,
yes. So
thinning
it
of
should
the
not
skin
it
flap.
should not project high into the skin. You mean to say?
Yes,
See, this should not be projecting high into the skin to perforate it to give implant exposure. That is very, very important point sir has raised. So it should be pressed to the level of the bone flush. It should not be projecting ideally over the level of the bone, just to prevent it coming into the contact of the skin and final extrusion. Now I'll be making the drill holes. Sorry, cutting the area. Tie down hole. Cutting the area. We tie down holes here, tie down holes behind so as to fix the implant properly. And then immediately in the next 15 minutes, we'll be through with this case. Hopefully. The diamond there. So this is a very frustrating thing sometimes. यहाँ करना 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 David. So these are the tie down holes from the cutting there. Sorry. Now I'll make a tunnel to carry the cable from the implant to the inner ear. So this is all mechanical part of the surgery, you can say. I'm making this little bit of the, overhang, creating this overhang, which is sometimes very helpful in, tucking your implant cable.
Okay.
This is at times useful because you need to keep a longer cable as the size of the mastoid is going to grow in children. See, the overall development of the inner ear, middle ear is remains same. What is at the time of birth? It doesn't change. It is only the axon-artery canal, mastoid, and other parts of the temporal bone which grow. Even the mastoid do grow for almost 2 centimeters or so, and you need to have almost 3 centimeter cable, extra cable lodged in the mastoid to cope up with the growth of the mastoid so as it doesn't pull the implant out. This is one of the major factor otherwise in implant migration. When the mastoid grows, it can pull the cochlea, the electrode out of the cochlea. So this is all about the initial drilling, the creating the well for the implant. This is overhang I have created. This is the tunnel for the cable. This is posterior tympanotomy. And now, before going to the implant, I will collect certain things. Give me some bone dust first. Kariti, collect bone dust. Keep this bone dust. We collected some bone dust. Let little bit more. थोड़ा सा और दे दे bone dust. कम पड़ जाएगा. जरा. So this is what the bone dust I have collected initially. One minute. This will be important, I'll tell you, for the fixation of the cable at points. And now, one more thing, a little bit of the periosteum, which will be needed to seal the cochleostomy. Sealing of the cochleostomy or the inner ear opening into the cochlea is very, very important to segregate the inner ear space to prevent infection going into the inner ear in case infection develops outside. Periosteum is the ideal material.
Okay.
The same periosteum available in the field will be sufficient. And now finally, now going back to the area where we left, that is round window. So this was the mechanical part for the fixation of the implant and all those things have to be done. Important aspect. Now coming to the round window, how to enter into the scala, how to widen the inferior vena patli bar. Make sure that you don't go anteriorly, make sure you don't go medially. Just inferiorly extending the round window. See this. Come down. See my mark.
Yes.
This bone inferior to the round window. This is absolutely safe. Medially, if you go to the round window, infero-medially, you may damage the cochlear aqueduct or inferior cochlear vein. They are going very, very close to each other, directly medially. Anteriorly, if you go, you may damage the basement membrane.
Okay, sir.
Inferiorly, I am extending to enlarge the round window inferiorly.
Okay.
To create a straight tunnel. That's it. पानी मत डाल ज्यादा यार. See this, I am thinning this bone inferior to the round window.
Yes, sir. Yes.
So I will open up the straight trajectory into the scala tympani. Now give me the अरे यार छोटा देता ना. Removing this round window now.
Okay, sir.
Opening the round window and see this wide opening now.
Yes, sir.
Now let me tilt the microscope. See this wide opening?
Yes, sir.
And this is now the straight tunnel. Give me some steroid. I will just लंबा देता हूँ. See this. I will just flush with a little bit of the steroid. This is under high magnification. Can you see this tunnel which I have opened?
Yes, 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 sir.
Just inferior to the round window.
Yes, sir.
पतला वो दे दे accurate. See this?
Yes, yes.
Inferiorly, this entire tunnel. See the length of the tunnel completely.
Yes, sir.
In the medial wall, in the medial wall, in the center part of this tunnel is the modulus. What you see structure on the left side is the modulus.
Okay, sir.
That is the entire tunnel. See the depth of the tunnel. If
Superb,
my
sir.
implant goes, this is a straight tunnel, I would say.
Yes, yes, sir. Yes, sir.
थोड़ा drill करना है मेरे को. वो steroid दे. We introduce steroid whenever we open this.
Yes, sir.
Steroid is the only known thing which has, has been proven to be, Now see the straight tunnel.
Yes, yes, sir.
Right there.
Fantastic.
And this will, if I push my implant, this will go straight into the stellate. This is why it is opening into the scala tympani. Just see the direction of this tunnel.
Yes, yes, yes.
So we are in the straight lumen rather hitting than any wall. And this
Okay,
lumen is scala tympani. Okay. See that lumen?
yes, sir. Yes.
The medial wall of the lumen is the modulus.
Okay, sir.
The steroid. This way, my all intracochlear structure, including the osseospiral lamella and the basilar membrane, is above this.
Satish, do you mean to say by drilling this that you have removed the hook area or the crista part?
See this, the wide, straight trajectory. Yes, sir.
Do you mean to say that by drilling the inferior part like this would remove the hook area or the crista?
Yeah, that hook has been removed. Hook is the crista.
Yeah.
That the turn into the scala tympani area, that is the hook, which
So
was
would you call-
limiting our access to the scala tympani.
So would you call that as the extended round window or the modified
Yes, you
round
can
window
call
approach?
it, you can call it extended round window. But this is not cochleostomy. Cochleostomy is a separate opening where you may get lost.
Yeah,
You
yeah.
may go into a different cell. You may get lost. And this is purely inferiorly widening the round window. Now I will fix my implant. Now my electrode insertion will be a child's play. There is a straight tunnel,
Yes, sir.
supero-inferiorly directed towards the floor. Supero-inferiorly towards the floor, away from all intracochlear critical structure. Implant will stay all the way in the lumen.
Okay, sir.
That is the beauty of just little widening of the inferior tunnel. There is no discussion about the round window. If I get the same access with the favorable round window, I need not to remove the crista. It is not that we want to remove the crista. We want to get a straight tunnel rather than blindly pushing. Now, once I push my implant into it, it will go in the straight lumen. Implant enough. Lock. So that will make the implant insertion a child's play. Now, for fixation of the implant, we'll pass some thread first of all. Fixation thread to the section. Little cumbersome to make these holes and thread them, but believe me, this gives us so much of sense of security in terms of implant fixation, in terms of reducing the chances of implant migration.
Okay.
Done. Okay.
Other end. Section. Section. Well, so, other. Section. पता नहीं आता चौधरी उधर से डालो give him pass through this हाँ डालो उधर से डालो हाँ चलो दबाए yes चलो yes so now we have threaded the tie down holes for the implant
Yes.
fixation implant
Yes, sir.
plant. So the last part is fix the implant and pass into the skeleton tympani and fix it. The simplest part in the in the entire surgery, having made the straight trajectory to the skeleton tympani, the simplest part is going to be the implant insertion, which is go straight in the lumen without hitting here and there. So implant, see this in place. This is nylon, the traditional way of fixing it. Nylon can be dangerous if your tip of the nylon projects toward the skin, it can perforate. It can expose the implant. So you have to be careful with this fact. This nylon I'm inverting. Inverting this. Inverting this inside, see this? And pushing this with a surgery shell to invite some fibrosis over here.
Okay.
See now? So no free edge of the thread will come out in contact with the skin. Every single step is important. Now, another important thing is I'll make a separate tunnel for the ground electrode. Never use the same tunnel because there are reports wherein the ground electrode came in contact with the processor and the patient started perceiving pain on stimulation. So
Okay.
that may be a disaster sometime. It should be kept underneath the muscle so that separately. See that?
Yes.
So that's what they. Now the final part is implantation. This is a straight electrode array. Nucleus or many other companies have varieties of electrode arrays now. There's a range of electrode array according to the need
from the small to the large, to the compressed, to the half banded, to full banded, double, triple, so many variety of electrode arrays according to the need. Give me steroid. What's a steroid? Now, final part. area? Industrial area. बंद हो गए. See your straight tunnel.
Yes, sir.
Now, implant will be directed in the same fashion in which the tunnel is going, antero-inferiorly.
Yes, sir.
See my direction of the implant?
Yes, yes.
Supero-inferiorly directing into the floor.
Okay, sir. Yes, sir.
There's a very, very delicate movement wherein the hand sensation of blockage are important to perceive. See this?
Yes, yes.
Slowly, without resistance. It's just a child's play now. See the white mark?
Yes, yes.
That's it. So, another thing important in reducing the intracochlear trauma. See, first is this inferior extension of the round window. What my point?
Yes, sir.
That is the hallmark. You get a straight lumen. Your implant is in lumen. It is not hitting. Not hitting here and there to give any trauma. Number one.
Okay.
Second is your insertion depth. Slim implant, another important thing, then the insertion depth. See, the array I am using is not going to go more than 24 millimeter inside.
Okay, sir.
That is our last limit. You have to understand this fact from the, histopathological studies. This implant, this cochlea has a length of, this implant, the cochlea has a length of 30 to 35 millimeter. We know
Okay,
it.
sir.
And the spiral ganglion, the studies have proven, has a length of maximum 15 millimeter or so. Know what
Okay,
I'm trying to say? What I'm trying to say? You don't need to stimulate the entire cochlea. You don't need to push the implant in the entire cochlea.
Okay, sir.
Because your spiral ganglion, I told you I made a diagram of the spiral ganglion.
Yes, sir.
Bodies of the, hair cells. They extend from the basal cell in the modulus to up to 24 millimeter maximum.
Okay, sir.
Less than 24 millimeter. See, all the hair cell fibers, I will, let me put it and show you with the diagram. All the fibers from all the three turns, they project towards the base. Fibers from the basal turn radially project towards the base medially, middle turn towards the base, and the apical turn towards the base. So maximum, the length of the spiral ganglion is 15-16 millimeter. See what I'm trying to do.
Okay.
Bringing this periosteum around the implant. to seal this cochleostomy. Rukna. You know, whatever. So what I'm trying to say, this implant should not go beyond 24 millimeter or so in the narrow cochlea to damage the intracochlear structures.
Okay, sir.
If it is going up to 24 millimeter, that is more than enough.
Okay, sir.
See, my periosteum is stuck to it and brought him out. It is so simple without resistance. See that?
Yes, sir.
So in modern electrodes, they are having sometimes markers also available at this till this level you have to insert.
Yes, exactly. We have also a white mark, you see. See, all around that is the periosteum.
Yes, sir.
Loud enough. थोड़ा सा suggest gel form. Yeah, the periosteum is stuck. See that?
Correct.
Stuck all around to the bony margins, so that it will seal all around. So my goal was to bring the periosteum all around. This seal should be perfect. See this? Snugly fitting the periosteum. See this? This will not move at all now. So this sealing the periosteum is another important thing to prevent the implant migration, to prevent the infection ascending into it. This seal should be perfect, not adequate. It should be perfect to prevent future introduction of infection inside. See that? Gel form.
Yes, sir. Excellent.
Good afternoon, Satish boss. Mohnish here.
Hi dear, where were you?
Oh, sir, I'm in Kerala. I had another meeting out here to attend.
Oh,
Just
we were
got free
talking
and saw
about you,
the
man.
last part of your surgery and wonderful, sir. Maza aa gaya, sir.
But we were talking about your achievements.
Arey, nahi. We all are learning from you. So that's wonderful. And the way you inserted this was so elegant to watch. I was just wondering, how slow do you want to go inside the cochlea? Now, there are people right now, you must be saying that there are various studies which show that you should insert it over 1 minute, 2 minutes, which is very difficult for a human hand. So,
Yeah.
how
So
do you plan?
initially, this concept is important. You're right. This was developed. The idea was to push through a narrow opening inside.
Yeah.
Absolutely blind. You never know where the implant is going. What happens initially? You go through the round window, implant is hitting the modulus, start curling up. Once it curls up, hitting the basilar membrane, osseous spiral lamella, God only knows where it is going. So, to have a seal, it was advocated to push it very, very slowly so it doesn't curl, doesn't hit hard, and you get a feel of resistance. Now, widening of this, round window inferiorly, you have a straight opening right up to the 180 degree. You know your implant is going to go straight inferiorly. Once implant goes there under vision inferiorly, it is going to go in the scala all the way in the right direction. So it is the initial trajectory which matters most. If initially it is blind, you never know beyond your control where it is going to be. So that is most important, this inferior extension to prevent the intracochlear trauma, number one. Number two is the length of the implant insertion. The spiral ganglion, we have studied almost 30 articles over it. We did our dissection a lot many times in the lab. You are not supposed to go beyond 24 millimeter maximum. That is our maximum limit. And that will not compromise your stimulation of any, area of the implant.
Yeah, very
any
true.
area of the spiral ganglion population. Because the superior, apical and the upper middle turn spiral ganglion population are projecting inferiorly. You are never supposed to, push the implant right over to the apical segment, because you go beyond 24, the dimension of the scala is so some millimeter, and you are going to ultimately give more trauma than benefit. This has been proven. Not to go 24 is the bottom line now. From the recent literature, even recent so many studies, even there is no point. Yet it stimulates the entire spiral ganglion population. I'll come to it. I'll show a diagram. What I have done here is put a small bone dust to fix the implant at the facial recess level here, because it has been seen that this distance with the growth of the temporal bone, we know we are leaving this excess cable inside. With the growth of the mastoid, growth of the extraorbital canal, the cable is going to expand. But this distance from the round window to the facial recess remains stationary. This is not going to change. Taking that advantage, we are fixing it to prevent further, a step further to prevent migration. Implant migration to me is a disaster. So you have to do a proper fixation. You have to do a proper, by all means, wherever you can ensure a good fixation, you should do. And this is one of the ways. See that?
Yes, sir.
Anything, Monish, you want to add on to?
Brilliant, sir. I think it cannot be overemphasized about proper fixation. Wonderfully done. Veritas mein pura aisa gets struck. So I think very important, because later on if it migrates out, it's a very bad thing to have.
Yeah. The migration is a disaster. That's why fixation at the cochlear smooth, fixation at the facial recess. This traditional fixation by the, tied down holes rather than a periosteal. Though I know the periosteal technique is very good, but since this is giving us very good result, not a single case of migration, that's what we have seen. So don't want to change it, and it gives us amazingly good results. Now, what about the implant insertion, depth of the insertion? See, Ranju is here to do the NRT, which is important to give you a feel good that the implant is giving, electrical stimulation, and that stimulation is stimulating the, higher pathways, and you are getting the response. That is something really good, though it is not going to change our plan, as it was a normal cochlear smooth insertion. In any given case, whatever the NRT comes, we are not going to change it. Yes, radiology may be warranted if anything goes wrong in the NRT or something. So now give me the pen and paper. What I was telling, this is important. There is no point in pushing the implant deep into the cochlea. The reason is, see this. This is the level of the round window, suppose. Can you see this?
Yeah, we can.
Yes, sir.
See this? Now, this is your scala going like this. Your organ of corti here in the basilar membrane outside. Basilar membrane here outside, the organ of corti is 30 to 35 millimeter long. Got my point?
Okay, sir.
What you are stimulating here, medially here, the modulus, and in the lateral part of the modulus, spiral ganglion cells. See like that?
Yeah.
Our implant is at the medial end, close to the modulus. Now, here in the modulus, this spiral ganglion cell population extends not to 2 and 3/4 ton, just to 1.5 ton or 1 and 3/4 ton maximum. Like if you see the mid-volular section like this, this is apical ton.
Yes, sir.
This is modulus. Now these fibers from the modulus, from the spiral ganglion cell, come from the basal ton like this, toward the base, like this, from all circumference. Then from the middle ton, they converge inferiorly like this. See this?
Yes, sir.
Into the modulus. And from the apical ton, steep inferior conversion into the modulus. So if your implant goes 1.5 ton up to 420, 450 degree, it will cover up the entire population of the spiral ganglion cell without even going inside the apical ton, because all these apical ganglion cells are projecting down.
Yes.
So if your implant goes even up to 420 degree, 450 maximum, it will stimulate the entire spiral ganglion cell population without going right to the narrowest part of the scala to the apical ton.
Okay,
If you
sir.
push in the narrow scala, this is going to give more damage than the benefit. This has been proven, and this has been working very well. So our proposition now is not to implant beyond 24. And even in this 24, let me tell you, the entire spiral ganglion cell population stimulation is not possible with the traditional implants.
Okay,
See,
sir.
the hearing range frequency, this tonotopic organization of the spiral ganglion cell to be stimulated by particular frequency, for a human being, we hear from 20 hertz to 20,000 hertz. But all these implants are not going to stimulate 20 to 20,000 hertz. All these commercially available implants are stimulating from 75 hertz to 12,000 hertz maximum, 11,750, something like that. So implanting the entire scala is not going to give any benefit. Implanting even the entire length of the spiral ganglion is not going to be benefit. So initial 4 millimeters by and large from the round window is waste. It is not going to be implanted for that matter. Because that 4 millimeter constitutes from 20,000 to 12,000. No electrode is going to stimulate that range, those fibers. The only thing from 4 millimeter of the round window to the entire length of the spiral ganglion cell population is 16 millimeters. So 4 to 16 reduce 1 millimeter or so. We have only roughly 11 millimeter of the implant into the cochlea, 4 millimeter, starting 4 millimeter beyond the round window, is most useful practically, which is stimulated by all these commercial implants.
Okay, sir.
So it is a myth that you need to push the implant into the entire scala right up to the apical ton. There is no point in doing that. Only thing is those crucial 11 millimeter where there is maximum spiral ganglion cell population, stimulable population by implant is stimulable population. All those most basal spiral ganglion cells cannot be stimulated by any commercial implant. This is the implant is not giving us hearing of 16,000, 17,000, whatever hertz. It has a limited capacity to stimulate certain frequency range, and that representative area of that frequency is starting from 4 millimeter from round window to next 11 millimeter or so. So that is the most useful area, stimulable. The NRT is going on.
Yeah, beautiful NRT, sir.
Yes, sir, it is coming, and it was a smooth. I could see the basal turn in length, straight basal turn for almost 8 to 10 millimeters, and was inferiorly directed going along the floor. So I'm sure it is not going to go anywhere beyond the trajectory of the scala tympani. The goal is to prevent implant migration, damaging the modulus, basilar membrane, osseous spiral lamella, Reisner's membrane, going all the way in the scala vestibuli. That should be avoided, and that can be done by under vision guidance the implant into the straight trajectory of the scala tympani along the floor. So that is best possible by removing the inferior, edge of the round window, that part of the bone, and gives you straight action. The small thing can prevent maximum intracochlear trauma. That is our proposition, and implanting not beyond the 24 millimeters from the round window. That is maximum.
Okay, sir.
Monish, any suggestion? anything, any questions?
Sir, very well done, perfectly executed. We all enjoyed this particular surgery.
Thank you, Kapil.
Satish, it was an excellent demonstration as always, and it gives me, feeling of being proud teacher of you when you acknowledge your teacher at this platform. I would say that the student has beaten his teachers and he has become teacher of teachers now.
Correct, sir.
You're always our teacher, and we'll keep learning from you always.
Every time, sir, every time we get some new points, some new things.
Science is
Thank you, sir.
evolving, boss. To learn every time, science is evolving so fast.
Thank you, Samdani sir. It was pleasure co-moderating.
Hi, Kapil. How are you?
Good, sir.
Satish, when are you taking the Steppies case, by the way? Any idea?
Yes, sir. Hello? Yes, sir?
When are you going to take Steppies?
Yeah, after the FES case.
Okay.
So the next case we have taken,
Okay.
we have taken the next case is the case of nasal polyposis with some interesting anatomy. Our FES case is directed today with the aim of, exploring different anatomical difficulties pertaining to the frontal sinus. So the case one probably has some difficult frontobular cell, I think it is. Let me see the CT scan. The other case is a huge, even bigger than the frontal sinus, the huge intersinus septal cell. And then one more case has some different anatomy. So after this case, we'll be taking Stappies.
Okay. Thank you.
Thank you, sir, for being with us. Thank you, Kapil and Monish. So, you want to announce for the
Yes,
next
sir.
case? Yes.
Thank you, Dr. Thank you, Dr. Satish Jain, sir, for that wonderful demonstration of cochlear implant. I'm sure people in the audience have surely gained a lot of knowledge regarding cochlear implant. The next case I would like to, the sir will demonstrate is of patient Sashi, who's 30-year-old female and has complaint of nasal obstruction and complaint of hyposmia since 3 years. In this session, the moderators are Dr. Gautam Khan, who is the president, Indian Academy of Otolaryngology, Head and Neck Surgery. He's also the vice president in Association of Phonosurgeons of India, and also the chief consultant in Nightingale Hospital, Guwahati, and HOD of ENT department in Pratiksha Hospital, Guwahati. The second moderator is Dr. Pankaj Gupta, who is the professor in Department of Neurosurgery in Mahatma Gandhi Medical College, Jaipur. He's an eminent personality and one of the very well-known neurosurgeons of the country with a vast experience which spans over 25 years. And third is Dr. Devang Gupta, who's a senior associate professor in ENT department at BJ Medical College, Ahmedabad. He's also the present honorable secretary at AOI Ahmedabad branch. He has an experience of over 20 years and has special interest in rhinology and skull-based surgeries and has conducted various workshops and conferences for the same. Now, I would like to hand over to Dr. Satish Jain, sir, who will demonstrate the case of FES, which is the next case. Thank you.
He the patient, Shashi. Hello.
Hi. Hello, Dr. Jain. How are you?
Hello, sir. Fine, thank you.
It's always a pleasure watching you, and honor to be there participating with in your webinar and workshop. And the way things are moving, I think we'll have a great show in Jaipur in 2023.
Sir. Hello. Hello.
Yes, sir, we can hear you.
Is Dr. Gautam Khan online?
Yes, yes, I'm Dr. Khan speaking.
Hey, boss, how are you?
All well, sir. Enjoyed your first surgery. Always there's something to learn from you every time.
So nice to hear from you after such a long time.
Sure. So we are all looking forward for Jaipur next year.
I can see Dr. Sethi also online. Dr. Sethi from Singapore, or teacher Dr. Sethi. If I'm right, is he online? Hello. Hello, sir. Hello. Yeah. But is he online? So this next case, this patient has a nasal polyposis. I'm not going into the theoretical aspect of polyps. We have always discussed the indications and all that for surgery. But this is definitely, to mention, is an inflammatory disease. And the inflammatory load, which is not tackled by the medical treatment, requires a surgical exercise. Because most of the time it is a steroid dependent disease, and with nowadays with a full house fest, we make the space for the steroid delivery right into the depth of the sinus. Topical steroid penetration is improved, so the need of the oral steroid is diminished. That is the whole, strategy nowadays. So now the goal of surgery has changed. Goal of surgery is not just removal of the disease or the inflammatory load. Goal of the surgery, yes, of course, is to remove the inflammatory load, but giving the penetration of oral topical steroid deep into the sinuses. That is more important, so that need of the steroid is avoided. Oral steroid is avoided. Now, this particular patient, when we talk of sinus surgery, once the patient is, taken for surgery, once we talk of the surgical part, the most important thing with the radiology is to give us a complete 3D anatomical pathway, like a Google, map. And this is important in sinus surgery because the margin of safety is very less. These paranasal sinuses are surrounded all around by the orbit, skull base, and critical anatomical structures, even carotid artery, optic nerve, and various other things in the close vicinity, sometimes in some millimetric relationship from the sinuses. And see this disease, there is a complete whiteout occupying all sinuses with the distance to see this lamina papyrus is a thin bone separating from the orbit. The skull base, particularly in the anterior part, is very, very thin. Some millimetric thickness of the skull base separating from the intracranial space. So, the most important thing in carrying out a safe sinus surgery, a complete comprehensive work, requires a 3D information of the 3D, some millimetric anatomic information of the area where you are operating. Slightest, disorientation from the anatomy can lead to disaster. This is why the sinus surgery, understanding of the anatomy is very, very important.
And Dr. Satish, I think we can see that the enteroethmoidal artery is not flush to the skull base in this particular patient.
Enteroethmoidal artery here. See the anterior thyroid artery you are talking about?
Yes, sir. Yes, sir. So
See
for
the
a beginner, I think this is an important thing because it's not on the skull base.
Yes, it is little inferior to the skull base, hanging inferior to the skull base. It is more at risk rather than passing through the skull base. Your point is valid. So this surgery, I'm dedicating it to Dr. Sethi, who has been our teacher, who is the father figure of this surgery, who is the one who propagated all recent concepts of sinus surgery in our country. By his years and years of, hard work, propagating the concept to the each and every part of our country through number of workshops. And we learned a lot through his, teaching. So thank you very much, sir. Once again, we can never forget your contribution to the sinus surgery in our country. So coming to the anatomical details quickly, I am running the coronal section. Again, the CT scan was shot in axial section, and this is all reconstruction which is required. And see the size of section, 0.4 mm. Every movement, every time we move, we are moving by 0.4 mm. Imagine, we can't miss any small structure while, going through the scan. Now, the most important, I told you in the beginning, we purposely kept cases on request regarding the difficulty we face in the frontal sinus with variable anatomy in the frontal sinus. And this particular case, look at the frontal sinus. This is the frontal bone. I am going behind. See the two frontal sinuses. Can you see? This is the frontal beak, you can say. This is frontal beak. This is nasal bone anteriorly. Going behind is the frontal beak. This is the septum. And now see, still there is a beak. Still beak is intact. Can you see some cell in the left frontal sinus?
Yes, sir. Yes, we can.
Looking like an isolated cell, but this is not isolated cell. That is the beauty of dynamic CT scan. Otherwise, in a snapshot, one can think it is a type 4 frontal cell. For everybody, this is not type 4 frontal cell at all. There are variety of cells in relation to the frontal sinus, which complicates the frontal sinus, anatomy, frontal sinus work. Certain group of cells which are anterior to the frontal sinus drainage pathway, narrowing the frontal sinus drainage pathway from anteriorly. Those are the anterior cells like Aganese cell, Kuhn cell, frontal cells, type 1, 2, 3, 4, so many described. All those are anterior cells narrowing the frontal sinus drainage pathway from anteriorly, push the frontal sinus drainage pathway behind, narrowing from anteriorly, and the strategy for them is to go behind this cell and fracture them out anteriorly, as simple as that. Then there are group of cells which are behind the frontal sinus recess, drainage pathway. Why I am using this word drainage pathway? Because drainage pathway is composed of two things. The upper part is the frontal sinus ostium, bony ostium, and below is the frontal recess, which is not a canal or ostium, but which is decided, that is the pathway for drainage of the frontal secretions, decided by the surrounding anatomy. Anteriorly, Aganese, posteriorly, skull base, bulla, suprabullar cells, all these actually decide the drainage pathway, that is frontal recess. So above is the ostium, below is the recess, constitutes frontal sinus drainage pathway. So the cells which are behind the frontal recess narrow the frontal sinus pathway from behind are the suprabullar cells, frontobullar cells, supraorbital cells pneumatizing the above the orbit, and those cells are attached to the skull base behind. They are behind the skull frontal sinus drainage pathway, but behind them is the skull base. So you can't afford to go behind them and fracture them anteriorly. Knowing the fact that they are attached to the skull base, you cannot afford to go behind them to damage the skull base. So how to discriminate intraoperatively which cell is attached to where?
Here comes the role of CT scan, and that to a three-dimensional CT scan. Now, this cell looks like a type 4 cell. Believe me, it is not type 4 cell. I'll tell you the reasons why. If I go behind in the coronal plane, see this, go behind. The entire cell you can see like this occupying the frontal sinus recess pathway. See, this is the crista galli, this is the cribriform plate in view, and this cell is still behind, going more and more behind. So this is a posterior anatomy, what you can make out of this coronal section, not much more than that. It cannot be anything. To discriminate, exactly you need coronal section. See this cell. Now as I come anteriorly, this cell is disappearing. What does it mean? This cell is not attached anteriorly, as simple as that. At least you can make out this fact with the coronal section. Again, let me, for the junior colleagues, anteriorly there is no cell. As I go behind, the cell comes into the picture. See this cell, and far behind till this cell is extending. If I come from behind, you can see this cell where my cursor is. You can see this isolated cell in the frontal sinus. From behind we are coming, but as we come anteriorly, it disappears. That means this cell is attached behind. This cell belongs to the posterior group of cells. It's as simple as that. It cannot be frontal cell, it cannot be type 4 frontal cell, would have been attached anteriorly otherwise. So anteriorly is free, there is no cell. This is posteriorly based cell. And now let me reconstruct to 3 planes to see crystal clear the dimension of the cell and attachment of the cell. See this. Let me come to the coronal to pick up the same cell from the coronal. See this cell? Let me take my cursor into it. See this cell, where I am exactly. See this cell on the sagittal path. Now, let me see the sagittal sections now. Very clear now. Can you see this cell?
Yes, very nicely. Yeah.
Can you see where it is attached to?
Yes.
All the way attached to the skull base behind.
Exactly.
The coronal section cutting like this was showing isolated cell like type 4. This can be crystal clear differentiated. One and only section can do that. That is sagittal section. Can you see the clarity now?
Yes.
Now,
very clear.
Very clear. Now see, this is the agonizing cell below here.
Okay.
This is the frontobular cell. Can you see this?
Right.
The frontal bulla is here, and this is the cell, the suprabular cell, which is extending far beyond the level of the ostium. That is the level of the ostium. Far beyond the level of the ostium, high up into the frontal sinus. Can you see?
Yes.
Very clear?
Absolutely.
Attached to the posterior wall. So it is frontobular cell. Anybody, any doubts about the cellularity can ask this question. It should be crystal clear. The cell is attached to the skull base. Never ever attempt to go behind the cell, otherwise you will end up damaging the skull base. Had this been a type 1, 2, 3, 4 cell attached anteriorly, you would go definitely behind this and fracture this anteriorly. But here if you try to, would be a disaster. So this is a type 4, this is a frontobular cell extending high up into the frontal sinus, attached posteriorly, and see what it has given. It has narrowed the frontal sinus drainage pathway anteriorly. Can you see this? It has narrowed the drainage pathway so narrow. Can you see this? Hello?
Yes, we can see. Yeah.
See, it has narrowed the drainage pathway anteriorly.
Yes.
So now, coming from here, even with the 70 degree, we can see this. We will be able to see the anterior wall of this cell with the 70 degree.
Right.
Now, the goal is to completely remove this cell from here. If I come with the instrument from here with the 70 degree here, what is going to be the obstacle? This beak. So biggest obstacle in this patient in order to reach out this cell is going to be the beak.
So now
Right.
the alternatives to us, number one, let us remove the organ AG first. Look at the entire face of this cell. Open up this cell whether we are able to remove this complete septation intact without doing a draft.
Okay.
In the slightest difficulty if we face in removing this cell intact without drilling this bone beak, we will do a draft 2 immediately. There's a straightforward, treatment for this scenario. Is that clear?
Yes. Yes.
So that's an interesting situation of the frontobular cell. We are dealing with frontobular cell, which has narrowed the frontal drainage pathway and complicated this. I hope it is clear.
Yes. It's very
Now
clear.
the rest of the I am not going in details of the CT scans, but rest of the positive findings, let me tell you, will come one by one from anterior to posterior. Number one, this is a concha bullosa. Can you see this? The pneumatized middle turbinate with inflammatory, secretions into it. Maybe inflamed mucosa, maybe secretions, whatever. Can you see this?
Yeah.
So second thing we need to do is to deal with this concha bullosa. We have to do something to this concha bullosa to get space to enter into the ethmoids further. Can you see this?
Yes.
That is one. Secondly, all this white out. Septal deviation is there, need to be corrected. Then all this complete opacification of the cells. Then the Kiros is good average. I would say Kiros 2 here. The only important thing Dr. Gautam Khan has already pointed out, this, beaking of the orbit where the ethmoidal artery is coming into the roof of the ethmoid to pierce the lateral lamella here. See, this artery is a branch of ophthalmic artery given off in orbit, leaving the orbit along the skull base, then piercing this lateral lamella of the cribriform. This is medial lamella, this is lateral lamella. And this turbinate is attached to the junction of medial and lateral lamella. See here. So this artery perforating the lateral lamella here to enter the intracranial space. Now this artery is below the level of the skull base, so you have to be little careful not to damage this artery. This is more prominent, I would say, and you have to do everything to protect this artery from being damaged. Now this scenario of frontobular cell, see, until now the frontal sinus, now the frontal sinus is gone. What is this? Supraorbital cell. This pneumatizing above the orbit to certain distance. Supraorbital cell. Now the cribriform plate coming. And now the cribriform plate after the supraorbital cell is the anterethmoidal artery. So keep in mind this interesting anatomy. This is dangerous anatomy, I would say, wherein too much of pneumatization of the skull base has made this anterethmoidal artery, decent. After that, we'll go behind in the postethmoids. The important anatomy in the postethmoid is Onodi cell. See the Onodi cell.
Yeah. We can. Yes.
That is the sphenoid, this horizontal septation in the sphenoid. Now again, whenever you have a doubt of the Onodi, go to the sagittal section. If it is. See, the cell is projecting beyond the sphenoid anterior wall. Can you see this?
Yes, we can. Yeah.
That is Onodi situation. Not very dangerous, but this is Onodi. So this cell on the coronal you can see is the Onodi, and it is going beyond the anterior face of the sphenoid. In this situation, the optic nerve many a times comes to line the lateral wall of the Onodi rather than the sphenoid sinus. Rest anatomy we'll discuss later, but this is by and large the positive finding you can see in this particular case. The positive radiological finding. Ready? Any questions? Hello?
I can't see on this screen. Maybe.
Oh. Hello?
I cannot see on this screen, but maybe this on the other screen they can see.
Are you getting the CT scan on the screen or not?
No, I am on the Zoom link, so I'm not getting the questions from the audience. That's why. So can somebody from the volunteers look into that as well?
Of course. So can you send this link of questions to Dr. Gautam Khan?
Yes, I will.
यहीं पे ना वो अपना पंजा to Dr. Gautam Khan. Hello, boss. Hello.
Yes, sir. Yes, sir.
You are getting the link of questions. So whatever you find appropriate, you can raise.
I'm sorry, the link has not come to me. Anybody can help actually.
Boss,
Yeah.
check your WhatsApp for the link.
Yeah, I have checked my WhatsApp. I have got the link for the Ignite workshop and I have got the link for the Zoom meeting, but not the link for the
अजय को
pitch.
बोलना किधर है? वो सौरभ का है? आए जब मेरी बात कराना। नहीं आने दो।
Zoom link और Ignite workshop ये दोनों का ही link है. Questions, question answer का link.
Hello.
Yes, I'm on. Yeah. I have got the link for the workshop and the Zoom meet, the Zoom link, but not for the question answers.
हाँ नहीं चलो सौरभ से बात करा दो बढ़िया हटाना माइक
बंद
Hello, Dr. Satish. Yeah. Hello.
She couldn't let Malay.
Hello, Dr. Satish. Can you hear me?
Hello.
Hi, Satish.
Hello.
They are sending me the link. By the time I think you can get on, I will get, once I get the questions, I'll pass it on to you.
Okay.
Okay, sir.
So, boss, are you getting the picture?
I'm getting the picture very much. The picture of the CT scan is still visible, not the picture of the cell. Yes, now. Now we are switched.
No. How is the picture?
We have got the endoscopic picture, sir.
How is the endoscopic picture?
Very clear.
Okay. So this is the primary picture without any decongestion. And now my first part of the preparation, intraoperative preparation, has started with decongestion using this topical adrenaline in the marrow cell. My other part of the preparation.
Dr. Satish, while you are doing that, can
to
we
reduce the inflammation, to improve the surgical field, to reduce the overall bleeding. Because of this inflammatory condition, the mucosa is inflamed. Though we give preoperative treatment and all that to reduce the inflammation, edema, inflammation, infection, whatever, along with all these things makes the mucosa inflamed, vasodilatation, that all contributes to the bleeding. So the preparation, besides the preoperative preparation, this intraoperative preparation is very important.
In fact, there is a question in this regard from Dr. Amali Adeku from Otokpu. I don't know which country is that. The question is, what is the basis for pre-op steroids in FES in general and in this particular case when the disease is so extensive? From Amali Adeku. Sorry, the picture is frozen.
Inflammation to reduce the overall bleeding. And that works in the polypoid situation. There is no point in giving steroids in a non-polypoidal situations. In polypoidal, it works like magic to reduce the inflammation and overall bleeding. So that pre-operative preparation is very important. Similarly, the intraoperative preparation is important. And the part of the intraoperative preparation, what I am doing is topical decongestion. Other part of the intraoperative preparation, for that, I'm grateful to our anesthesiologist for giving us amazing surgical field with reduced cardiac output. The pulse rate is exactly 61. That is what we want. See, in this surgery, the major part of the bleeding is capillary. So in order to reduce the capillary bleeding, it is not pure arterial bleeding where you need hypotension and all that, very important. We can operate in normotensive conditions, but to reduce the capillary bleeding overall, we need to reduce the cardiac output. And for that, the best thing is to reduce the heart rate.
Satish boss.
Yes.
Dr. Devang Gupta from Ahmedabad.
Aji, क्या हाल है?
बस बढ़िया boss.
यार ये लग गया.
I had a question.
Yes, boss. Haji Devang, bolo.
Hello.
Yes, yes.
Hello. Boss, do your anesthetists give Arcamin or a beta blocker or alpha blocker to reduce the pulse rate preoperatively?
Here I don't know. Let me tell you, there are many ways to achieve the same thing.
Right.
Some people, like you said, use the clonidine, it's an alpha blocker. Some people use other beta blockers like short-acting esmolol, long-acting different ones. Some people use TIVA, total intravenous anesthesia. Some people use gaseous anesthesia. See, the goal overall is to reduce the bleeding, to reduce the cardiac output.
Yeah.
Of course, TIVA is best, no doubt about it. That prevents vasodilatation. But that can be achieved by various other means. And Here I am having super field from anesthesia side. The BP is 110 or so, and the pulse is 60. That is what I want. So the overall goal is to reduce the cardiac output, reduce the heart rate. See?
Yes, boss.
Only thing I am doing again and again is applying this topical adrenaline rather than injecting it. No point in injecting, you can achieve the same field with topical. And topical is pretty safe. You can prevent systemic dissemination as you don't inject anything inside.
Right.
Second thing, for the venous, improving the venous drainage to reduce the venous congestion, what all you can do is raise the head end of the table by 10 or 15 degrees, reverse Trendelenburg position.
Yes.
See now what I'm doing, using the micro debrider, under vision, keeping the cutting edges under vision, see this? And removing the polyps, visible polyps from the nasal cavity and the meatus.
The screen is
See,
frozen.
once I remove the polyps, I will get more space to identify more landmarks in a better way. Can you see this?
Dr.
No,
Satish,
sir.
the screen is frozen. It's not moving.
Screen is frozen, showing no debrider. It's not live, I suppose. No live. The screen is frozen.
Oh, what happened, Dinesh? Dinesh? सुन क्यों नहीं रहे? The telecast has stopped.
The picture is frozen. Now I think they're getting back.
Are you getting now?
Not yet, sir. Not yet.
Not yet. Come on.
We had the picture, then it got frozen actually at one point.
Hello. Sir, can you see that now?
No, not yet.
No.
Just 1 second, sir. There's some nut is
Okay.
there. We are just
Dinesh, you carry on with your correction. Meanwhile, Satish boss.
Yes.
Okay.
How long you give intranasal corticosteroids prior to surgery?
Depending upon the situation, sometimes there are so many other factors. So, but minimum 5 to 7 days. Minimum.
Intranasal, right?
No, oral steroid for polypoidal disease. Oral.
That's what I got. Yeah, got it.
For polypoidal disease, always short course of oral steroids. Non-polypoidal, nothing.
Nothing, yeah.
Satish, there is a question from Dr. Leena Jain from Nasik, not directly related to this case, but since we have got a little time, I thought I'll ask you, what is the treatment needed to be given in follow-up after surgery for a case of cystic fibrosis with bilateral nasal polyposis?
Yeah, cystic fibrosis is a different endotype of CRS.
Right.
It's a different, very, I would say, aggressive endotype of CRS. Chronic rhinosinusitis has different endotypes having different pathophysiology. And one of them is cystic fibrosis. So, nowadays is the time of precision medicines with different endotypes having different pathophysiology, requiring correction of different underlying pathomechanisms. So cystic fibrosis is because of a genetic defect in the CFTR gene, cystic fibrosis transmembrane receptor gene. And that leads to altered sodium channels leading to viscous secretions, and viscous secretions trapped in the sinuses leading to blockage of the mucociliary clearance and a vicious phenomena.
Yeah, we have got.
Hello?
Now we are getting the picture, boss.
Okay. So I was telling something about the cystic fibrosis. Did you get?
Yeah. Audio is clear. Video was a problem.
So that is a different pathophysiology involving the CFTR gene. That's a genetic defect leading to viscous secretions and giving a sort of, vicious phenomena where the sinuses are blocked, their mucociliary clearance is blocked and acquiring secondary infection. And most of the time it is Pseudomonas. So because of the ciliary activity hampered, which cannot be cured because it is a genetic defect.
Yes.
So the target is to treat symptomatically to improve the, sinus drainage. Though there are a lot of work is directed towards improving the genetic defect also. But the overall goal is to improve the mucociliary clearance of the sinuses, and that is mostly gravitational. The drugs are targeted towards thinning out the secretions. All this is to prevent the secondary infection which can lead to lung infection otherwise, and which is the principal cause of mortality in cystic fibrosis. Lung infection, many a times requiring lung transplant to save the child. So cystic fibrosis is a fatal disease, I would say, and that requires a different kind of surgery requiring gravitational drainage. That surgery requires gravitational drainage, and we do a sort of medial maxillectomies on both sides, wide, sort of draft procedures, complete ethmoidectomy, middle turbinate resection, whatever you can do to give gravitational drainage. Now, are you getting the picture?
Yes, sir. It's very nice.
Yeah. So see what we see after initial polyp debridement. We just debrided the polyp in the lumen. What I said, if you remember, during radiology, this patient has a concha bullosa. Can you see this concha?
Yeah.
See this middle turbinate full of polyps from inside. Can you see this?
Yes.
Right.
This concha bullosa blocking the entire drainage pathway. See this?
Yes,
and
boss.
this is completely thinned out, See this polyp inside?
Yeah.
This is pure concha bullosa obstructing the drainage pathway and complicating the things further. So in such situation, we need to remove at least lateral plate, or even more if required, we will do. So what I have done, I have opened up the concha. See, this is the inside of the concha. That is the lateral plate. You can see. Can you see this?
Yes, yes.
Variety of concha bullosa secretions situations one can come across, and you need to do different sorts of treatment to the concha according to the situations.
Boss, for the benefit of PGs,
yes.
One question, what should be the optimum speed of your debrider when you are away from the vital structures?
When you are away from?
Vital structures, what would be the desired optimum speed of debrider blade?
Depending upon the area where you are working, the control you require, the precision you require, all that depends. It's not hard and fast. But like concha I was removing, I was removing under a lesser speed for a better control. For polyps, you can use higher speeds.
Yeah.
Once you're working in the lumen away from the critical areas, you can use differently.
Yes. Maximum speed, probably.
That is the lateral plate of the concha I removed. And this is the medial plate of the turbinate. See this?
Yes, very well preserved.
Right. So that was the concha bullosa obstructing the area thoroughly. That's the part of the lateral plate is still here. See this? That is part of the concha only. This one.
Yes. Boss, is it true that we should preserve the middle turbinate, whatever thin plate of bone it is, as far as possible?
Not always. See, if the
particularly in the massive eosinophilic disease, wherein you require a long-term thorough irrigation deep into the sinuses. Many a time, looking at the situation, we may have to cut the middle turbinate partially, not complete. Middle turbinate removal never means complete removal.
Yes, partial.
It never means chopping.
What are those conditions, boss?
Yeah, but because sometimes it obstructs the drainage of the, penetration of the topical steroid deep into the sinuses, and many a time we reduce the turbinate.
Okay.
Sometimes it is floppy, you remove it partially. Idea is it should not pose problems.
Right.
If not posing problem, it should be respected. See now the field.
Okay. Yeah,
now we can see some better anatomy in the lateral wall, which was earlier not visible because of the concha. See?
Searching for maxillary sinus opening.
Yeah. This is uncinate process. This is the fontanelle behind.
Yeah.
That is uncinate process because uncinate is the mobile structure in the lateral wall.
Yeah.
Never get disoriented. Uncinate is a mobile structure. We must feel that first and then think of removal. Secondly, in massive polypoidal situation like this, concha and polyps can distort the anatomy. So be careful not to damage the surrounding structure because here the critical structures are in close vicinity. If disoriented, one can enter into the orbit easily at the beginning of the surgery. One can damage the nasolacrimal system. That should be avoided. See, every point of time I am using the saline adrenaline to improve my field.
Yes, boss.
This is the surgery of landmarks. At each and every point, we should be able to see our landmarks thoroughly.
Yeah. So there are various ways to remove uncinate process, right?
Yes.
Yeah. What are your preferred method?
Can you see the mobile uncinate? See this? Devang?
Yeah, we can. Very nice.
Can you see this
Yes,
mobile
sir.
uncinate?
Yes, sir. Very nice.
So your question, the various ways. Traditionally, people would take the sickle knife and remove the uncinate from the lateral wall like this.
Like this, yes, sir.
Yeah. See the uncinate is the upper part and the horizontal part going variably behind. But this way, many a time this is very close to the orbit.
Yeah.
If you go a little deep, one can enter into the orbit at the beginning of the surgery. And that can really affect your temperament. So best is to avoid that disaster. What best is? Take a reverse biting, engage into hiatus semilunaris inferioris, direct inferiorly and bite through the uncinate. See that?
Perfect.
Come anteriorly and bite through until the full thickness. Until you get the hard bone. See?
Yes.
See, I have broken this lower part of the uncinate now.
Yes.
To enter into the maxillary sinus.
Perfect.
And see now the role of the debrider. That's the part of the uncinate, which was little thicker.
Sir, here are you using the straight blood or rate 40?
40. See the part of the uncinate.
Yes.
This was the part
thin
of
bone. Yeah.
The part of the horizontal uncinate.
Yes.
See the maxillary sinus, glimpse of the maxillary sinus from inside.
Right.
See the polypoidal mucosa.
Within the sinus.
Yeah, I am looking at the pathology inside. You need to take a call of how much you need to widen it.
Yeah.
More the pathology, more the need of introducing topical therapy later, more the aggressive disease, more should be the size of the enterostomies.
Yeah.
As simple as that. Wash it. See that? So that you can monitor later on, the surveillance can be long-term maintained with the wide openings. You can introduce the topical therapy much better, more effectively. So according to the disease, if you have a minimal disease, you don't need to make a bigger opening, you know.
Yes, sir.
So this is my initial, you know, middle meatal enterostomy.
Boss, what should be the anterior limit of your sinus?
Anterior limit of maxillary sinus. Hello?
No. This enterostomy.
Yeah,
Enterostomy, boss.
Yeah, nasolacrimal duct.
Okay.
In any given situation, we are not supposed to traumatize. That is one of the disadvantages of using the reverse biting. You keep coming anteriorly without realizing that you are cutting through the nasolacrimal. You can damage that, and that's a major complication. So while using backbiting and coming anteriorly, you need to stop when you come across the hard bone. Okay? So this is the second part of the, you know, what we have done so far, middle meatal enterostomy. We'll see later on with the 70 degree.
Yeah.
Okay? So we have removed the polyps, we have reduced the concha, we have done a middle meatal enterostomy. The most critical part of the surgery I have already explained on CT scan, that is frontobular cell. That is a challenging scenario this patient's anatomy is giving us. See, I am going behind the upper part of the uncinate to fracture it out. See the thick uncinate.
Nice. Boss, by the way, does your marrow still contain adrenaline now?
Pardon?
Are you still using adrenaline in your marrow cell now?
Yeah, that you have to use throughout.
Okay. The same concentration.
Yeah, same concentration. See now what I am doing? I am removing this uncinate from the lateral wall to reach my lateral limit. Can you see the lateral limit now?
Yes.
That is the lamina papricia. See behind?
That's right. Yeah. Very nice.
This patient has a little thick bone, you know. See the lamina papricia very clear?
Yeah.
Yes, we can see.
So, you were asking, the Devang was asking why not to use the sickle knife. If you use the sickle knife, you never know how close your lateral wall to the uncinate. You see this, how close it is? See this lateral wall completely.
Yes, boss.
Reach to the lateral limit of your dissection immediately. The moment you remove the upper uncinate, you reach there. See that?
Yes.
Here, everything is distorted because of the concha bullosa.
Yeah. Boss.
Yeah.
So sometimes we see not much polypodal mucosa within the maxillary sinus, nor so normal. But there are some cobblestone appearance of mucosa, you know.
Yes,
so how to tackle that?
See, cobblestone mucosa is again the manifestation of the inflammatory load.
Yes.
Now, with adequate, you know, enterostomy and ensuring the adequate topical antibiotics, topical steroid later.
Yeah.
You are not supposed to be very aggressive.
Right. It is going to settle down.
Yes. If we are able to introduce the steroids, topical steroids in future effectively.
Okay.
Now see,
So,
see the cell, air cell.
agar.
Yeah. So in cobblestone mucosa, you have to stay. Otherwise, what you do, if you try to remove that, you end up, demucosalizing the sinus.
Yeah. Lead to more fibrous mucosa later on.
Yes, yes, yes. So that is going to give challenge later on.
Right. Right. So in endoscopic sinus surgery, one should know what to do and one should know what not to do, right?
Yes, yes, exactly. Now see, this patient, our target is to expose the front of the frontobular cell, the entire
Right.
surface of the frontobular cell thoroughly. So what I am doing here, I am removing this agar-Neji complex, agar-Neji middle turbinate complex anteriorly to give me head-on access. See this? See this? I am removing this.
Right. Yeah.
Yes, yes.
This will give us a good access, head-on access. Let me show you. But here we know the most difficult part is that frontobular cell. And to tackle that, we need to do everything. And one of the best strategy, see the lateral limit all the way. Once you see inferiorly, you can say superiorly as well. See the lateral limit there is lamina. See lateral limit superiorly. Now, let me show you some very, very interesting anatomy here, how to approach that. I will use 70 degree and show you something very, very interesting, how to approach that cell. See now, we have enough access to reach out to the frontal sinus now.
Yes, yes.
We have addressed the concha, we have addressed the
maxilla
or superior, I would say uncinate process, agar-Neji.
So, Satish, in this particular case, you won't feel like widening the posterior fontanelle.
Posterior. Yeah, I have already included in it. See, there's nothing beyond. A little bit is left. I can. You're right.
Cut.
See this?
Yes, yes.
Yes. So that is adequate widening of this. Now, coming to that with the 70 degree. Now, our target area is fully in front of us. Now, the $1 million question is where we'll be able to deal with it without draft or not. See that?
Hello. Hello.
Yes.
Satish.
Yes, boss.
Dr. Pankaj Gupta.
Yes, boss.
Satish, can you tell me, you are doing very wonderful with this micro debrider, and in case if our and other colleagues have micro debrider, what is your opinion? What is your advice?
If do not have micro debrider.
If you don't have any micro debrider, or in other words, when this micro debrider was not with you, how you are doing the surgery?
Oh, difficult. Then see, micro debrider is important tool for expediting your surgical part as well as mucosal sparing tool. If you do the same thing with other instrument, pulling the things again and again can result in, demucosalization. So microdebrider is one of the most important part of the, armamentarium. When you think of the quality sinus surgery, you cannot think without microdebrider. As simple as that. If you try to, it is like, see this, I'm going into the recess, removing this cell. It is like doing your surgery without microscope, ear surgery without microscope. Yes. One cannot justify doing a great work with microdebrider. Now see what I'm doing. I've opened this agar cell here. Now, I will show you the cell I have opened, how it is extending to. See this? See the path of the cell, how it is extending to.
Yeah.
See this cell?
Yes.
See this cell? This is. See this cell where it is going high up into the frontal sinus debrider.
Yes.
Let me show you how it was. I have fractured the cell partly. Hello?
Yes.
Hello? I have opened the interior wall of the cell. See, this is into the cell. Frontal sinus is anteriorly here. 120 there, let me tell you. See, this is the cell inside of the cell where I am showing. And frontal sinus is far anteriorly. Look up.
Yes.
See, this cell is attached to the posterior wall here. Can you see where my debrider is pointing?
Right.
And see the frontal sinus above. See the frontal sinus above.
Yes, beautiful. Yes, we can see.
Can you?
Yes.
This is the wall of the cell need to be removed. This wall is going up.
Right.
See this wall?
Yes.
If I am able to remove this wall thoroughly, I don't need to do a proper draft. See the dome of the cell. Can you see the dome of the cell above? This one.
Yes, we can see that. Yeah.
Dome of the cell. See this.
Which forceps are you using now?
Side giraffe. See this. See this?
Yes.
The part of the cell I am removing like this. See dome of the cell?
Right. We can.
See, that cell has to go. Can you see this cell wall? The frontal sinus is beyond. The frontal is there beyond, and this cell, yeah, it has come out. So I have been able to remove the dome of the upper part of the cell, which is most otherwise difficult. Force us to use do a draft procedure, which most likely now will not be required. In draft, otherwise I would have to drill this bone. See the interior of the sinus above.
Can you see?
Yes, very beautifully demonstrated. Very nice.
Now the cell wall inferiorly is still lying. Where it is? Section. Show me. Let me show you the inferior part of the cell wall. Here it is. This one. See the inferior part of the cell wall. This is the inferior part of the cell wall. This one.
Right.
This is the. See this inferior part of the cell wall. I am removing this one. See this?
Yes.
Completely coming out, and that will
Unmute
widen
kar
my. See that? And then you will see your anterothoidal artery behind. This is reverse blade, so-called adenoid blade. See, that is the ethmoidal artery. Can you see?
Yes.
And this is my reverse blade widening to the maximum.
Hello.
Now see the frontal sinus pathway.
Very nice and clear.
So I could, there is still some cell wall remaining here.
Medial boundary.
Sit बता आगे पीछे वाले. See the maximum widening of the frontal. See that to the limits.
Yes. Lower, medial, lateral, anterior.
Yes. See my limits of the frontal. Lateral limit you have seen already. This one.
Lamina.
Medial limit is your turbinate, which we have partially sacrificed.
Yes.
Right. Posterior limit is the skull base, and anterior limit is the this beak. Now suppose had I not been able to remove this cell, the top of the cell, the dome of the cell from below, because of the limitation in accessing and instrumentation, what I needed to do that simple. Take 0 degree, remove this mucosa, expose this bone forming the beak, and drill away from here to here. If you drill away, if I drill away this beak, I would be able to access this with 0 degree behind. Simple.
Right.
So only thing is either you are able to remove that cell from behind or be ready to do a draft. I hope it is very, very clear.
Crystal clear.
Now see, that is over there. Chota. Giraffe ke saath gel form. Now let me show you, shrink the mucosa inside the frontal to get details. This is decongesting the mucosa inside the frontal sinus. Because some edematous mucosa. See the frontal now.
Bit clear.
Much better?
Better.
So what we have done to achieve that, we have removed this middle turbinate agar complex here to get a 0 degree visualization of the frontal. Went with that 70 degree to remove the dome of the cell from above, which was arching high up beyond the ostium. We could see on CT scan. Remember? And this cell is out. Now we will be through with this case in 10 minutes. Our next case is going to be a most likely autosclerosis, a conductive hearing loss.
Right. See now the frontal part is clear. See the limits.
Yes.
Preserving the mucosa maximum possible. That is most important. Now see this polyp medial to the turbinate. Don't be so aggressive in damaging the. Just remove the superficial. Don't leave too much in raw areas. Can damage the olfactory area. See this all polyp. This is one of the indications of partial turbinectomy when you have too much of. You are asking when to remove the turbinate. One of the indications of partial turbinectomy is when you have massive mucosal disease medial to it. Because with such a turbinate there, your solution will not be able to make path for the to reach the target area medially. I will remove the part of the turbinate there. So my job with the 70 degree done, you can see. See that? We'll just train this patient in the particular position to douche, to irrigate the depth of the sinuses in particular positions. Sugar.
Your handling of the 70-degree scope is such a.
Pardon?
Your handling of the 70-degree scope is such a beautiful watch. It's not so easy in everybody's hands, actually, the way you do with the 70-degree.
You have to get used to. I don't think it is so difficult also. Yes, but that is
it's an art.
I would say a learning curve that you need to get used to. See this part of the floppy middle turbinate. Now definitely I am going to remove because there was a lot of polypoidal disease medial to it.
Right.
See now it will give access for my topical to reach everywhere. Can you see?
Yes.
In a much better way. Now the job left is straightforward. Job left is straightforward. I will not do much to this mucosa medially. I just shape the polyp. More you are aggressive there, more you are trying to damage the, I would say, olfaction. That's the posterior end of the middle turbinate having some vessel there. Now, the job left is posterior ethmoid and sphenoid, though it is most important. But now, not much of the work is left. Simple. So, frontal is great. Now, see with the 0 degree.
Yes.
See now what we have ensured are a topical solution reaching everywhere. See straight. That is what we have made sure of. Turbinate is not going to fall laterally. There is no obstruction, no inhibition. Nothing is limiting the secretions or the solutions reaching everywhere in the depth. Now, this is your ground lamella. Can you see? Hello? What I want to show here is the roof of the maxilla. Level of the roof of the maxilla. Can you see that?
Yes, we can. Right.
Floor of the orbit. That is maxillary line. See that? So now, quickly I will get into it. This is all disease. See the posthethmoids? Hello? That's the posthethmoids, but I will not take the straight trajectory. See
Yes.
this? If I keep going there, I can damage the optic now.
Yes.
What I will do, this is very important.
Sphenoid sinus. Yeah.
Yes. Go medially. The best landmark for the sphenoid is your nasal septum.
Yes.
Hugging the septum. One thing can save you from disaster sometime in life. Enter into the sphenoid only by hugging the septum. No. See this. I will remove this later. See, this is superior turbinate.
Yes.
This is part of the middle turbinate above. Superior turbinate. This is my septum. See, this is septum?
Yes. Yes. Close to the septum.
Yes, always. See this? That cavity is sphenoid. Can you see?
Yeah, very well.
Not to enter from laterally. See why I am not cauterizing this part of the septum, in spite of the little bit of the bleeding, because I am afraid I can damage the olfactory cells unnecessarily with more and more cauterization. Leave it, it will stop. I don't want to traumatize that much.
Yes.
See this? Now we are in the sphenoid. See that?
Yes.
Could be intersphenoid septa behind.
Satish boss.
Now I'll widen laterally. Yes, yes.
Yeah, for juniors, I would like to have a question. How much of superior turbinate you can sacrifice to open the sphenoid sinus properly?
Ideally, 1/3, lower 1/3.
Okay.
But not beyond lower half.
Yeah.
The reason being on the upper half of the superior turbinate medially,
olfactory
cells.
Yes.
So I'm just completing my job here.
Yes.
As you go along.
Some more skull-based cells here. That is your ethmoidal artery.
Yes.
See how useful the tool is.
Yes.
See, debrider, how useful the tool is.
Yes, sir.
You don't have to pull anything. Pankaj was asked just now if you do without debrider.
It was very difficult to do without debrider. We must have done a lot of cases.
But you know.
But now it's not advisable.
See, everywhere mucosa is intact. Can you see? No
Yes, sir.
stripping done. No stripping done everywhere.
Yes, yes.
No stripping done.
Bas, kahani khatam.
Satish, there is a comment from Dr. Fazili Wahid from Peshawar, the great surgical magic show, and he wants to know what tips are to be followed to avoid recurrence.
Recurrence. To avoid recurrence, we must reach to the pathophysiology of the disease thoroughly, because every CRS has a different endotype. We must know what endotype of CRS we are dealing with. We must get thorough investigations. For example, the various endotype of the CRS are AFRS, AERD, your cystic fibrosis, your eosinophilic rhinitis, sinusitis, your CCAD, allergic AD. So we need to get the thorough investigation to know what kind of disease it is. Number two, if it is polypoidal, definitely steroid has the main role. Do full house FAS and ensure preserving the mucosa. Wide openings wherever the massive disease is. See the sphenoid sinus. Wide openings wherever the massive disease is, and ensure the post-operative irrigation. If allergic, get the allergic testing done and whatever required immunotherapy or anything. If immunodeficient, correct the immunodeficiency. If AERD, do the aspirin desensitization.
So depending upon the cause, treat the pathology. Don't consider every CRS as the same disease.
Right.
CRS has various endotypes. Every endotype is a different pathophysiology.
Or there is a question from audience.
Yes.
What should be the optimum size of sphenoid sinus opening?
Nothing like optimum size.
Okay.
The size of the sphenoid sinus vary from patient to patient.
Okay. So what should be the landmark that you would be able to see with the 0 degree to say that the sphenoid is open properly?
So that's what I'm coming to it. I will show you.
Right, sir.
At the small Heller cell that was.
Yeah.
So in order to do an adequate sphenoidotomy, to ensure an adequate sphenoidotomy, first of all, go along the septum, flush it. And number 2, widen till the lateral wall. Give me the Kerrison. I'm coming to that point only. You asked before. See that? See the sphenoid sinus?
Yes.
This is the anterior wall. Now
Yes.
what I'm doing is widen adequately to flush with the lateral wall.
Right.
You can do with a Stamberger punch, you can do with a drill, you can
Kerrison.
do with a debrider, or you can do with a Kerrison. See this? Flush with the lateral wall. See, in full house fest, the tendency nowadays is more and more to do a full house, means complete job to avoid a revision surgery, at least the bone work. So that in case the patient doesn't follow the medical treatment or treatment required for the particular cause, pathophysiology, in future, no bone work is needed. Or you can give your patient indirect guarantee, even if you don't take a treatment. Sometime polyp develop, you can remove the polyps in the office without needing bone work. That's the intersinus septum.
Satish, there are 2 comments or other questions from Ashwini Kumar Verma from Nalanda. One comment is that traditionally ethmoids have been divided into anterior and posterior ethmoids, but in fact anterior ethmoids should be divided into anterior.
The question?
He has said that traditionally ethmoids have been divided into anterior and posterior. Ethmoids should be divided into anterior, inferior, and
Yeah. Can you repeat, boss? Can you repeat?
He has said that ethmoids have been divided into anterior and posterior ethmoids, but in fact the ethmoids should be divided into anterior inferior and posterior superior. He wants your opinion on that.
Yeah, traditionally divided into anterior and posterior ethmoids. Yes.
Yes.
And what is he asking? Next part?
It should be divided into anterior inferior and posterior superior.
Ethmoid cavity.
Yes, yes.
You can say the most of the, anterior ethmoids and posterior ethmoids are divided by the basal lamella. That is a very, very, I would say, physiological classification, because anterior ethmoid drains in different area and posterior ethmoid in different area.
Right.
That is not an anatomical division, that is a pure physiological division.
Right.
But my point?
Yes.
Now dividing into anterior, inferior, posterior, superior, I don't know the need of dividing into and the rationale behind that. Any scientific rationale is beyond the understanding. Why to divide? Who divides? Now give me 70 degree. See the whole panoramic view.
Dr. Satish?
Yes, madam.
Dr. Bharti, good work. And, when we see neo-osteogenesis in recurrent cases, what do you tell the patient about the outcome?
Neo-osteogenesis, right. First of all, is a massive disease.
Yeah.
Some can be good if treated properly, but the reason behind the osteogenesis is very important. Reason behind the neo-osteogenesis is leaving behind a lot of raw areas in a massive eosinophilic disease. Leaving behind the raw areas will invite fibrosis, neo-osteogenesis, because the underlying disease is there. The mucosal disease, the eosinophilic disease is there, and you leave a lot of raw areas to give rise to stimulate the neo-osteogenesis, to give rise to stimulate the osteitis, and that is the massive disease to treat with. In any given case, that has to be thoroughly, drilled off, given a wide, opening to the sinuses, and ensure topical irrigation, because the osteitis develops is basically depots of inflammatory cytokines. Like in frontal sinus, if neo-osteogenesis develops, you need to do a wide sinusotomies. Most of the time, draft procedures according to the need. Neo-osteogenesis is otherwise a very difficult disease to treat. It will again lead to fibrosis and blockage. So, remove the neo-osteogenesis, osteitis part, ensure the patency, and then ensure the topical steroid, irrigation, which can prevent further such thing happening. So that's a valid question. Neo-osteogenesis should be prevented by doing mucosal preserving work. That's the only way to prevent. Preserve the mucosa. If you remove the mucosa, the bare bone will invite everything. See the maxillary sinus?
Yeah.
Wide, we have enough drainage, access to the topical. See all the entire skull base, the frontal sinus up there. See there? The ethmoidal artery, the ethmoidal skull base behind, post-ethmoidal artery, the sphenoid sinus. So this is complete clearance of the disease with full access for the topicals now to reach everywhere. See now, when we discuss about the topicals to reach, we need to give this kind of a cavity. It should not obstruct our, topical reaching anywhere. That is the now important goal of sinus surgery.
Excellent, Satish boss. As usual, nothing to say much. But sir, I have a theoretical question for the postgraduates who are watching this live. So, like HeLR cell, hello?
Yes.
HeLR cell is a anti-ethmoidal group, right? Which pneumatizes the orbit.
Yes.
Floor
right,
of
sir?
Yeah.
Floor of the orbit, yeah. So likewise, there is an additional postethmoid group cell.
Yes.
Which pneumatizes the orbit flow. Have you encountered this kind of cell theoretically? What is the name? I have read somewhere.
Yeah.
Name I don't know.
Al-Hazar or Allah, I am not able to recognize.
Correct. It is there.
Bharti ma'am?
Yeah, it is there. I think one of my colleague, Dr. Nishan, and when he was working with Meghanath, they have done that one publication. Correct. What you said is
I read from there only.
Yeah.
Al-Hazar. Cell of Al-Hazar.
Yeah.
Okay. How often do you find this?
That's the final picture from this side. And I am leaving here to our colleague to finish on the other side. So Dr. Ajay will finish on the other side the rest of the work, and we will move on to the next case. That is probably autosclerosis.
Super, boss.
Very nice.
Thank you. We can take questions. Meantime.
Yeah, there is another.
Sir, the question is for The question is for everyone. Like, what is your routine post-operative protocol?
Hello.
What is your routine post-operative protocol in the term? Routine post-op protocol. Post-op protocol, like how many days you give antibiotic, how many days you give oral steroids, and then that dosing, Budesonide rescues dosing.
Yes.
So your question is valid. अरे बंद कर दो ना उसको यार, 10 बार बोलना पड़ता. Hello.
Yes, boss.
Yeah. So that depends upon the inflammatory profile of the patient.
Right.
How much the eosinophilia is. That's why some part of the mucosa should be sent for histopathology to know the mucosal eosinophilia. The serum eosinophilia, Ig level, immunodeficiency, the proper endotype of the disease. Like for example, different endotypes have different post-operative protocols. Too much of eosinophilia will dictate irrigations for long term. Allergy, associated allergy comorbidity will require allergic testing and immunotherapy. AERD will require, aspirin desensitization. AFRS will again require long-term steroid irrigation and, allergic testing and immunization. So, depending upon the profile, that's why the patient should be thoroughly investigated for the inflammatory profile. The post-operative treatment is directed. That's why. क्या नाम है नेक्स्ट पेशेंट का? इसका सीडी कहाँ है?
Tarun boss. Hello. Tarun जी है क्या? Tarun ओझा boss.
मैंने सीडी मांगी थी तब भी इसको.
Yes.
तरुण जी बहुत बढ़िया अरेंजमेंट किया है.
Yes, how are you?
आई एम फाइन सर. बहुत बढ़िया अरेंजमेंट किया है. बहुत बढ़िया. ऑडियो विजुअल, केस सिलेक्शन.
Thank you, thank you.
और मास्टर तो है ही सतीश बॉस.
Yes.
Satish, there is one more question from Nigeria from Dr. Amali. He wants to know, since you advised to avoid the use of cautery around the superior turbinate, how would you stop the usual using there?
Yeah, if it is not too much, we should avoid. If it is not too much, we should avoid. If it is otherwise bothering, like I did at couple of places, it was unavoidable. So you can use minimum.
Thank you, Satish. It was a pleasure watching you perform. And
again, I take pleasure to request you all to come to Jaipur for the AOICON 2023. Tarun boss is not leaving any stone unturned to make it grand success. Really grand. And his goal is to make this AOI like never before. So we request you to come in large numbers to Jaipur in February 2nd to 5th. We will be having hands-on courses before the conference. So today is the ignition. And a lot of things are coming in the future for the AOICON 2023.
Today is just a sample show, isn't it, Satish?
Yes, madam, you're right. This is what.
So when the sample is like this, you can imagine how the show will be. You and Dr. Tharun will be having for us good.
So under your guidance.
Oh, no. What is that?
See,
actually, I'm very much relaxed now.
We have the strongest AOI team.
That's there.
Very, very committed, and I hope the Rajasthan team will do their best to execute your plans.
Thank you, sir, for such a detailed description of the CT and surgical steps which are to be performed and how to avoid complications in FES. The next case is Pratibha, of 28-year-old female who has complained of decreased hearing in left ear, which is gradually progressive since 1 year. I would request the previous moderators to kindly continue giving their inputs for this session too. Also, I would like to introduce Dr. Markandeya Tiwari, who's an associate professor in Department of ENT in Goa Medical College, who is an eminent personality and has been giving constant input, and HOD, and who's been giving constant input in the workshop. Next, Dr. Ashwini Verma, who has a private ENT center in Bihar and has developed his own techniques of scarless retro helical endoral incision for ear surgery, and especially which is used in stapes surgery. Also, Dr. Sunil Samdani sir, who is a senior professor and former HOD of ENT department of SMS Hospital, Jaipur, and has an elaborate career spanning for over 27 years. And I would also like to welcome Dr. Surinder Singhal and Dr. Anil Suri. Now, Dr. Satish Jain sir will continue with explaining about the case of Pratibha.
So we have amazing people with us this time. Ashwini boss, hello. I remember him when we did our workshop in Bihar long back, years back. It was more than 10 years, I can say. And he was having each and every equipment you can think of, beyond imagination. Pentero microscope, every possible thing you can think of in ENT was there. Yes. He bought the laser in 2006, I think, luminous laser. Look at his dedication in, carrying out the high-end top work, never compromising. So the next case is a stapes, most likely. As you know, the patient is a female with a bilateral conductive hearing loss. And the next patient, I am just waiting for the CT scan to load. इसमें है ही नहीं, डेटा नहीं है इसमें. Hello. Hello.
Yes, we are there.
Yes, Satish.
Yeah, boss. I was trying to load the DVD of this patient. Probably some issues. So what I will do, I will take you through the CT scan of some other stapes patient to know what all to be seen on CT scan. That was a straightforward situation. This patient I remember, and the CD is not loading. The moment it loads, we'll come back to you again.
a straightforward situation. This patient I remember, and the CD is not loading. The moment it loads, we'll come back to you again. A straightforward situation. This patient I remember, and the CD is not loading. The moment it loads, we'll come back to you again.
Hello.
Hello.
Hello, Dr. Satish. Hello, I am Dr. Srini.
Yes, boss.
Actually, I got the link late.
Oh, welcome, welcome. So, what I was trying to say, the CD of that patient is not loading, so I am just going to take you through the CT scan of the other stapes patient after that.
Okay, first of all, thank you for clearing my doubts regarding ethmoids. Actually, I was thinking why it was divided. Basically, it has been divided physiologically. Thank you so much.
Rather was a difficult question. I couldn't. I really don't know what to say.
No, it was basically I am doing face now with 3D, so the things are entirely different with 3D.
Superb. So, are you getting the CT scan picture on the screen?
Yes, we are getting.
What I want to discuss here at what all to be seen on CT scan before stapes surgery. Why we need a CT scan? Most of the time it is straightforward and you can handle small bit problems, but why CT scan is needed? See, this surgery is one of the most, I would say, exciting surgery in otolaryngology where you can get results on the table.
Yes.
This is one of the surgery which is all or none in terms of giving results. You may get a dead ear also. Even a sub-millimetric, deviation from the norms can result into dead ear. So this requires a very diligent work from the surgeon side. And the role of the CT scan is to apprise you of any other different diagnosis, to apprise you of the difficulty you can encounter during surgery, so that you can prepare yourself to deal with that, or you can avoid operating and giving a hearing aid. Like for example, many a time this conductive loss could be because of some other regions, and on you exploring the middle ear, you find the ossicular chain is mobile and you have to cut a sorry figure. So in CT scan, what all need to be seen before stapes surgery? In morning, we saw the CT scan in relation to cochlear implant surgery. Now, we have to look at the CT scan from different perspective from stapes surgery. So the first most important thing, like we discussed in the morning, which is more relevant here, is the superior semicircular canal. It is one of the, I would say, not very uncommon, but yes, uncommon but important region for a misdiagnosis, that is third window phenomena, if you have a dehiscence in the superior semicircular canal. And how can you see? In the coronal picture, you run your superior semicircular canal. See, this is superior canal. This is vestibule. And run if there is any bone deficient above the superior canal. Here, not only the canal is intact, but there is cellularity above the canal also. There is usually pneumatized bone. So there is no dehiscence of the canal. Otherwise, in one of the situation of superior canal dehiscence, the bone above the superior canal is dehiscent and it acts as a third window. Third window means normally what happens? The sound coming to the stapes through the ossicular chain, preferentially going to the stapes goes in, the inner ear fluid moves, the round window comes out, and that baffle effect gives rise to action potential generation. That is hearing. Now, in that scenario, that energy is never lost between two windows. That's how the proper action potential is generated with the fluid movement in the inner ear. Now, if there is anything leaking from the inner ear labyrinth, besides these two places, is known as third window. So, whatever sound energy mobilizing the perilimb will be partly transmitted through the third window also, and will not be efficiently able to generate the action potential, and that will leave a sort of conductive hearing loss. In spite of an inner ear phenomena, will give a conductive hearing loss. That is third window lesion, and most commonly it is with the superior canal dehiscence. We must see the superior canal thoroughly. There could be another third window lesion, many third window lesions. Anywhere
the sound is leaking from the labyrinth. Besides these two windows is a third window. If there is cochlear carotid dehiscence is a third window. If there is enlarged vestibular duct is a third window. So anywhere dehiscence besides these two windows is a third window and can result in conductive hearing loss. And stapes surgery, you must be careful, because in this third window phenomena of superior canal dehiscence, the bone window is much better because of more sensitivity into the inner ear at the vestibulocochlear partition. Scala vestibula, scala tympani partition becomes more sensitive to the sound, bone conduction sound. So bone conduction sometimes goes in negative. Air conduction is hampered because of the third window, and it leads to a conductive hearing loss, particularly in low frequency, which can be falsely taken up by surgeon as otosclerosis, and exploration can take place. With a negative finding like exploration, then you get a sorry figure if you get a later on radiology a third window phenomena, that is superior canal dehiscence, and here the CT scan has importance. So, and secondly, why it is important? There are three windows. The step is, suppose there is associated otosclerosis also with the third window phenomena. The one of the window, that is stapes, is not moving. Two windows, the round window and the superior canal dehiscence, are working, and patient is asymptomatic from vestibular symptoms. The moment you make the third window, you make the fenestra and the stapes, patient will develop third window symptom, vestibular symptoms, severe vertigo and all those. The moment you do stapes surgery, the patient becomes symptomatic. So that can be a disaster. So we must know if there is any such a phenomena is happening. Then what you need from the stapes point of view, again, the possibility of gusher like we discussed in the cochlear implant, any widening of the intra-aortic canal, widening of the cochlear, aperture, enlarged vestibular aqueduct, all these inner ear malformation has to be ruled out. If there are any, abandon the stapes procedure, stop thinking about that and give a hearing aid. Then any misdiagnosis. We have seen in the practice many a time, ossicular chain fixed by other regions. Couple of cases we have seen where there is anterior fixation of the malleus by a anterior bony fixation. And in that scenario, you can pick up on the CT scan if there is any anterior bony fixation, and your diagnosis of otosclerosis is ruled out. Then you have to do a different procedure. Anterior malleolar ligament, if it is completely ossified, hyalinized, you can pick up on CT scan. If there is any superior fixation of the ossicle like stapes, the malleus, see this, malleus you can see in the coronal plane. We have seen couple of cases, the malleus fixation in the aortic, you can pick up by CT scan very easily, and then you need to do a different procedure going above in the aortic and, vaporizing that bony segment to release the malleus. So there could be different diagnoses which are mistaken as otosclerosis can be picked up. Then facial now. See this. In coronal picture, let me show you. See this. Normally what happens, this is ossicular chain. Incus, malleus, and then this stapes goes to the vestibule. This is vestibule, this is oval window, and just above the oval window, this is lateral canal. Here is the facial now. If the facial nerve is prolapsing, overhanging facial nerve, coming right over the stapes, can be easily picked up in coronal section as this opacity hanging down on the oval window, and you can certainly avoid the stapes surgery in those situations. Or with guarded prognosis, if you are experienced, you are able to deal with, you have to accordingly counsel the patient. So the facial nerve prolapse, something need to be seen on CT scan if it is. So all these things, if you don't know, but CT scan will give you surprise. So the role of CT scan is to prevent intraoperative surprises. We have seen couple of times, see this jugular bulb, it is quite low. If I come up at the level of the promontory, there is no jugular bulb. But sometimes we have seen the high jugular bulb, even coming above the level of the round window. And if you're not aware, you can damage it while elevating, even while elevating the flap. You must be aware of this anomaly. If there is any abnormality in the jugular bulb, coming high up, and you have to be accordingly prepare yourself or otherwise give a hearing aid. Persistent stapedial artery, though there is no direct evidence that you can pick up by the a CT scan, but indirectly if it passes through the facial canal. Give it a larger dimension of the facial canal. It passes through the stapedial crura to enter the facial now, and give the facial canal as little bulkier than normal. And secondly, if the stapedial artery is persistent, normally what happens in embryo, it is absorbed by the 10th week, and it is absorbed and runs through the foramen spinosum as a middle meningeal artery. It becomes part of the external carotid system. If it is persisting, this foramen spinosum is absent. This is foramen ovale, this is foramen spinosum. So in any case, if you find absent foramen spinosum with bulky facial canal, it gives you a suspicion of a persistent stapedial artery, and accordingly you have to take a call whether to operate or not, or if you have found where to go further or not. There are many decision-making factors we'll discuss later. So by and large, from autosclerosis point of view, you have to look at the CT scan differently, and all these fine points are important in decision-making to go ahead with surgery or not, to deal with difficult anatomy or not. And this will definitely prevent you from intraoperative surprises. So our policy nowadays, in such a clean-cut surgery where you can give best results as compared to any other otologic surgery, it is always better to get a CT scan done before rather than getting surprises. Yes, sir. Your viewpoint, your observation, your suggestion, any questions we can take before we move on, as the case is ready. I didn't know it. उसके बाद इधर लेंगे ना कुछ.
Hello. There is no audio coming.
Because in this third window phenomena of superior canal dehiscence, the bone window is much better because of proximity to the inner ear and vestibulocochlear partition. Partition.
सपना MRI हो गया ना उसका.
सर माइक्रोस्कोप है, इसमें हैंडलिंग में प्रॉब्लम आएगी. मैं दोनों बटन दबते हैं सर. ये
अच्छा दोनों.
मैं जब इशारा करता हूं
ये वही वाला है ना. हेलो.
Yes sir, video is not playing.
Yeah.
We have not started.
Satish,
Yes, madam.
when do you advise MRI, like any situations, MRI in autosclerosis?
Yes. Great question. You know, some patients, we advise MRI to two group of patients, you know.
Yeah.
To rule out any endolymphatic hydrop. The reason is, the aim is to rule out endolymphatic hydrop because many of the patients with autosclerosis, because of autosclerosis also, sometimes develop subclinical hydrops. And if you are not aware of it, opening the vestibule can result into membranous labyrinthine rupture because which is the saccule or whatever is dilated and can result into dead ear. And this has been observed. We always counsel our stapes patient that up to 0.5%, 1% patient may develop sensory neural hearing loss. Because there are certain regions which are beyond, you know, our capacity. And one of them is the subclinical hydrops. How to pick up that subclinical hydrops? These patients may not develop clinical vertigo or sometimes occasional vertigo which is not, you know, brought to the notice or remain absolutely asymptomatic. So in order to pick up those patients of subclinical hydrops, we can advocate MRI. Many patients were not even willing to, you know, take chance and ready to get MRI done. We can get them, tell them this MRI can give us more better picture of any hydrops going on. So the chances of, you know, sensory neural loss can be minimized. If at all, our surgery can worsen the situation, we can at least avoid it. And those who can afford, those who are more concerned, can be known. Secondly, those patients who have occasional history of vertigo, it is better to do that than giving a dead ear in case the hydrops is going on.
Yeah.
So I know the cost is a limiting factor, but it is very, very useful. So important than giving a dead ear. MRI can pick up the hydrops so easily. इसकी लाइट कम करो ना. अंदर अंदर ये नहीं ये ग्लेयर आ रही जो. हाँ अब ठीक है. हेलो.
Yes, sir.
Yes. Are you getting the microscopic picture, sir?
Yes, yes.
How is the picture there?
Nice, sir. Nice.
It's very clear, sir. Seen well.
Okay. So going to the surgical steps of stapedotomy, what we have been doing, I'll be using laser as well. We'll be coming to that at the point of use of the laser with the advantage and, you know, options. But the basic thing, most important thing from the beginning is the exposure. For a good stapes surgery, the exposure is, you know, imperative. A good exposure is very, very important. And what all you can do is, in the simplest way, our area of interest is the posterior superior area. We are not supposed to go into the every quadrant of, you know, mesotympanum. The area of interest is posterior superior. Sometime you may have to go anterior if you have situations like intramalleolar ligament fixation or so. So we design a flap where we leave an option to go anteriorly in case required. So in the simplest way for the junior colleagues, the flap incision, the flap should be adequate in length. It should not be too short or too big to be cumbersome to handle. See, this is the level of the annulus.
Yes, sir.
I am giving this incision roughly 6 millimeter or so lateral to annulus. That's a single horizontal incision. See that? In multiple goes, you know, never ever try to go in one go, as you may tear the flap.
Okay.
In multiple goes, deep down to the bone, ultimately going bang deep on the bone.
So this is my initial horizontal incision.
Okay, sir.
Yes. Now, just to bring it to center. Now this is inferior. Our area of interest is superior only. So to avoid the flap getting teared, what I'm doing, I'm making an inferior incision to limit my, inferior exposure to prevent the flap from getting torn by the elevation of the rest of the flap. So it's a sort of release incision, you can say, inferiorly.
Okay, sir.
So that we don't have to go beyond this inferiorly. See this?
Yes, sir.
This is a vertical release incision inferiorly. Only inferiorly. Superiorly will not give a release incision. Rather, we'll make it curvilinear to go as far anteriorly as possible.
Okay, sir.
This is the simplest version of a flap elevation. See, I didn't give any release incision superiorly. I can keep elevating as long as I want.
Okay, sir.
Slowly reaching the level of the annulus. You can see the annulus coming into picture. See the annulus?
Yes, yes.
Annulus. See that?
Yeah, yes.
And now I can incise the mucosa to enter into the middle ear. See, inferiorly up to the release incision, so I can replace my flap far anteriorly without any problem.
Okay.
There is some low current. Yes. Now, coming to the area of interest. Now our area of interest is superiorly, posterior superiorly, I would say. And at this point of time, you see the glimpse of the incus. Yeah.
Did you cut the chorda, sir?
Pardon?
Did you cut the chorda?
Not really. I have not seen the chorda yet.
Okay, okay.
I will show you. That was the mucosal tag only.
Okay.
Now see. You can see so easily the round window.
Yes.
Circular. See, that is the glimpse of the long process of the incus.
Yes.
Can you see the incus? Long process?
Yes, yes, yes.
sickle. I can see the glimpse of the chorda tympani now. Chota sickle diya gaya. See this, that is the chorda tympani.
Yes.
Hello, you were asking about the chorda.
Yes, sir. Yes, I got confused with the mucosal tag. Yes, the chorda is intact.
Yes. There are a lot of mucosal adhesions to the chorda. Chorda is sometimes the obstacle. You need to deal with it very, very gently. See, that is the bony overhang. You are just able to see the glimpse of the long process, not completely.
Yes.
Yes, yes.
You're okay. Now, give me the curate. Now, the idea is to remove this bone. Why we need the exposure? So that we should be able to see the whole window completely.
Yes.
And we should be able to manipulate our instrument, our piston in the whole window thoroughly. So we need a good exposure for that. See, this overhang can be removed by various ways. You can use a micro drill here.
Okay.
You can use a good curate also. You can use a micro mallet and the gouge as well. See, the chorda runs in the canal. You can see the glimpse of the head of the stapes now. Now important is to remove this overhang to get the ideal exposure. We should be able to see. Give me the micro drill. I can use the micro drill here. I hope the picture is good.
Yeah, yes. Good.
Very clear.
First most important part in this surgery is the exposure.
What's your take on endoscopic stapes?
Pardon?
Endoscopic stapes, sir. People are doing endoscopic stapes. What's your opinion?
Boss, I couldn't hear you properly. Hello?
Hello?
Yes, boss?
People are doing a stapes, endoscopic stapes surgery. What's your opinion regarding
Endoscopic surgery, endoscopic.
Endoscopic stapes?
Yeah, see, endoscopic stapes to me still is not appealing for the reasons. Lambi de na bar. Endoscopic stapes doesn't give you a binocular view to give you the depth perception as compared to what you get from the microscope. So endoscopic stapes is still not the standard of the care, I tell you. A lot of people are doing, publishing. Arey yaar, section band hai.
But in live workshop, I have never seen any surgeon putting the piston in single or single time or double, or they has to fight. They have to fight for introduction of the piston.
In endoscopic?
Yes, yes, yes.
Endoscopy was maybe having some advantage, but still there are.
But endoscope we can provide very good video quality. That is, and that it cannot be matched with our any microscopic video.
There are a lot of disadvantages with the endoscope. See, the proposed advantage of endoscope is with a wide angle endoscope, you don't need to drill much. The overhang, you get a good panoramic view inside. That is fine. But you don't get a binocular view.
So you can use the curate, you can use the micro drill, anything.
Are you using diamond or cutting, sir?
No, diamond.
You cut that.
Always diamond.
Only diamond.
Okay.
Where is cutting in this area?
No, curate the. यार वो अपने वाली नहीं है रोज की, बोल रहा हूँ तेरे को. Give me good curate, the regular one. ये भी नहीं है. शायद यार रेगुलर करते हो देना यार. See, this is very important part to deal with the overhang. Good. रोज करता हूँ उससे देना. You need a lot of overhang removal. I can see the glimpse of the tendon now.
Yes, sir.
पानी. And see, lot of thick canal wall bone. Can you see?
Yeah, yes.
The curate, this curate is not good, boss. पुरानी सी है वो. हो सकता है. So I am just looking for the good curate.
Use this.
Scissors. That one नहीं काट रहे. Yes, so this more overhang has to go. Could you see I'm seeing without speculum?
Yeah, yes.
So that more light goes inside. That's why. Just to show you better.
ऐसे लेके आती थी वो मक्खन। है ही नहीं हो, चमकती है ही नहीं इतनी हो, है ही नहीं हो। देख, गिव मी अदर क्यूरेट।
You're not using any speculum, sir. Is canal wide?
Yeah, I can use. I was using.
Now it's is the canal wide enough, sir? I mean, you're not using a speculum. So-
Yeah, I can use, no problem. Just doing without speculum.
Okay.
More light was going in because my movement was excessive. But my visualization should not go away. Just for the sake of
Yes,
demonstration.
yes. Okay.
There are many who prefer an endoral incision at this point. Are you in favor of that?
It's not about the endoral or anything. It's not the lateral, obstruction I'm facing. Endoral is not going to change anything. It is not the lateral obstruction. Lateral narrowing is not the problem. What is circular there? Section. मैंने तो मैं दूँ See some adhesions in the oval window?
Yes.
See, because of the adhesions, we are not able to see the footplate region. Lot of adhesions. Fine section. Quick. And now, see the glimpse of the footplate.
Yes, yes.
Yes. So I can see a nice view of the footplate. This is the stapedial tendon. What I believe is still a little bit of more of the overhang I want to remove. Can you see?
Yes.
Yes, sir. Seen, sir.
Little bit of the overhang. It is basically full canal is thick.
Yes.
Very thick overhang here.
See, I have to drill that much. Can you see much better picture now?
Yes, yes.
करना है डेमो क्या लिखता तू यार Now see the better picture of the oval window.
Yes, sir.
Yes, it's very cleanly seen, nicely seen.
Yeah, now we have a better exposure. The entire canal was overhanging.
So we had to drill completely. Now you can see even the posterior most part of the foot plate, even the pyramid you can see.
Yes, sir.
I hope everything clearly visible.
Yes,
Can you point out the pyramid, sir?
Pardon?
Please point out the pyramid.
Yes. The posterior part from where the tendon is emerging. See under high magnification.
Okay. Okay.
Let me show you. See where this tendon is emerging from. See this.
Yes, sir. Yes, sir. It's seen now. Yeah.
And you can see the entire foot plate. Now the next is to check the mobility. In order to check the mobility, see the difference after overhang removal.
Yes, sir.
Entire canal was overhanging. Now see what I'm trying to see. The malleus here anteriorly. See the malleus incus?
Yes. Yeah.
And when I mobilize the staples, the foot, look at the foot plate. It is not mobilizing.
Yes.
Correct.
No movement. Oh. So that is a joint. Joint came out. See? Already joint clear. See that?
Yes. Yes.
It was very flimsy. ये हटाइए ये फंस रहा है another mess. This is not good. That instrument is stucking. Yeah. See, there are two steps in this surgery which are critical. Critical in terms of giving complications. If you are not diligent, can give complication. One is corotomy, another is fenestration. During both the steps, a slightest mechanical trauma, slightest excessive mechanical trauma can give rise to disaster. Got my point? Like during corotomy, if the patient, if the foot plate mobilizes, it will definitely give some sort of sensorineural hearing loss, depending upon the mobilization and your luck. Similarly, during fenestration, if the foot plate gets mobilized, can lead to disaster. I told you, this is one of the surgeries which requires highest level of diligence. So in order to prevent this complication at these two steps, for these two steps only, our preferred equipment is the laser. I've been using this luminous laser since 2007. Amazing. It has changed the, changed the life, I would say, in stapes surgery. Now, no need of any mechanical movement at these two steps. Remember the psyche of the situation of the surgeon. You are doing corotomy and the foot plate gets mobilized.
Correct, sir.
You can't do anything but to stop. Sometimes the foot plate may bring out, foot plate may get fractured, and that is all disaster in a patient where is conductive hearing loss, where you can give a amazingly good result.
Yes,
but
sir.
To prevent that, because mechanically sometimes the foot plate is not adequately fixed. Your mechanical movement may not be absolutely correct. That complication happens to occur in up to 5% patients. If you are not having a laser or something, a mechanical movement can lead to mobilization.
Agree, sir.
So in order to prevent that, we are fixing the micro manipulator to the microscope. And we'll tell you how laser can, change the scenario. Can be so extremely useful. I have not cut the tendon. I can cut the tendon with the scissors. It doesn't make any difference.
Okay.
But I'll be using the laser as a rehearsal that it is working good.
Okay.
Focus, good, and not going anywhere else.
Hair gone.
Can you see the laser beam coming inside?
Yes, yes, yes. Sir.
Yes, sir. We can see the laser point.
So, see now what I'm doing? I'm doing a rehearsal by firing at the tendon.
Yes.
We'll vaporize it.
What the wattage you are using?
A minimal 8 watt. The size is 0.3 mm beam size. Ready?
Excellent, sir.
See how precise it is.
Yes, yes.
Now my next step, badao power, is to vaporize the posterior crust.
Yes, yes.
This is most important, one of the most important steps because this posterior crust is too stout.
Yes.
See, I'm keeping the tendon away, or the cauda away. कहाँ से जा रही है ब्लीडिंग यार? See the crust hollowed out.
Yes.
Give me the. It is the posterior crust which is a problem. Now I can easily fracture it. See that?
Yes, yes.
Anterior crust is almost always fragile, and you can easily fracture and remove it. See the stapedial arch coming out. Can you see?
Yes.
Yes, sir. Yeah, very nice.
So what we achieved without transmitting the mechanical movement at the level of the foot plate, we've got it vaporized. There cannot be any safe method than this. Now look at the foot plate.
Yes, sir.
Now the next step is fenestration, and before that we'll measure the required length of the piston. Some oozing from the inferior edge somewhere. Let me handle this. Touch karna. See this? This somewhere from the flap incision. See this? See some oozing. I didn't involve that snake. See somewhere from the flap incision. See that?
Yeah.
Yeah, yes, sir. Some canal wall, some smaller results.
Yes. इसको योग रखना छोटा दे यार ये तो गहरा है छोटा दे आदमी है छोटा दे यार So this is just a small adrenaline ball.
Sir, have you encountered sclerosis of the incudo-malleolar joint and the foot plate is fine?
Yeah, once we have found that, that's a congenital anomaly.
So what has your approach been in that, sir?
You know, we have found once fusion of the joint long back. So we encountered a gusher in that patient.
Oh, okay.
So after that, we got the CT scan done post-operatively. That was long back when we never used to get the CT scan done for every patient.
Okay.
After that, the CT scan done, and it turned out to be a direct communication at the cochlear base.
Oh, okay.
Had we
So
done
you
a
had to
CT
abandon the surgery in between.
Yeah. Had we done the CT scan before, we would never take. See now?
Yes, sir. Clearly
I
seen.
will check I will be using the titanium piston. So I will be using the measuring rod from the same company. It doesn't look like a big piston. It has its own, measuring system.
Yes.
See different grooves. 1, 2, 3, 4, 4 point. Let's fix at 4.25. You have to check at every, distance to know the appropriate length required.
Okay.
See this bar?
Picture center.
Center, please centralize the picture, sir.
This is the problem with microscope. This had happened with endoscope.
This is vario microscope. No, the microscope is good, but little, jumping. I will increase. See this?
Your earlier microscope, that sensor.
Now, can you see this?
Yes.
Yes.
This is corresponding to the middle of the thickness of the incus. Can you see?
Yes.
Yes.
This is 4.5. And this is a parameter, not the length, for that matter, from the company. That includes extra 0.3 millimeter, which is going to go inside the vestibule.
Okay.
So I'll be using a 4.5 size piston, not 4.5 mm, 4.5 size. Because what we use is a clipped titanium with its own advantages. Now the biggest question is where to make the fenestra. The safest area for the fenestra, the Hugo Fish had a lot of studies done on the temporal bone to see the
Sir, have you taken out the cotton ball before using the laser? Have you taken out the cotton ball?
No, the cotton ball is inferiorly placed. I will take out later. I am at the foot plate now.
Okay.
So this is a technique with this laser, again atraumatic. See this. I will be making, according to the Usofix observation we follow, the membranous labyrinthine structures are farthest from the foot plate in the central part inferiorly. And that is where we are going to make the fenestra. So membranous labyrinthine structures are farthest. Yes. See now?
Yes, sir.
Single shot, 20 watt. Yes, ready? Can you see the fenestra?
Yes.
See what a magic. Say this, what a discrete fenestra.
Yes, sir.
What a discrete fenestra without any mechanical movement at the level of the foot plate. Could you see?
Yes, sir.
That is the beauty.
See, during this fenestration, if your foot plate happens to get mobilized, you're gone. Definite sensory neural loss. And then you are not able to place the piston as well. A situation of conductive hearing loss can turn to a sensory neural loss easily. This laser is amazing because this is one of the most rewarding surgery. Can be a nightmare otherwise if the patient develops dead ear. See this?
Yes, yes, very
Yes, yes.
Now the last thing is to put a piston. See, everything is ready. Give me piston. And this piston is a beauty. Titanium, extremely biocompatible. The reason for using this piston is a clip piston which holds the incus tightly.
Okay, sir.
You don't need to manipulate like Teflon for crimping. Crimping is hazardous sometimes. Not only hazardous. Under crimping, a loose piston can erode the incus.
Yes, sir.
Over crimping, the procedure itself can lead to malioinguinal joint dislocation. Tight crimping can erode the incus.
Yes, sir.
So adequate crimping, what we believe is very difficult from a human being. Though you can do it, this piston will not require crimping. It's like a video game. See this?
Yes.
Yes, sir.
At the lower end, kept at the lower end, and this piston is pushed. And see the middle slot of the piston taking the incus.
Yes, sir.
See this?
Yes, sir. Very nice, sir.
What a tight communication. In fraction of seconds, few seconds. See this piston right inside the vestibule, and it is tightly onto the incus. But only a small circumference of the incus is in contact with the piston, not the entire piston. See this?
Yes, yes.
Yes, yes.
No play between the piston and the incus. See this?
Yes, yes.
See this? The size we have already measured. The piston is adequately inside the vestibule.
Hello, Dr. Satish.
Size is very important. An overlong piston can be a disaster. See, this is ideal.
Yes.
So in no time, the piston placement is the easiest part of the surgery. That is the beauty of clip titanium. Two advantages. Number one, most important is no need of crimping and a tight assembly.
What type of forceps do you use to hold this piston?
The simple alligator forceps.
Simple alligator forceps, because sometimes it's tangled in that.
It's a fine alligator forceps. See this? What I'm checking is the tight, attachment of the incus onto the piston.
Okay.
See that?
Yes.
And that is the beauty of this piston. Teflon, the biggest problem is the adequate crimping. Right angle. Adequate crimping is the biggest problem. See this? The vestibule is not overlong, it's not short. That is what the adequate length of the piston is very important. If the piston is not overlong, your endosteal membrane forms underneath the piston in no time.
Okay, sir.
Except in very demanding situations, we don't use the vein graft. Demanding situations means revision situation. We always use a vein graft if it is a revision case. Number two, demanding patient, those who are frequent flyers, divers, who are exposed to more pressure change. What my point?
Yes, sir. Usually, after how many days can they fly, sir? As according to you?
Depends. On safer side, we advise patient not to fly for a week or so until the endosteal membrane forms. Now I'm using a drop of blood, yes, as a sealant. As long as the vestibule is full of perilymph, the blood is not going to seep inside.
Okay, sir.
Pressure inside the vestibule is much more than the pressure in the middle ear.
Okay, sir.
And this blood is a good sealant with fibrin in it. Now I'll remove the cotton ball. See that?
Yes, sir.
So, for checking whether the patient is fit for fly or not, we do a tympanogram test later on if patient wants a fitness.
Okay.
In tympanogram, the pressure is changed to almost 400 minus positive, whatever. The tympanic membrane becomes absolutely solid. The piston goes maximum inside whatever can go in pressure change situation. And if the patient doesn't develop vertigo, passes the tympanometry test easily, you don't need to do anything. The patient can do anything, patient can fly, patient can do any work. So the tympanometry test is an important test.
Very neat demonstration, sir.
Excellent, everything.
And we'll put a gel form.
Satish,
Yes.
what is the minimum conductive loss you advise the patient to undergo surgery, and the maximum?
Minimal conductive loss. Once you are having laser, you can even work at the low airborne gaps. But see, the idea behind not working at the less airborne gap is the foot plate may not be adequately fixed. If you are doing with your mechanical tools, you are likely to get a floater or fracture, whatever, mobilization of the foot plate. In inadequately fixed foot plate. If you have a laser, you can still give good results, even in the low airborne gap.
Minimum gap. How much do you like to go?
25.
Pardon?
25 decibel loss, AB gap.
Minimum airborne gap.
Yeah.
Yeah, we operate in patients wanting to improve hearing, even with a laser, even with a 20-25 dB airborne gap. Otherwise, if you don't have a laser, you should wait for the more airborne gap for the foot plate to be adequately fixed. You never know. If you use your mechanical tools, the foot plate may get mobilized. That is the fear. With laser, that fear is gone.
And like if at all the patient has 45 decibel loss and we have done, do we expect the closure to be like full closure, AB gap, or like what exactly is your experience?
A properly carried out stepidotomy.
Yeah.
We have seen so many times almost complete closure of the airborne gap, unless it is complicated by some other things.
Okay.
So within 5 decibel, we have seen so many times, unless there is some sensory neural loss or some other regions, malleolar ligament fixation, long extending otosclerosis can lead to that, can lead to impaired,
तो ये है और हमसे का ब्लड भी है मैं आपको वो करवा दूं.
Sir, have you encountered otospongiosis anytime?
Hello?
Hello? Have you encountered otospongiosis anytime? It's not yet completely sclerosed?
Yes, we have encountered variety of situation of the foot plate. Otospongiosis is active focus.
Yes, sir.
But yes, the active focus is one of the situations difficult to drill, more vascular. You have to drill away the focus. You have to have a lot of patience, and then post-operatively should be followed by bicarbonates.
Okay, sir.
Hello. Hello, Dr. Satish. Hello.
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 Hello. Yes, sir. I'm Dr. Vaishali here, sir. Sir is just doing something. He'll get back to you, sir.
Okay, okay, okay. When he gets back, I'll get the question. Yeah.
Hello.
Hello, Dr. Satish. I have a question. I'm Dr. Thiru from Chennai.
Yes, sir.
We do get women in their 50s who come diagnosed with otosclerosis with some sort of a mixed hearing loss. What sort of outcomes do you discuss with them? I mean, what is the sort of outcomes can you expect to give them when they have questions like, do I need a reoperation after some time, or will my hearing get worse after some time? I mean, these patients who are in their 50s, closer to presbycusis ages.
Yes.
What sort of counseling do you do for such patients?
So mixed hearing loss should be treated differently. Definitely they need stapes surgery. That is a different aspect. But they need more workup. They need more workup to rule out cochlear otosclerosis. Like madam was asking about the MRI, they are the candidates for the MRI to be done to see otosclerotic changes in the inner ear. Those are the patients wherein the role of bicarbonates is valuable, very important. Those are the patients who still require stapes surgery for their better, hearing. But at the same time, you may find difficult findings intraoperatively. Those are the patients who require a proper CT scan, who may have difficult obliterative and some other kind of foot plates. Those are the patients wherein the sensorineural part should be defined differently, can improve with stapes surgery, because one of the aspects of the sensorineural part of the bone conduction loss is the inertial component, leading to Carrat's notch, sometimes described as a mixed hearing loss. So stapes is the only surgery wherein post-operatively you find overclosure. Overclosure means your your air conduction is getting better than the bone conduction.
Yes, yes, sir.
Because the bone conduction improves. As the inertial component is lost, we know the bone conduction has three components. And one of them, when you strike the bone conduction, the hearing strikes the bone, one of the component is to pass through the extra-auditory canal.
Yes.
And that relative movement of the stapes, once it is mobile to the skull bone, gives the movement of the inner ear fluids. So that is lost in stapes, and that amounts to a reasonably good amount of hearing loss, which improves. So bone conduction improves to certain extent. So the mixed hearing loss should be properly defined, thoroughly, investigated. These are the patients where you get surprises. But still they need stapes surgery. In spite of having mixed loss, may not completely improve, but still the stapes surgery is indicated for those having massive bone conduction loss. Still your hearing aid will work better after the stapes surgery if you want full improvement.
So our discussion of outcomes should always be on this, not, we can't really, are the results consistent, or it may vary a lot?
Yeah, result will be there, but you have to counsel it properly for the realistic improvement. You have to have a thorough radiology to know the inner ear involvement. Whether there is cochlear otosclerosis setting in or already set in. Because those are the candidates wherein the bicarbonates have amazing role to arrest that otosclerotic process in the bone.
Okay, sir.
So they require more counseling, realistic expectations. Those are the candidates.
Just one more question, sir.
Yes, sir. Please.
We've had, we just noticed a few cases where there was a good airborne gap closure, but the patient has had high frequency SN loss.
Well, can you repeat, sir? I was busy somewhere.
Hello, yeah. We have had, we have noticed in a few cases where there is a good closure, airborne gap closure, but the patient also has developed a high frequency SN loss.
Yes. So SN loss, your question is amazing. See, in stapes, the surgical technique has a lot of bearing on giving, sensorineural hearing loss. In spite of all possible, care one can take,
still there are so many unknown reasons to give sensory neural hearing loss.
Yes, sir.
But there are certain ways, if we follow intraoperatively, one can avoid. And the most common reason for giving SL loss is the suctioning over the fenestra. If you suck the pen over the fenestra, it is bound to give sensory neural loss. So the most thing you saw in the surgery, entire duration, the perilymph was completely filling the vestibule. I was not going even close to it to suck over that.
Yes.
If you suck the perilymph, the sensory neural hearing is inevitable. Whatever degree, it depends on your luck.
Yes.
So the commonest reason to give sensory neural hearing loss, in spite of the best surgery done, is suctioning the perilymph. Number one.
But does it manifest with a high frequency loss, sir? Just a high frequency loss?
Yes, it can. It can. So, second, there are many reasons, unknown reasons to give hearing loss. Because once you open the inner ear, lot of physiological disturbance starts in the inner ear. Inner ear is otherwise a completely sealed area from outside. Moment you open, the pathophysiological changes in the inner ear for many reasons due to the fluid mechanics, reasons due to bone particle going in, reasons due to the vascular regions, reasons due to so many other unknown things can give sensory neural hearing loss. So that's why a proper counseling of these patients preoperatively is required. That's why it is in the guideline that up of reasons beyond the capacity of the surgeon, unknown reasons.
Yes.
But having known all this fact, we must keep in mind not to suck over the fenestra. That is one of the biggest reasons.
Absolutely, sir.
Minimal traumatic work. If you drill over the stapes, if you do use mechanical instrument and give some sort of mobilization which is beyond your control, can lead to SNHR.
Absolutely, sir.
So you have to be careful. The laser is one of the most, I would say, powerful tool to avoid many,
mechanical. Yes, sir.
Yes, nightmares in stapes surgery.
Thank you, sir. Thanks a lot.
Thank you.
Moving on to the next case, we have a child, Vanshika, of 7-year-old female, who has complained of nasal obstruction, complained of excessive snoring, and complained of mouth breathing since 2 years, and is a case of adenoid hypertrophy. I would like to welcome Dr. Soumya Sitaram, who is Associate Professor, Department of ENT, St. John's Medical College, Bangalore. And she has done her clinical fellowship in European Academy of Allergy and Immunology and is Secretary of Indian Academy of Allergy. I would like to welcome Dr. Bharti, who is consultant in Banu ENT Head and Neck Center, Mysore, and President AOI, and has experience of over 36 years in the field and is an eminent personality in the field of ENT. And I would also like to welcome Dr. Thiru, who's Professor of ENT from SRMC Chennai and has a keen interest in head and neck surgeries, endoscopic ear surgeries, and endonasal approaches. I would request the previous moderators to please keep giving their inputs for this session too. So now I would like Dr. Satish Jain sir to continue with the demonstration.
Thanks, Dr. Vaishali. It is indeed always a pleasure to watch Dr. Satish Jain operate. And I should say that today's surgeries are like a teaser for the upcoming AOICON and very nicely executed, very nice. So look forward to the Jaipur conference.
Thank you, madam. And again, we take this opportunity to invite you all to Jaipur for the upcoming Mega AOICON in 2023.
Thank you, sir.
We expect participation from the large number of, delegates for the huge scientific program. Yes. Connect karna. Hello.
Yes, sir. We can hear you.
Are you getting any endoscopic picture?
Yes, sir. We are getting. Looks like there's a mild deviation to the right.
नहीं ये किंग हो रहा है ये रही इसको इधर निकालो मैं बताऊं हेलो हेलो नहीं किंग हो रहा है मैडम ये किंग हो रहा है नो इधर लगाओ दोस्त किंग नाउ सी देखो रेजिस्टेंस हेलो सो दिस इज अ young child presented with adenoid facies with history of mouth breathing, snoring, allergic rhinitis, and so on. And classically diagnosed with obviously with adenoid facies, having adenoids, was treated conservatively with nasal sprays, mometasone, antibiotics, so many things. And now has been kept for a endoscopic adenoidectomy. After that, we'll be taking the next case will be a face with a different, frontal sinus cell as compared to the previous case, and then some vascular tumor in the nose and parotid are the cases lined up. So this patient requires adenoidectomy. I know everybody is doing adenoidectomy. There are many ways to do adenoid. There are many tools to do adenoidectomy, right from cautery to the debrider, cobblator, harmonic, bipolar, so many things, or even the adenoid curate, traditional one, people have been using. So with the improved understanding of the physiology and the pathology associated with adenoids, we have modified our technique to a different one, taking the help of the latest gadgets. Can you see the adenoid tissue?
Yes, sir.
This is after the complete medical treatment and decongestion. See the.
How many days you give, Satish?
Yes.
Medical treatment, how many months you give before you decide upon adenoidectomy, or it is the size of the adenoids which decide? I don't need to give any medical treatment.
Yes. If obstruction is too big a problem,
grade 3, grade 4.
Not wait for long. Yeah, we have seen even younger patients. Younger patients are more, adenoids are more bothersome, wherein give sleep apnea, they give, pulmonary artery hypertension. A couple of patients we have seen with pulmonary artery hypertension, and those are the patients you can't wait for long. So the indications are varied. It's not always the obstruction which is the indication for adenoidectomy. The non-obstructive indications are more becoming commoner now. The two groups of non-obstructive indications. One is children with CRS not responding to medical treatment. It's a huge group now. CRS is now more and more, I would say, increasingly diagnosed with more emphasis, more diagnostic tools to diagnose the nasal problems now, and CRS is frequently diagnosed. And in children, like adults, the first treatment is medical. So those children who do not improve the medical treatment, adenoidectomy is one of the means, as it has been proven that the adenoid harbor biofilms. And those biofilms, they keep on releasing virulent bacteria to give sinusitis, non-polypoidal sinusitis in children. So that is one of the reasons. And in those cases, those children who are not responding to medical treatment can do well with the adenoidectomy alone, avoiding a need of sinus surgery, or in case required, sometimes only middle metal enterostomy. So adenoidectomy has a major role in those situations of non-obstructive indications. Another major non-obstructive indication is the children acquiring repeated ear problems. Many children getting repeated otitis media with effusion, and one of the reasons is the adenoids giving rise to the, inflammation in the eustachian tube. May not be large enough to give obstruction, but yet adequate enough to give problems in the eustachian tube and in ear. And those are the candidates who are good candidates for adenoidectomy, particularly laterally hypertrophic adenoids.
Sir, actually, most people consider this as a very simple and innocuous surgery, but we have seen one fatal outcome in a child with persistent bleeding which never stopped. It happened in Bangalore in one of the centers.
From adenoid?
And adenoid, sir. Yeah, I don't know why, but then they lost the child also. So
Really?
it was yes, it happened quite a few years back in Bangalore.
Oh my God. That is.
One of the reasons they said was excessive use of coblation, and they had breached the prevertebral plexus.
That's why. See, the technique which we use here, which I'm going to demonstrate, which we have adopted as our standard technique, is the judicious use of cobbleter and microdebrider at places. And one of the most important part of this, see, our goal is adenoidectomy. At the same time, not giving collateral damage to any structures in the surrounding. Structures in the surrounding means structure in the nasal cavity, eustachian tube, soft palate, and the structure behind the adenoid in the prevertebral area. These are the goals of this surgery, and that's how we use, in spite of having little bleeding we come across, we use the microdebrider for the reasons I'm going to tell you, and the cobbleter for the different region which I'm going to tell you. So we use both debrider and cobbleter for the regions. The goal is complete removal of the adenoid. It's not the adenoid which are, is a tumor which can come back. Adenoid is a lymphoid tissue which get hypertrophied in response to allergy and infection. That's why after adenoidectomy, we follow them with the treatment of allergy and all that. That's a part of, protocol post-operatively. So, in our technique, what I'm going to propose you is going to be accomplished in 3 stages, 3 phases, I would say, or 3 steps. The first step, I'm using the 0-degree endoscope from the nose and a red 60 blade from the oral cavity. Can you see this?
Yes, sir.
You can see the eustachian tube, and I'm using the debrider. I know cobbleter is an amazing tool where you can do bloodless, but the unwanted charring with the cobbleter in the surrounding, which we don't want to violate the planes. I'm using this debrider in spite of knowing the fact that we'll give some bleeding. So what will minimize the bleeding, will go quickly. My first step is gross removal. See this, as early as possible. Gross removal. This is just gross removal to open up the airway. This should be accomplished as fast as possible to minimize the bleeding. And it looks like the job is done with this much of adenoid removal as the airway is opened up. The nasal obstruction is relieved.
Yes, sir.
But this is just a part of the procedure, just step 1. See, this is step 1. And at this step, we will, pack for a while with the same saline adrenaline gauge. This is the bleeding which should be acceptable to take the advantage of the microdebrider, which you will see now as we get into the right plane. Our planes are not violated because of the charring if you use otherwise with the cobbleter. See that?
Yes, sir.
This is just application of this, for few seconds.
Hello.
Few seconds. Yes.
Have you tested injecting the retropharyngeal area with Jalopin betadine in children? It also reduces bleeding. I am routinely using it.
It's an infiltration.
Yes, in the retropharyngeal area.
That's great information because generally we avoid infiltration everywhere on the mucosal surfaces. So, but it's good that you found this. But this bleeding, whatever I said, you know, you saw the bleeding. Is hardly
sir.
any. I will tell you why this should be acceptable, because the biggest advantage we get out of that is, so it's a price to pay, I would say, to get the right plane. The bleeding is the price we are paying for that, using the
Bleeding is not so much. Bleeding is
This
not
is
so.
not much bleeding, Satish, because
Yeah,
it's a
yeah.
magnification, maybe 5 ml.
Yes,
That's
yes, I
all.
know.
I think it should be acceptable, as you said.
Yes. See now, just application for few seconds, and it stops.
Yes, sir.
Yes, this wash of yours is good.
Yeah, irrigation is another method, you know, to achieve hemostasis.
I think it's adequately removed also. It's good airway is there.
Yeah, airway is opened up, but as far as removal is concerned, this is not adequate.
Okay.
See, this was the site of little oozing. I can coagulate that. The role of coagulator is to use in between. See that? Now, Anita, wash kar.
Usually the bleeding will be in the center, the branch of the ascending pharyngeal artery. You get.
Yeah. Now see, this is after the first phase. The first step of the surgery is gross removal, you can see. Okay?
Yes.
I am doing just little bit of the surface coagulation to improve the field, though it is hardly any. Yeah, see this pack again. I will just place the pack again for a while. There is hardly any bleeding. Because this is simply application of topicals, you know, adrenaline. Just for few seconds, without too much of pressure. Yeah, wash. Later. Now, my second phase will start with complete removal of the adenoid in the plane behind in the midline. एक साइड से डाल, ये इधर से डालते, आगे से डालते हैं. हेलो, साइड
Yes,
से
sir.
साइड से डाल. नहीं, नीचे रख. Yes. So now my second phase will start the removal of the remaining adenoid in the perimycial plane behind. Behind is the longissimus capitis muscle, longus colli muscle. See this. This is the oropharyngeal mucosal plane. Can you see?
Yes, sir.
So now, what I am trying to do, I am trying to get into this mucosal plane. See, I am using the same red 60. Camera pe dal. I am using the same red 60 microdebrider close up. See, I'm using tangentially. I'm using this tangentially to get into the plane. See that? You will see the flush perimysium plane. Can you see the white perimysium?
Yes,
Yes, sir.
Once you are in this plane, once we are in this plane, I will keep going up. See, behind it the muscle. Can you see?
Yes,
with the
yes.
perimysial covering. And this blade, which is anteriorly facing, is never going to damage the perimysium. Can you see the perimysium?
Yes, sir. We can make out.
Why perimysium is important? Because as long as the perimysium is intact, you are not going to damage the muscle
Prevertebral
behind.
plexus.
Because damaging the muscle behind is a disaster. See, and the beauty of this debrider is, it is not rear facing.
Front facing.
Anteriorly facing, yeah.
It is away from the perimysium, completely away. See that? See the midline. As long as the perimysium is there, see the perimysium behind?
Yes, yes.
Or adenoid tissue are coming into it, the blade. See this. No question of damaging the perimysium. If perimysium, behind the perimysium is the muscle. Suppose if you are using the cobblator, the perimysium charring is inevitable.
Yes,
Okay.
100%.
And then the muscle charring is also inevitable. What my point?
Yes, it's
How
always
can you
there.
protect? How can you control the collateral damage by the heat? Now see the plane, perimysial plane. There is no adenoid in the midline anywhere.
No.
No, it's not there. It's
This is
clear.
the mucosal plane of the oropharynx. And this is the perimysial plane. And this muscle is ending here up. See, the muscle is ending here. Above here, this bone, there is no muscle. See, muscle is here. Can you see?
Yes, yes.
But here there is no muscle. There is periosteum only. There is bone behind. So now here I will strongly do sort of combing. See, this is combing to get the adenoid out. Now I have no fear of damaging the muscle. Below I was conservative so as not to damage the muscle, but here, construction kar dijiye. सीधा करने हैं बताओ. वाह. See, now here I am combing. This is hard combing into the periosteum. My periosteum will not cut with the debrider. See this? But the soft adenoid will come into the debrider. See that?
Yes, yes.
That is combing because here is the bone behind with the periosteum over it. Below was the muscle, above is the bone. Basio-occipit. See, there is no adenoid. I am doing hard combing into it. Clear? See now in the midline. Can you see this?
Yes, sir.
Perimysium, so clear.
Very neat and clean.
Perimysium so clear. Wash. See the shining perimysium. And what I will do now, नीचे रख. कर. Soft end से कर. Now see, I packed behind for a while. Again for a while. This is my second phase over. Patla section de mark. One should avoid nasal trauma with instrumentation. That is very, very important. Too much of trauma in the nose. Too much of the trauma in the nose can invite crusting, and we can't expect any sort of cooperation for these from these children for douching and all.
Yes, sir.
So avoid trauma to the nose to give too much of crusting. See this? Just packing for a while. That's it. Over. Now I'm removing
Yeah,
this
Satish,
bag.
all your instrumentation was through the oropharynx. So the juniors and the residents should understand your steps. Only scope through the nasal cavity.
Yeah, and sometimes
Suction once in a way. That's what we observed.
Now see after the second phase.
Yeah, we can see the perimysium nicely now. Yes.
Perimysium means two things. Number one, see this perimysium means we have completely removed the adenoids in the midline. Perimysium means your muscle is protected behind. That's my point?
Yes, sir.
Only perimysium can ensure these two things. See, this is one surgery, we can make it very, very rewarding. See, minimum use of third aspect of the perimysium, intact perimysium is, if the perimysium is intact, muscle is not exposed, chances of post-operative bleeding, you can rule out.
Infection.
Because it's covered by the fascia. See this?
And the pain also will be less.
Yeah, minimal. The scarring because of the muscle, trauma will be least. There's no scarring practically. Now what I will do, the post-operative bleeding we have seen, where it can come from? From where the vessels are. As long as the perimysium, see, as long as the perimysium is intact, we are not supposed to do any cautery over it. Got my point? If you cauterize too much, that is going to char the muscle. Now this area above is the periosteum. Periosteum has a lot of vessels, and I am doing a carpet coagulation here. See this? Without any fear of charring any muscle. Can you see?
Yes, sir.
This is carpet coagulation from the area where the bleeding can come from. See that? And that is what the periosteum area is. See, there is no question of bleeding which now can come from this area. This is carpet coagulation. Now you see the adenoids from this plane. Gone? Hello?
Gone. It's gone, sir.
Yeah, and here is the periosteum, which is completely coagulated to prevent the secondary hemorrhage. Because there is no muscle to contract if the bleeding comes. Here is the muscle to contract, and the perimysium over it cannot bleed. So it is essential to do a carpet coagulation above to prevent the chances of secondary hemorrhage, because there is no muscle to damage. Now my third part of the surgery is to remove the adenoids completely from the lateral area, from the fossa of Rosenmuller, which is still harvesting a lot of adenoids. See this. See the adenoids.
Yes.
Again, in the same way, see, if I use my coagulation for removal of the adenoid, it will char everything. See the plane? We are not supposed to damage. And see here, just press on the muscle. See, I'm pressing on the muscle behind. I'm not blindly pushing my blade inside, allowing the soft adenoid to get sucked into the blade. See that? Find out. Can you see?
Yes, sir.
The soft adenoids are getting sucked into the blade. We are not pushing the blade blindly inside. See, allow the adenoids. Wherever the soft tissue adenoid, it will jump into the blade. Muscle or anything will not jump into it. What's my point? And see the clearance of the fossa of Rosenmuller. No, like that. That is the clearance from the fossa of Rosenmuller. See this?
Yes, sir.
No soft tissue is left behind to jump. I will just place a simple pack for a while. Just for a while. So this is tricky to remove the adenoid from the lateral part. Record this.
It is essential to remove all that not possible. Every visible. Hello?
Pardon?
Is it really necessary to remove all adenoids? Complete adenoidectomy?
Hey, boss, why we are operating? See, these lateral adenoids are responsible for the ear problems. See, and you can easily remove. You don't go deep. You don't go blindly inside. Just stay over the perimycial plane. Same thing what we did in the midline, we did in the lateral part. See this? We leave it for a while and go to the other side. See the same thing on the opposite side. Safely. Safely without damaging. See this?
Yes, sir.
Hello, Dr. Satish.
Press on the muscle. Yes, sir.
What sort of caution would you advise a surgeon when putting a blade of this sort into the fossa of Rosenmuller? I mean, the fossa of Rosenmuller, the depth is related to the ICA.
Yeah. I was coming to it. I know.
Yeah.
This
So what sort of advice would you give to a beginner surgeon?
Yeah. Let me tell you. The first point I have already tell you. See again here. Just pass your blade. See the cutting edge and allow the soft adenoid to fall into the blade. I am not pushing inside this to cut something out. See this? See this?
Yes, sir. Yes.
See the adenoid tissue is dying to get into the blade. See this? See, it is jumping into the blade.
Yes,
Can
sir.
you see? My carotid is more than a centimeter, more than 1.5 centimeter away from it, with two thick muscles separating from it. See what I did? Can you see my cutting edges all the time?
Yes, sir.
Press on the muscle. Press on the muscle.
Okay.
Allow the adenoid to see now. Nothing adenoid. No adenoid is falling into it.
Yes.
I will not do anything. So allow the adenoid tissue to fall into it rather than pushing it hard into it. Number one. Number two, see my lateral area opened up.
ಅದೇ ಅವ್ರೇನೋ ದೇವಸ್ಥಾನಕ್ಕೆ ಹೋಗಿ ಎಲ್ಲ ಮುಗಿಸ್ಕೊಂಡು ಅವನು ಅದೇ ಎಂಗೇಜ್ಮೆಂಟ್ ಏನೋ ಇದಾಯ್ತು ಅಂದ್ರೆ ಎಂಗೇಜ್ಮೆಂಟ್ ಆಗಿದ್ದಿಲ್ಲ ಹುಡುಗಿ ಫಿಕ್ಸ್ ಆಗಿತ್ತು ಎಂಗೇಜ್ಮೆಂಟ್ ಅಂತ ಆಯ್ತು.
Bharti ma'am, your speaker is on.
Yeah, we can hear.
Hello.
Yes, sir.
Yes, sir.
See now, it came out only the soft adenoid tissue jumped into the blade. So what we did, allowed the adenoid to jump into the blade rather than pushing anything to get anything cut from inside.
Yeah, I think this message has to go to the postgraduates and the younger consultants watching. They have to be cognizant of the fact that you can't push the blade inside and forcibly try to remove it.
Yes. Just softly press on the muscle behind and allow the soft tissue to get sucked into it. Only the soft adenoid will get sucked into it. That's it. With all the time cutting edge of the blade in your view without pushing anything behind.
Post-op, will you put the child on intranasal steroids, sir?
Yes, always. We have to treat allergy.
Okay.
Allergy is a medical disease. You can't treat surgically. Now see, I am removing and see the fossa of Rosenmuller. Can you see?
Yes. Yes, sir. Yes, yes.
Is any adenoid left behind?
No, not at all.
No, even the muzzle is so nicely seen with the fascia over it.
Yeah, fascia over it. That is most important.
Dr. Satish?
Yes, sir.
I mean, we have transitioned from an era of blind curettage to something aesthetically more pleasing now and obvious complete removal. Have you noticed any difference in outcomes? I mean, barring the reoperating rates, have you noticed any other difference in outcomes over the years? Quite obviously, leave behind the reoperative rates. I mean, previously, blind curettage always used to have a higher.
See, first of all, you rule out the possibility of revision surgery 100%, almost.
Yes.
See that? And you can effectively treat or tackle the adenoid related complication better because now there are no adenoids. Laterally hypertrophic adenoids, many a times you must have observed, you have treated adenoid, yet the ear problems are not stopping. Recurrent otitis media, you can't do anything but to give steroid and nasal drops and all that.
Yes.
This, believe me, works amazing. See the fossa of Rosenmuller on this side.
Yes,
see
sir.
How see how deep it is. See how deep the fossa of Rosenmuller is. See this?
Yes, we can appreciate, sir. Yeah.
So you can, there's a, my surgery is over. Just couple of minutes we'll look for the hemostasis. See, important thing is we are not going beyond our limits. Now everywhere around, see there's the limit. You are in the right limit, the bleeding will automatically stop. If you leave some adenoid tissue behind, which it may keep bleeding. If you have the perimysium all around, there's no question of bleeding.
The people, hello?
Just what?
People who don't have coagulator, how they will use cautery? Monopolar should not be used, I think. have two incidents of temporary paralysis of subpalate, monopolar population. So monopolar should not be used in especially for soft nostril motor.
So cobbleter has become I tell you, the essential part of the
NT.
armamentarium in ENT now,
Yes,
due to various regions. It has a vast, not only adenoid or anything, but it has a vast, application. Adenoid is this cobbleter is amazing tool. So look at the adenoid surface.
Wonderful, sir.
This will just leave it for a while. Now, in situations, suppose you are worried about the bleeding from the adenoid, particularly laterally or somewhere, what we do sometimes to stay on the safer side, we just leave a single layer of Surgicel into it. Single layer. It sticks so well, it doesn't behave like a foreign body to come out. Let me show you. So my adenoidectomy is done. See this? देख इसको रिट्रैक्ट कर, ये क्या रखी है आज? इधर. Hello.
Yes.
Sir, we can see the Surgicel being placed.
Yeah, single layer. Single layer of, just to show you, though it is not needed here. But yes, you can do for a peaceful, post-op because
excellent.
वो the cobbleter there. इसको retract करिए, stick it to. There is some area. Yeah, यही से. See some oozing from the edge. You can control with the cobbleter easily. I'm using 0 degree. You can use 30, 45 in case you want to see laterally. Give me for a while. 2 मिनट के लिए छोड़ दे. And this is just to how to apply the Surgicel. because Surgicel sticks so well. It works like magic. See, why did we do all this? To achieve a comprehensive adenoidectomy. Number two, without giving any complications in the surrounding, in terms of surrounding damage. Watch there.
Sir, until this Surgicel gets absorbed, it can potentially block the eustachian tube for the child.
Not really. Eustachian tube is here, far anteriorly. See, eustachian tube is here. Surgicel is behind. It is not blocking. Surgicel doesn't swell up like gel foam. See this? Now see the panoramic view. This is comprehensive adenoidectomy.
Very nice, sir.
It may
Usually
take
we
10
don't
minutes.
see adenoids in conferences. Nobody demonstrates adenoids. I think perhaps first time I'm seeing very nicely done.
सामने से दो. Irrigation for 5 minutes so that you get to know if there is any oozer. Now irrigation from the nasal cavity side. See this? All crystal clear. See? Wait for 5 to 10 minutes for any single drop of blood if coming. Because children, you can't take a chance of even a drop of blood. They are not going to cooperate. The parents will go psycho. Okay, you there. Restless night. See, the Surgicel is all set. So this is all about the adenoidectomy. That's the final picture. Thank you. Thank you for your attention.
Thank you,
Next
sir.
Thank you, sir.
Thank you. Idhar le lo. So the next case will be again a sinus surgery, I think.
Yes, sir.
Thank you, sir, for such an insightful demonstration. I would like to remind the audience watching about the national conference AOICON 2023, which will be held in Jaipur from 2nd to 5th February, organized by AOI Rajasthan. We would like to request everyone watching to register as soon as possible and in large numbers so that we can make the event a grand success. We look forward to welcoming you all in AOICON 2023. The next case would be of patient Rajesh Yadav, who's 35-year-old male, who has complained of nasal obstruction, nasal discharge, and excessive sneezing since 3 to 4 years. I would request Dr. Ashwini, Dr. Markandeya, Dr. Bharati, and Dr. Thiru to please continue moderating the next session too. Thank you. I would like Dr. Satish Jain to please proceed with the next case.
Okay, so this patient is the first one, Rajesh, no? Can you connect to this? Hello?
Yes, sir.
So this is another case for sinus surgery with some interesting finding. Are you getting the CT image?
Yes, sir.
So this is a axial section CT scan. It's always shot in axial plane, and then we reconstruct. So let me show you first the coronal plane for your understanding. See this full house complete whiteout. Can you see?
Yes, sir. Yes, yes. Sir.
The gross septal deviation. See this?
Yes.
Giving nasal obstruction, gross septal deviation. And see the most interesting finding if I come anteriorly. See, which is the frontal sinus? Which is the frontal sinus? This is frontal sinus on this side, this is frontal sinus on this side, and this is what? The bigger one. This is intersinus septal cell. Amazing. Can you see?
Yes, sir.
Why I'm saying so? If we follow it dynamically, see this. Can you see now better?
Yes, yes, sir.
This is frontal sinus on this side, frontal sinus on this side, and this is intersinus septal cell. See, this is the intersinus septal cell.
Yes, yes, yes. Sir.
Which is overgrown bigger than the frontal sinus itself.
Yes, yes, sir.
See, the frontal sinus is here.
Yes.
Frontal sinus has frontal recess here. Frontal recess here. This is the beak. See this
Yes,
beak?
sir. Yes, sir.
And the first cell, the anterior most cell in the paranasal sinuses is what? Intersinus septal cell. Of the entire cellularity in the paranasal sinuses, the first, or I would say the most anterior cell is the intersinus septal cell.
Okay, sir.
Then comes the Aganegi behind.
Okay, sir.
So it is more anterior anatomy than Aganegi, and see this intersinus septal cell.
Yes, sir.
And this is communicating to which sinus? Left sinus. See this is communicating to the left frontal sinus. Could you appreciate this? Intersinus cell, septal cell has to communicate to one of the sinuses.
Yes, sir.
And where it is communicating to the left sinus. Now, how to ensure, how to see much better, a more three-dimensional view that it is communicating. Why I'm saying it is communicating to the left one? Let's see. See, I'm taking my cursor to the intersinus septal cell. See in all planes.
Yes, yes, sir.
See on the axial, the intersinus septal cell. Can you see?
Yes, sir.
Now, as I go behind, see now this is communicating to this sinus.
Yes, yes. Yes.
Now the same thing you appreciate in the axial to confirm this.
Yes, yes. Correct.
Now let me show you. See, this is intersinus septal cell.
Yes.
Now,
Sir.
as I'm going down, see this is communicating to this.
Right.
See, this is incomplete septation, and this is communicating to this sinus.
Yes. Sir.
So this communication, if you take it here, that is the communication of the intersinus septal cell. So posteriorly, it is communicating with this cell is communicating with the left side frontal sinus.
Yes.
So this cell is an amazing anatomy, which is much bigger than the both frontal sinuses. It is overgrown, bigger than the size of the frontal sinuses. The frontal sinuses have been compressed on both sides.
Yes, sir.
See, this is the beak. As I go behind, now the sinus is open. So we have to open this sinus like a regular one.
Yes, sir.
We have to open this sinus like regular one, and see posteriorly here, this is the frontal intersinus septal cell which is communicating to this.
Yes, yes.
Once we remove this party wall, if we remove this party wall between the intersinus septal cell and this cell, the sinus, this will be a common cavity.
Okay, sir.
And that will be the final answer to it. for the drainage of the frontal sinus and intersinus septal cell both, we have to communicate them together.
Okay, sir.
So that is the key finding in this particular patient. Rest is same. The other positive finding is a gross septal deviation on the left side only. So we have to do first left septoplasty.
Yes, sir.
Then on the right side is the concha bullosa. Can you see this?
Yes, yes, yes.
This side looks like, compressed middle turbinate, a thin middle turbinate.
Yes, yes.
Huge maxillary sinus and complete whiteout. No differentiation in the cellularity. And as you go behind, see this? This is ONOD.
Yes, yes. Correct, sir.
How to confirm? Let me show you. I was saying this as an ONOD cell.
Yes, yes.
Now take my cursor into it and see the sagittal at the same level.
Yes, yes.
See, this cell is going beyond the anterior margin of the frontal. This is ONOD. So you have to take the advantage of dynamic CT scan to go to all planes, to see every single anatomy in a proper way.
Okay, sir.
See on the opposite side. This uncinate is compressed because of the polyp far laterally.
Yes, yes, sir.
See on the opposite side, this uncinate has been, the lateral nasal wall is compressed because of the polypoidal mass.
Yes, sir.
And made this right side sinus so small. See this? The lateral wall of the nose is compressed laterally because of the polypoidal mass and made this sinus so narrow. Difficult, eh? So this is a difficult sinus on the right side. This is not a challenging sinus, but opposite sinus is difficult. Got my point?
Yes, yes, sir.
Such amazing findings in this case. And again, I will demonstrate one side, and the side which is, most important here because of this intersinus septal cell. This is the impression of the optic nerve here. That is the impression of the carotid artery here. And that is the carotico-optic recess. The sphenoid septum is almost in the midline. So no challenge there. There is a little bit ONOD cells on both sides going beyond the anterior margin of the sphenoid sinus. And this gross deviation, we have to correct this. Gross septal deviation, we have to correct this. And then this intersinus septal cell. So that is our goal in this patient with this interesting anatomy. Any questions or anything? Hello?
Yes, sir.
Any questions before we move on?
Yes. Hello? Hello? Hello?
Hello? Yes, sir. Hello?
Hello?
Hello.
Yes, sir.
Sir.
Yes, sir.
Sir, I mean, this is just a question for. How do you time your CT scan, sir? You said all these CRs with polyposis, you put them on a week's course of corticosteroids, oral
Before
corticosteroids.
Before the surgery.
So your CT scan is done after the course of corticosteroids or just before the surgery?
CT scan was done when the surgery was planned.
Okay.
The optimum time of CT scan is when you plan the surgery.
Okay.
Once you plan the surgery, then you have to prepare the case. And obviously that CT scan is done when surgery was planned after the medical treatment only.
Yes.
So the pre-operative preparation is different.
And the planning for the surgery is
yes,
different.
Yes.
So that's a very interesting case. That's why we kept this. So our first case was the frontobular cell. And this
Satish,
is, yes, madam.
Satish, I have one doubt. Here, it doesn't look like fungal, isn't it? I mean, we are not seeing any hypertension, but it's such an expansile polyps we are seeing. Is it common to have such expansile polyps without the,
very,
I mean, on
funny.
radiology?
Now, let me tell you, this is the soft tissue, soft tissue window.
Yeah, yeah.
And can you see the heterogeneous densities in the back?
Yeah, now I can, yeah, correct.
So could be fungus inside.
Yeah, then no problem.
See this?
In this case, hello Satish. In this case, sphenoid sinus is not extending little more anteriorly and giving the impression of that it is a onodicell.
Sphenoid sinus is
extending anteriorly in the posterior
sphenoid
area.
sinus is always in place. Sphenoid sinus is always in place. The posterior ethmoidal cell may vary in their size and dimension and growth. This could be fungal as well. On the right side is a concha bullosa. See this? See this concha on the right side?
Yes, yes, yes.
See this? The huge bullous bulla ethmoidalis. And see this fungal material could be so interesting. Let's see. So in a couple of minutes, we are getting on to the case. Hello.
Hello, sir.
Yes, sir. So we can discuss questions or anything. Meantime, the case is being induced. It may take 5-10 minutes.
इसमें लगेगा 3 तो सामान
उसको प्लाई का वाला है सर छोटा।
किसके लिए?
Hello? Hello?
Hello.
Yes, sir.
Hello, sir.
Hello? Hello, sir?
Yeah. The screen is frozen.
No, sir. The screen is not frozen. Actually, the patient is getting induced, sir.
Oh, okay.
Yeah. Yes, done. Thanks, sir. Thanks.
Hello.
Yes, sir.
Yeah. Am I audible, sir?
Yes, yes.
So this is the initial finding without decongestion now. Can you
Okay,
see
sir.
the polyps?
Yes, yes.
See the multiple polyposis and opposite side as well. See the polyps.
Yes, yes, sir.
Madam was asking, could be something else giving that much of pressure. See the amount of
Yes.
polyposis.
Yes, yes, yes.
So the initial decongestion as usual.
Yes, sir.
This is opening the nasal space.
Yes, sir.
See the multiple. Let me debride some polyps to get more space.
Sir, you will do first septoplasty.
Pardon?
You will do first septoplasty, sir.
Yeah, I will have to do. Let's see. See the gross polyposis.
Yes, yes, sir. What may be the possible etiology in this case, sir?
Pardon?
What may be the possible etiology in this case?
Possibility of?
Possible etiology, sir, of this polyp.
Yeah, etiology is, see, for all sinus disease, it has been proven to be a immune complex etiology. Etiology is nowadays almost always immune complex. See, this is just gross removal of the polyposis.
Yes, sir.
Why? Hello.
Yes.
Why did you select left side first in this case? Although you
Because
have
of that frontal intersinus.
Because one side I will demonstrate that is intersinus septal cell.
okay, you have to demonstrate that.
Yeah.
It has got less amount of space in this area.
Huh?
There is telling less amount of space.
Right side could have been done easier. No?
Yeah, with less, roomy nose,
Yes.
you get more space on the right side.
So once you remove the right side, septum can be pushed to that side also.
Recall it. Say this gross deviation in the floor, the spur in the floor.
Yes.
Post there, no? See the amount of polyposis.
Yeah.
मतलब है ना सब Count the blade. Blade. See the landmarks what we see here. Can you see this mobile structure?
Yes.
This is uncinate.
Yes.
This is the horizontal portion of the uncinate. I can see this.
Yes.
This is vertical portion. And we saw there is a massive disease in the maxillary as well. Massive means full. So let's open the maxillary first. See. Not cutting. I have not done the septoplasty yet. Yes, this maxillary is full of polyps.
Yes.
See, this is looking like some fungal material. This is upper vertical part. Washed, no? Couch. See, I have, looks like adequate space for my superior work. We can do septoplasty later.
Okay, sir.
See, this is fungal material. See this?
Yes, sir. Oh.
We saw on CT scan. Motor. This we could see on CT scan this.
Yes.
But heterogeneous. Motor wala this section. Motor wala no? Massive polypoidal disease, fungal disease. And these are the patients which require mega middle metal antrostomy. They require more surveillance, more steroids post-operatively. Wash. लगाओ. Crowd this motor crowd. Oh, so this is the initial work. Our goal is to go up and see the intersinus cell in the frontal left.
See this cheesy material?
Yes, yes.
Cloud.
Oh, God.
This is classical of allergic fungal sinusitis.
Yes, looks like so.
Okay, rest will clear once we see the CTs with the 70-degree later.
Okay, sir.
Now, see the all distorted anatomy.
Yes, yes, sir.
This is the upper part of the uncinate. I am following it up. The first thing we'll make out is the lateral limit.
Okay, sir.
See, everything removing, everything.
Can't imagine, sir, without doing septoplasty. Left side, sir. Amazing.
See, this is my lateral limit.
Yes.
Could you see?
Yes.
Going little quick. That is lamina preparatia. Could you see?
Yes, yes, yes.
क्या हुआ? So I have defined. See the maxillary sinus below?
Yes, yes, sir.
Up and One. That is your lateral limit above.
Yes.
Just to define the landmarks. See, all anatomy distorted. So you take care of your landmarks.
Yes, sir.
See the skull base behind.
Yeah.
I can see the posterior artery there, like vessel there on the skull base.
Okay.
See the vessel?
Yes, yes, yes.
That is the level of the skull base. That is the level of the axilla. Now removing this Agar-Naji middle turbinate complex anteriorly.
Okay, sir.
Going quick.
Debriding middle turbinate, sir.
Partly. This is part of the middle turbinate.
Yes.
Yeah. कैसे छोड़
See now, the landmarks so far we have got.
Yes, sir. Middle terminate lamina.
Yes.
Posterior ethmoid.
Yeah, that is the skull base behind.
Yes, yes.
This is posterior model skull base behind. Lamina, middle turbinate. And we are going up anteriorly.
Yes, sir.
This is your maxillary sinus. If you do frontal in the end, you can easily do the sphenoid work over here.
Yes, yes.
Sit there. So leaving the frontal work for the end.
Okay.
See the polyposis.
Yes.
Still a lot of polyps.
It's coming from bulla, sir.
See, debrider surgery. See, all.
Yes. This is bulla, sir.
Yeah, it's all removed. Fast endoscopic sinus surgery going on. That is the sphenoid. See this?
Yes.
Everything being done with the debrider only.
Onodi is on right side, no, sir.
Yes.
Onodi is on right side.
Yeah. I am. See, even if there is onodi, you stay close to the septum.
Okay.
See, this is the medial orbital wall inferiorly.
Yes, yes, sir.
Now let's see. Pardon. Patla section. I have not corrected the septum yet.
Yes, sir. Amazing, sir. Amazing. Can't imagine. In the such deviation.
See the corridor now.
Yes, yes. Clear.
See the maxillary sinus fully widened.
Yes, yes.
Out there. Out section. See the maximum work with a 0 degree has been done.
Yes, yes.
In the sphenoid sinus.
Yes, yes.
See the coina behind.
Yes.
Now in the sphenoid lower part,
Yes, sir.
I'm using my red 40 towards me.
Yes.
Not toward the critical areas.
That ovally stone mucosa you will remove, sir? Debride little bit?
No.
Okay.
See, with this much of 60 there, this much of patency, this much of space
Yes.
for the
Enough for
topical
delivery.
fluid to go
Yes.
inside. Practically no need to damage the mucosa unnecessarily.
Okay.
In first surgery, mucosa is diamond. You preserve the maximum mucosa, will be minimum crusting.
Okay.
So see, this sphenoid work has been done. We'll do irrigation, maxillary sinus. We'll see with the 70-degree little later. And the full space for the work anywhere now. And now moving toward the frontal. The 640 there. See now with the 0-degree.
Yes.
What cell I am opening is the middle cabinet Aganesi complex.
Yes, sir.
Panda.
Clear.
Okay, once this complex is completely removed anteriorly,
Yes, sir.
you can approach the frontal sinus much better.
Okay.
Blade which faces the surgeon
Yes,
is
sir.
always safe.
Okay.
Let me take 70-degree now to finish off on this side. See now I am with 70-degree.
Yes, yes, sir.
See, this is the skull base we defined behind.
Yes, yes, sir.
And we are following the same skull base anteriorly.
Yes, sir.
Now what you have to define anteriorly, this is the beak.
Yes.
See that?
Yes, yes, sir. Corridor is clear, sir.
Oh, 120. See, that is frontal sinus.
Yes, sir.
Construction, you know. You can see the frontal sinus now.
Yes, sir.
Now, I will show you what we have seen on CT scan. See, that is the frontal sinus, and this is Chiji material.
Code the lumbar. Code ऊपर. Kambi वाला. 120.
एक मिनट आवाज मत. Hello.
Yes. So that is the frontal sinus.
Yes,
Sir,
sir.
which debrider it is? Right, 60?
Yeah, this is 120.
Okay.
Now, where is intersinus septal cell?
Medially, sir. Medially looks like.
Yes.
Yes, medially.
Now see where I am
Yeah.
going.
Yeah, yeah. Correct, sir.
And see, this is the party wall.
Yes, yes, yes. Clear. Yes.
Now see. That is the party wall.
Yes, sir.
Wash. And this is intersinus septal cell. See this material. Section there. See how easily we could establish this connection from CT scan.
Yes. It's a typical AFRS.
This is intersinus septal cell. We know this is much bigger.
Yes. Oh, amazing. Amazing, sir.
See, that is.
Yeah, yeah, correct.
This is much bigger.
Yes, sir.
To blade again. Go drill.
Plus, sir.
See how you can see both the openings. This is what exactly we saw from CT scan.
Just plus, sir.
See, that is the intersinus septal cell.
Yes.
That is the frontal sinus. Wash. So we have to irrigate more and more now. See this?
Amazing.
I'm sure this will do well. This will do well. 120. Either.
Which instrument you will use, sir, for removal of this septum?
For this?
Removal of this septum, which instrument you will use, sir?
Ideally the drill. Ideally the drip, and if you have find the adequate opening is there,
yes, sir.
You can leave like this. See, this looks good.
Yes, yes, sir.
This looks adequate.
Yes.
See the entire cavity on this side.
Sir, one cell is
Why I did not did the septoplasty first? Because we have to do opposite side, and the septoplasty done earlier will create problem on the opposite side.
yes, sir.
Sometimes becomes floppy.
Yes, sir.
Flaps can become problem. So this side job is done. And the important thing is this big intersinus septal cell. See that?
Yes. Superb, sir. Sir, one cell near anterior ethmoidal artery, just
One cell?
near anterior ethmoidal artery looks like some.
Anterothoidal artery is not bothering us.
No, one looks like in that region some disease.
No, it is not.
Okay.
See, this is anterothoidal artery.
Yes, yes, sir. Clear.
See here?
Yes, sir.
This is anterothoidal artery.
Here, yes, sir.
Aerosol. See the maxillary as again cobblestone mucosa.
Yes, sir. Into the inferior part.
Satish boss,
Yes, boss.
do you use 120-degree blade for maxillary sinus clearance?
Yes, yes.
70 degree.
120. If you find difficulty, I can bring my blade from the sublabial region.
Right.
But since you have such a huge, now drainage or the irrigation pathway, see this? You don't have to be very aggressive with the, mucosa removal.
Okay.
Yes.
That is unnecessarily inviting problems.
Right.
See this?
Yes.
Yes. Quite well.
This is 120.
Yeah.
Wash. See the maxillary is good, it will revert back.
Yes, it will revert back, right, sir?
This is not irreversible mucosa.
Yes, yes.
Post-operative irrigation with the steroid will bring back to normal.
Yes, yes.
Now, in all the difficult frontal we did today, if you have slightest if you're not confident, slightest of the doubt regarding incomplete job done, whatever, convert to draft. Simple.
Right.
That is the final answer.
Right.
So we will move on to the other case. This will be done, finished on the other side by our colleague. And see the intersinus septal cell. See that?
Excellent.
Yes, sir. Excellent. Wonderful, sir. Amazing. Amazing, sir. Without such a limited space.
So we'll do septoplasty on the other opposite side is done.
After that, you will do sir septoplasty.
Yes, once the opposite side is done,
Yes,
then
sir.
we'll do the septoplasty.
Okay.
Opposite.
Thank you, sir. Thank you. Fantastic, sir. Fantastic.
What is the next case, boss?
The next case is going to be a interesting vascular nasal mass in a female with operated 2-3 times somewhere with different pathologies, maybe inflammatory myoblastic tumor through some pathologies, some pathology commenting like hemangiopericytoma, some pathologies commenting as pseudo tumor, some as don't know what it was, 4 or 5 different diagnoses were given. As a female with a extremely touch profusely in the right nasal cavity. We have the MRI as well with the vascular mass enhancing on contrast, but not extending too extensively outside the confines of the nasal cavity or sinuses. So I think whatever it is, we need to subject the tissue for not only histopathology but immunohistochemistry and removing that. The patient came with a bleeding. The bleeding is there every day. So the first is to get rid of that, and it is excisable, completely excisable endoscopically. So in 5 minutes time, we'll be back with the next case. Meantime, any questions related to this?
Hello.
Hello.
Yes, boss. In this kind of fungal sinusitis,
yes,
do you give some post-operative antifungals like?
Not really.
Not really.
Not really. See, this is not invasive fungus.
Allergic.
This all disease is because of the patient being allergic to some environmental fungus.
Yes.
Wherein this eosinophilic reaction led to this kind of disease. So this is pure allergy, antigen antibody reaction.
Right.
Steroid is the answer. And these are
Yes,
the
yes.
patients which require post-operatively oral steroids also for some time. And full irrigation with the topicals.
So, what are your indication of voriconazole in invasive aspergillus fungal sinusitis?
Yes.
Hello, what areas are involved?
Anywhere. Invasive fungal disease is not surgical entity. Role of surgery is to open up if sinuses are blocked, to get the tissue for histopathology, to relieve the compression if pressure symptom there on some critical area. That's it. It's purely medical disease with voriconazole being of choice.
Okay. What's the dose and how long?
That is the biggest question, the how long. But we
21 days?
monitor with 3 things.
Initial dose, Mansi, we have to be very careful about the liver enzymes because in significant number of patients, the liver functions are disturbed with voriconazole.
Yes.
3 days low dose of 400 milligram twice a day, then 200 milligram twice a day for few months, and we monitor with the serum galactomannan level, number one. Endoscopic picture, endoscopic findings, number two. Clinical findings, the patient symptomatology, and imaging, all together.
Right.
The length of duration of therapy is dependent upon all these four things.
Right.
Galactomannan is important test, being a protein in the fungal wall, and it is raised in aspergillosis.
How frequently we do go for galactomannan and imaging?
For aspergillosis, quite frequently, because you can monitor the therapy. With therapy, the galactomannan level come down.
Yes.
So before stopping the treatment, this is one of the criteria to see if galactomannan has come down to normal.
Right.
Clinical symptomatology has gone down. The endoscopic picture is good. Imaging is clear. Then only you have to take a call. Sometimes patient need to take for a year, 1.5 years. It's very frustrating disease.
Okay. So what is your experience of posaconazole in comparison to voriconazole in case of aspergillus?
Posaconazole is not as effective as voriconazole, number one. Number one drug therapy is voriconazole.
Right.
Those are alternative, and posaconazole is more hepatotoxic.
Yes.
If you really want to give...
And I think it is not fungicidal, no?
Fungistatic.
Fungistatic, yes.
Yes. So if the patient is, the voriconazole is giving hepatotoxicity, then the second drugs are etoconazole or this isovuconazole. Isovuconazole is safest of all.
Cresemba.
Yes. But it is not as potent as voriconazole.
In case of aspergillus.
But it is safe. Itraconazole is another alternative drug.
Is it effective properly?
Then no other drug is comparable to voriconazole.
Okay.
Voriconazole is the drug of choice.
Yes.
Now, it will take 10 minutes for the patient to shift. Meantime, I can take you through quickly to the, MRI findings of the next patient. कर दो ना. So once again, request for joining for AOICON 2023.
खंबागड़ी AOI राजस्थान आपका 74th नेशनल कॉन्फ्रेंस ऑफ एसोसिएशन ऑफ ऑटोलैरिंगोलॉजिस्ट ऑफ इंडिया AOICON 2023 19 से 22 जनवरी में आपका स्वागत करती है। of civilizational progress and rich cultural traditions. It has achieved a golden balance between modernity and a magical old world charm. Founded in 1727 AD by Maharaja Savai Jai Singh II, Jaipur, the capital of Rajasthan, is popularly known as the Pink City. Since the color pink was symbolic of hospitality, Maharaja Ram Singh of Jaipur painted the entire city pink. The pink that colors the city makes for a marvelous spectacle to behold. A city blessed with royal palaces and forts, you are sure to run out of time but not places to visit. The city palace, which is a home to the Maharaja of Jaipur, is sure to mesmerize you with its grandeur. With broad avenues and spacious gardens, the city is steeped in history and culture. The city also takes pride to be the first planned city of India. The famous walled city is a home to the bustling bazaars which are loaded with traditional clothes, bagru prints, handicrafts, blue pottery, traditional jewelry with the intricacies of kundan and meena, the colored stones of emerald and ruby, handmade paper, jutis, carpets and Jaipuri razai, stone sculptures, miniature paintings, decorative items. This modern city is one of the three corners of the Golden Triangle that includes Delhi, Agra and Jaipur. Jaipur is a well-connected city with a good air, rail and road connectivity. We have an international airport which receives multiple flights from various countries on a daily basis.
We have currently blocked 3 venues for the upcoming conference. Apart from JAICC and Birla Auditorium, the venue which sounds most promising at the moment is Radhakrishnan Convention Center. When needed, after due inspection and approval by the national governing body, these places can be converted into conference venues. We take immense pride to host you at the Radhakrishnan Convention Center, Jaipur. Endowed with state-of-art facilities, the venue has 2 large auditoriums, one having a seating capacity of 1,500, expandable to 2,000, and another one with a capacity of 1,200. They have been appreciated for all the academic and cultural events that have been conducted over here. The convention center is spread over 7 floors and has multiple lecture theatres. 3 halls have a capacity of 300 people and the other 3 of around 250 people. Each lecture hall has world-class audiovisual setup, a huge projector screen and other multiple screens, along with comfortable seating arrangement, ample of open space and clean washroom facilities. Jaipur has always been a hub for national conferences. We have hosted AOICON, FHNO and SkullBaserCon to name a few. Eminent national and international faculties from all over will assemble and share their knowledge. This extravagant conference will provide an array of understanding and draw diverse perspective of otorhinolaryngology. The academic feast will be an amalgamation of interactive live surgical demonstrations, workshops, orations, symposiums, paper presentation, poster presentation and quizzes have been arranged for the delegates to win exciting prizes. Adjacent to these auditoriums, we have lush green lawns, which will be converted into domes to host the delegates for lunch and refreshments. This space can accommodate around 2,000 delegates. These lawns are spread over a huge area and are accessible from all the corners of the venue. We will plan numerous food stalls where we plan to tickle your taste buds. Though Rajasthani delicacies will be a great attraction for all, but keeping in mind varied ethnicity of our delegates, we plan to incorporate maximum national and international cuisine to cater your palate. Spread over multiple acres, the venue has enough open space, which will be used up as parking lots for the cars and vehicles of the delegates. Along with the academic activities, in accordance with the AOI guidelines, we have planned to keep your hands full with various recreational activities that will be going on in the entertainment zones, recreation lounges and family zones. Logged in cloakrooms along with toilet facilities will be situated at multiple locations all across the venue. Keeping in mind your busy schedule while at the conference, we plan to bring you the best of Jaipur souvenirs so that you don't have to venture out in their search. tastefully organized and inculcated into a trade fair where these Rajasthani antiquities of timeless qualities will be available to you at fair rates. Jaipur, the pink city of India, is a huge tourist attraction. So we would love to host your spouses and family at this conference. And worry not, we have planned exciting activities to keep them entertained while you are busy with the academics. Various cultural events and arrangements for sightseeing in and around Jaipur have been arranged. Right from the time you land on this royal soil till the time you plan to leave, we will be at your service. Heritage cars, buggies, camel carts, elephant rides, and golf carts will be available round the clock to make your commute between the venues comfortable. We will make sure that you find the experience value for money, along with delegation certificates, RMC credit hours, international faculty lectures, and lifetime memories. The delegates will be showered with a bunch of complimentary stuff, which will be our way of showing gratitude for their attendance in this conference.
पधारोनी मारे देश रे
Jaipur is a beautiful city having an excellent amalgamation of heritage with modernism. With picturesque gardens and palaces, we plan to create dazzling banquet at such beautiful locations which will host our cultural events and diners. With over 1178 hotels, we have 15 plus heritage resorts, over 20 5-star luxurious hotels, and hundreds of budget and 3-star hotels in Jaipur.
Dr. Tarun Oja, the organizing secretary of AOICON 2023, with our organizing chairman, Dr. Man Prakash Sharma, our ENT patrons and ENT colleagues of Rajasthan, promise you to do our best at AOICON 2023 Jaipur. We welcome you all with open hearts. Please do come. Thank you.
Hello. Hello.
Yes, yes, boss, we are with you.
Yes, boss. So this next patient is a female, 30-year-old female, who has been operated 3 times before somewhere
Yes.
for the nasal mass with no still without conclusive diagnosis.
Yes.
So मैं कर रहा हूँ 2 मिनट. So going through the MRI findings, as I told you, the histological findings are still uncertain. Different pathologists have different opinion.
Right.
And since the patient presented with bleeding, acute bleeding, so got the MRI done, and this was the finding. So this is enhancing mass lesion. Let me take both the sequences together, the T2 weighted and the contrast. See this mass lesion, which is enhancing on T2 also a little bit, and intense contrast enhancement. See this.
Yes.
In the maxillary sinus is just secretions.
Yes.
See the lining epithelium showing inflammation and non-enhancing secretions in the sinus. So it has
Right.
nothing to do. It is simply blockage of the drainage.
Yeah. Yes.
This mass lesion, right from anterior to posterior, looks like attached to the ethmoids
Right.
or extending towards the ethmoid.
Yes.
See the ethmoid attachment?
Posterior
Ethmoid
till
attachment
posterior.
and extending into the nasopharynx.
Yes.
Now, if we take the axial in consideration,
This one right side is of contrast, no?
yes, this is contrast.
Yes, yes.
Now see, this is in the nasopharynx, doesn't look like invading anywhere. See this?
Yes, clear of periosteum.
Yeah, it looks like this is the nasopharyngeal musculature behind.
Yes.
So maxillary sinus is blocked. There's basically a mass lesion in the posterior part of the nasal cavity. Nasopharynx, female patient, looks like attached to the ethmoid somewhere. See this?
Yes.
Maybe acquiring at this is the level of the sphenopalatine artery.
Sphenopalatine.
Yeah, maybe acquiring the blood supply from the sphenopalatine. Most likely, there cannot be any other reason in this region for the vasculature. So maybe one of the strategies is to, let's see, once we decongest and see the situation, to take the sphenopalatine in control first and remove this. Let's see how it goes. But this is simply a highly vascular mass. Female patient is still unconclusive. I told you, pathologists are divided in opinion for their inflammatory myoblastic tumor, myofibroblastic tumor, hemangiopericytoma, pseudo tumor, and so on.
To this, some academic knowledge I have read somewhere. The hemangiopericytoma has more chance of recurrence, no? More chance of residual or recurrence.
Yes, hemangiopericytoma is a locally infiltrative tumor.
Yes, sir.
It has a malignant potential as well.
Yes,
it can metastasize also. It could be anything.
Yes, yes.
See here, the final, decisive would be immunohistochemistry.
Yes.
Marker study will be final.
Right.
What exactly this is to formulate any required post-operative management. Right now, the surgical challenge is to deal with this, probably after controlling the sphenopalatine. And there's a female patient. This cannot be angiofibroma, but this is something very vascular.
So, sir, are you? Hello.
Yes,
are you planning for modified anchors, right?
Not really. It's not going far laterally anywhere.
Okay.
See, the lateral extension is not there. See
But
this?
there is no much space in the nasal cavity, no? So
Yeah, let's see how it bleeds.
Right, sir.
How it turns out. We can convert to the anchor anytime. The anchor is required in such situation to have more space to control the things, to control the vessels and remove it. More hands you can
accommodate.
use, more instruments you can accommodate.
Yes,
More
yes, sir.
space to deal with the bleeding tumor.
Perfect.
So sometimes required.
Yes, sir.
So we'll be back shortly.
Right, sir.
Hmm.
Hello? Hello?
Hello? Hello? Yes, sir. Hello, sir.
Yes, not started, sir.
Sir, it's going to be start in few minutes, sir.
Okay.
Sir, the case is being induced, sir.
Okay.
So, sir, we'll let you know in just 5-10 minutes, sir.
Okay.
Okay, sir.
Hello. गाड़ी मतलब मंडे को काफी कुछ क्लियर हो जाएगा, हमें सब मिल जाएगा। तो इस वीक में मोस्ट प्रोबेबली आई विल गेट ऑल द डॉक्यूमेंट। तो अरे बहुत परेशान करके रखती है।
So what?
Hello, sir.
Cable connection. You on again? Yeah. Hello.
Yes, sir.
Yes, boss. So we are ready with the next case.
Okay, sir.
As I mentioned, it's a nasal mass, vascular nasal mass in a female patient.
Okay, sir.
So just in a minute's time, we'll be with the endoscopic picture. Connect karo bhai. क्या हुआ?
Yes, sir.
नहीं near use. ये केबल कहाँ जा रही है?
Hmm. Light, light on. Hello.
Yes, sir.
Yes, sir. Sir, let me know if you get the endoscopic picture. Viru, endoscope.
Yeah, yes, sir. We are getting.
Okay. So this is the initial picture. This was the packing place for the bleeding.
Yes, sir.
See, this is the nasal mask.
Yes, sir.
See how it bleeds on touch.
Yes, sir.
So first of all, we'll take the biopsy.
Okay, sir.
The tissue will be sent for histopathology debrider, as well as pack the pack. Immunohistochemistry. See, it is ascending towards the ethmoids.
Yes, yes, sir.
Like that. Suction look.
Sir, is easily friable, sir?
Yeah, it is friable. It is friable. So what we'll do meantime, I will resect the part of the middle turbinate, do some middle metal enterostomy and acquire some space.
Okay, sir.
For later. आवाज आती रहनी चाहिए. See, acquiring some space in the middle meatus.
Yes, sir.
Removing this anterior inferior portion of the middle turbinate.
Okay, sir.
Peg them. Peg bite. देखो bleeding mass. Peg biting. नहीं wash कर. एक हाथ में wash कर ले. So I'm just opening the middle meatus. We'll look for the sphenopalatine area. I've already taken a biopsy.
Okay, sir.
Viable है. No, debrider. 40 there. Give me 40 debrider. quick. Okay, no?
क्या कर रहे थे? थक गए हो?
Sir, it looks like plasmacytoma, sir.
See,
Grassy.
there are variety of mesenchymal tumors. Variety of mesenchymal tumors.
Yes, sir.
We never know exactly what it is. That's why we want a detailed histopathology and immunohistochemistry. But presented of the bleeding, excisable, whatever it is, the treatment is going to be same initially.
Okay, sir.
If it turns out to be plasmacytoma, will require additional radiotherapy. Radiotherapy is the treatment of choice for that.
Yes, yes, yes.
So, what I have done, that's a middle metal antrostomy.
Yes, sir.
And all now. That is
I think, sir, your
perpendicular.
next step is to identify spinopelvic artery, right?
Yeah, I am going to that region in case
Yes.
required to be. You see the vessel?
Yes. It has come out already.
See the vessel which is supplying. Water come. Okay, this will improve the situation.
Yes, sir.
Though I will go to that vessel later on to clip it required, if required, clipping. No.
Is it a main spinopelvic or some branch of it, sir?
Could be some branch. See, this access is important. Right now, I'm just giving time to improve the access.
Right.
Chalo, निकालो इसे. Section का. Debrider. Sit. See,
It's
this mass
separated.
is segregated.
Yes, yes.
This is segregated. Since we have already taken the biopsy, I will quickly debride it. See, it is completely segregated.
Yes, yes.
Okay. What is there? And this is the attachment which we will deal with. Then I will leave. There. See now this segregated portion I am debriding to acquire more space. See, this portion doesn't have any attachment now.
Yes, yes, yes. It has. Firstly, looks like plasma cytoma. Sir.
Could be. I can't say histologically what it could be.
Yes.
Biopsy already taken. लो इसको भी ले लो.
Yes, yes.
What?
Find all. So we have now the luminal component we have removed. See that?
Yes, yes, clear. Sir.
That was the maxillary sinus, and see where it is attached to.
Yes.
I told you it is looking like having attachment to the ethmoid. See this?
Yes, yes.
This is where it is attached to. This is where it is attached to. Come jaldi. Suction पानी ये तो बोले रखा कर. Right. Funny. Now I am going towards the. This is the anti-ethmoidal cavity. Uncinate. What? Wash. Let's see where it is. पुला दे उसको यार तेरे बस. See the area of interest.
Yes, yes.
पकड़ ले. Right. Quick. बाकी तेरे बस की नहीं है यार. दे. Suction कर. According to the MRI also it was attached to these ethmoidal septations.
Yes, sir.
Suction कर. Okay. Next 2 minutes will be through. Operating in the bleeding field.
अब मैं बोलना मत है, बेटा मैंने ऑन किया है।
बुला दे होते तो फ्री हो गया। खोल यार किसी का। This is the area where I am going to take the control of the artery. All bony septations been removed from where this tumor was taking origin. See this one.
Yes.
That's the region of the vessel. Will take the proper control of the vessel. बुला दे उसको.
Sir, you will strip mucosa from ethmoid.
Yeah. Straight there. बुला यार.
Are you going to clip the vessel or bipolarize, sir?
Yeah, the clip. We'll clip it most likely.
Does bipolarize is sufficient if you don't have a clip sometimes?
Yeah,
For spinopalatine?
you can.
Okay,
The
sir.
clipping is the,
More safe.
certain method, more safer side.
Yes.
No chance of rebleeding.
Yes.
रखना section. इधर रखना. ये बात नहीं. See that the sphenoid sinus?
Yeah.
Yes.
See the area of interest is here.
Yes.
I'm circumscribing from all sides to reach to the key area. इधर आ. Like that. बुला देना. क्या बोला? Now see, all around we have seen the ethmoidal cavity, absolutely free, the sphenoid wall, the maxillary sinus.
Yes.
Everything pretty clear. Now this area of interest where this tumor is attached to and getting supply from the vessel is important. Give me the chisel and hammer. See here is the tumor.
Yes.
So what I was doing, a little bit of the bleeding going on with, don't mind that. Halka. Yes. See, I'm opening the pterygopalatine fossa.
Yes, yes.
Yes.
See the earlier vessel which was bleeding was the greater palatine.
Yes.
See here,
Yes.
below, that is greater palatine. See this?
Yeah, yes. Clear.
This is greater palatine.
Hmm.
पानी 1 किलोमीटर दूर रखता है क्या? See, I am opening the medial part of the pterygopalatine fossa.
Hmm. There is some tumor underlying, I suppose.
The tumor is here.
Yes.
And see the vessel going to the tumor.
Yes,
see the vessel.
Bleeding, yes.
Clear, clear.
Could you see the huge vessel?
Yes, yes.
Yes, sir.
There is some. That's why tumor will remove in no time once we take the vessel control laterally. See? Exposure of the pterygopalatine fossa.
Yes, yes. Fantastic.
Periosteum. See the main vessel?
Yes, sir.
Could you?
Yes, yes.
You know?
Oh, it's a bit larger in diameter.
Yes.
Wow, fantastic.
It's gone.
You will clip it, sir?
Literally first, yes. Yes.
Okay.
This is one.
Yeah.
पूरा नहीं लगा. I will remove
Medially,
this.
sir, it is somewhere breached.
No, the clip is not properly applied.
Yes, yes.
Total. See the clip?
Yeah.
Let me remove this bone. Now we'll have a full control to clear it completely. See this?
Yes, yes.
Yes.
Everything under control. Without dankers.
Yes.
The brider. Lock oblator दो. जो अलग वैसा लगा. जो अलग वैसा लगा.
Which one is this, sir? Ascending?
This could be another branch. See this?
Yes. Branch of what?
Phenopalatine only.
No, give me 40 debrider. And now in no time we'll remove it.
Yes, sir.
Now everything is in the rubber cut.
This is like typical. Hello.
Yes, sir.
This is a typical origin in like angiofibroma, no? Very near to the spinopalatine area, the
See,
Viridian
any
canal.
vascular mass in this region
Yes,
will obviously be supplied
by
at the
spinopalatine.
sphenopalatine only.
Right.
There's no other big vessel in this region.
Right, sir.
Now finally, cobblator. We'll remove this. See this? The limits?
Yes, perfect, sir. This is like safety margin you are taking.
Pardon?
This is like a safety margin along with the tumor you are taking from the normal mucosa.
Yes. We never know what it is.
Yes, sir.
ठीक है सर बहुत डिस्टर्ब
You will remove all the tissues, leaving the bare bone, right? Underlying.
Yes.
So here will come the Viridian vessel, no?
Yes. We have clipped it behind.
Viridian vessel.
See, this is the mass.
Yes.
वो they are. नहीं कैरी चाहिए कैरी सही दे Can somebody hold the head, please? So,
Are you removing the floor of sphenoid, sir?
yeah. Tumor along
with the floor bone.
anterior wall.
Anterior wall, yes.
Satish,
Yeah, please.
Is it the median nerve area?
Median now is
Little
gone.
medial.
I have removed that region completely, boss.
Okay. Inferior.
This tumor was taking blood supply from this region from the sphenopalatine. Called there. And
But sir,
was attached to the region of the sphenoidal wall.
for the interest of many, just point out where is the Vidian canal area, sir.
First Vidian, let me.
Okay. Just point it. That's it.
Yeah. Vidian canal is basically in the pterygopalatine fossa.
Fossa, yes.
Posteromedially, running posteriorly in the floor of the sphenoid.
Sphenoid, yes.
ठीक है यार, इसको सही करूँ मैं. जहाँ टच हो रहा है. चलो. Now see this part of the anterior wall.
Yes.
बहुत बड़ा दे दिया यार, क्या कर रहा है? Just a minute.
Yes, sir.
Wash. Yes. Now we'll show you. Wash. No. Straight ले ले, कब पतला.
करो. ना कर लो.
Yeah. See, this is the region of the Vidian canal, which I am sacrificing. That I've already told you, greater palatine. So now this tumor is segregated from all around. We do not know what exactly it is, but whatever, it has to be completely removed with the underlying bone. पानी रखा. Gobletter. See the eustachian tube area below?
Yes, sir.
पानी रखना 1 किलोमीटर दूर लेके जाता है. बीमारी है क्या? See the eustachian area below?
Yes.
Band. And finally, this area I need to drill. I will drill away this completely.
Anterior wall and floor.
Yeah, because that is the key area where this tumor was attached to.
Yes.
Rest we are away from, everything.
Yes, sir.
There is no tumor around anywhere.
Yes.
Wide margins everywhere.
Very nice, sir. Beautiful.
No, drill.
This is nearly the same way we are drilling in angiofibroma, no? This. Possible. No, I got it. Not exactly like that. But all possible sites has to be drilled. No bone, no porous bone has to be left.
Yeah. See the part of the pterygoid process?
Yes. Medial
That is the
pterygoid.
medial pterygoid plate.
Yes.
क्या करते हैं? See the normal sinus cavity?
Yes.
Good. चल इधर ध्यान दे See how the anterior face of the sphenoid.
Yes.
Divided है ना 40. That is the floor of the sphenoid. That's the floor of the sphenoid with polypoidal mucosa.
Yes, sir.
You can see. Okay? Just polypoidal mucosa. I can remove this.
Yes, sir. Sir, on right side. Hello.
Yeah, all. That's the Vidian canal. See this? Vidian now.
Vidian now vessels.
Clear.
At the junction of the medial pterygoid plate with the sphenoid body is the Vidian now. Later.
Sir, if we drill little bit more on midden this pterygoid plate, we can nearly approach the area of foramen rotundum, right, sir?
Rotundum is little lateral to the
little, yeah, few millimeter lateral just.
Yes.
That we have encountered many in case of mucor.
Foramen rotundum passes through the pterygoid process.
Yes.
Superolateral to the Vidian canal.
Yes.
This
is near perfect.
See the nasopharynx?
Superb, boss.
That is Eustachian tube.
Yes.
Look up later.
Pterygoperitine. This. Some vessel is cut.
Greater palatine.
बंद है crowd section है ना so that's the final picture. We'll
Just sir, ethmoid once again, sir.
Pardon?
Ethmoid, just sir, superior, just see. Ethmoid
cavity. Ethmoid cavity is clear.
Yeah, superior little bit.
Yeah, let me show you. There's a maxillary sinus.
Yes, sir. Just see in that region.
Show this.
Yeah, it's pretty clear.
Yeah, absolutely clear.
Yeah. This
I've gone little wider everywhere.
Yes. Boss, you would like to remove this unhealthy mucosa of maxillary sinus or
No, no, this is just
not
because
really?
of the
Hampered ventilation. Yeah.
yeah. No, then
No, this
ventilation
is
drainage was affected.
more than adequate, sir. Perfect.
Okay, no, build the nice.
Sir, any disadvantage if you have approach through Danker other than
Not needed.
crusting
It
and
was not
healing?
going far laterally.
Right, right.
See, the anchor is approach.
Yeah. Basically, you should remove the tumor by whatever approach.
Yeah.
Yes, sir. This is upper part of medial pterygoid plate, sir?
Yeah.
Right.
Just is to just uncover if any.
Sir, can you show us the region of pterygoid venous plexus?
Pardon?
Pterygoid venous plexus.
Pterygoid venous plexus is distributed, scattered in various parts of the pterygopalatine and the infratemporal fossa.
Fossa.
It is deep to the muscles.
Yes.
So in various areas. So.
But sir, if we drill this pterygoid fossa, no?
Yeah.
There is invariably
Muscle
some
inside.
venous oozing.
There's nothing, just muscle inside.
No,
If I
not
open
in
the
this
fossa
case,
from here-
otherwise.
See, this is just a venous bleed.
Yes, sir. Sir, which venous bleed it is?
There's a lot of sphenoidal veins.
Okay.
Sometimes abnormal. These are not named veins.
Yes, sir.
I purposely went little wider all around.
Yes, sir.
In terms of bone removal, soft tissue removal, partition removal.
Right, sir.
Because this is unknown pathology, we never know. At
Yes,
least
sir.
now her nose will open up, the epistaxis will be taken care of, tumor is removed. Now let's
Yes,
see
sir.
the final
With all probable
histopathology.
safety margins.
Yeah, it turns out to be some benign pathology, nothing is required to be done.
Right, sir.
See the use taken tube. I drilled the
Yes,
floor
sir.
of the sphenoid and a part of
Yes,
the
sir.
anterior wall completely. So that
Exactly.
we don't leave any hidden areas where the tumor could be there.
Right,
See
sir.
that?
Right, sir. Perfect. Sir, can you please point out the pterygoid fossa?
This one. See this.
Yeah, this one.
Yeah, let me show you. This is medial pterygoid plate.
Yes.
This is good. This inside here is the pterygoid fossa. Here in this.
Fossa, yes.
If I drill this here,
Right, sir.
would be the
Yeah.
medial pterygoid muscle.
Yeah.
Tensor tympani and medial pterygoid muscle.
Right, sir.
So medial
My
most
question,
is the
sir.
tensor tympani. Take them.
Then medial pterygoid.
Yes. And now the beauty of the endoscopic procedure is the surveillance post-operative. You don't need imaging always.
Yes, sir.
In your office, you can see with your endoscope if anything going
Yes, sir.
wrong, if any recurrence
Right.
coming or anything like that. Watch back.
Perfect.
See, in your office, you can see everything with a 0-degree telescope.
Right, sir. Very
So we were-
meticulously done, sir.
So we were expecting this sphenopalatine to be the cause. Any mass in the posterior nasal cavity, bleeding mass, the supply has to come from the biggest vessel from that region, that is sphenopalatine.
Phenylpalatine.
Yeah, there is no other vessel.
Yes, sir.
Chalo, pack kar dena.
You made us master in
Okay,
this
ma'am.
area, sir.
Arey boss. So I think that is the last case to demonstrate. We have other cases going on, some stapes and remaining parotid and all that.
Are you going to do parotid?
We have already asked for the
Raise the flap.
elevation, but I think that is not for demonstration. I don't know.
Okay. Tarun boss, बताइए.
किधर है?
तरुण जी.
Hello. Hello.
हाँ भाई
Hi,
साहब.
Devang sir.
So
Demonstrate हो रहा है parotid?
It is
Parotid.
Wardheim's tumor.
Parotid, I would ask Dr. Satish.
नहीं, जो भी इच्छा हो सर, कोई दिक्कत.
You can see the MRI on the
Yes,
screen.
sir. Yes,
So
sir.
that is on
view.
FNAC. This is an old male patient, 62 years. Tumor in the lower part of the parotid. Smoker,
Yes.
elderly male. Tumor in the lower superficial part of the parotid.
Chances of malignancy.
Until proved otherwise, it is Wardheim's tumor.
Okay, sir.
Elderly male patient, smoker, with a tumor in the superficial lobe of the parotid, inferiorly towards the tail.
Yes,
Itself
sir.
is diagnosed.
Sir, what is the role of smoking? Role of smoking in parotid tail tumor?
Yeah, the Wardheim's tumor is, known amongst smokers, exclusively amongst smokers. Previously, it's assumed that the smoking tar from the smokers, that coal, passing through the duct leading to this tumor. So this is exclusively amongst smokers, elderly male patient,
right?
In the inferior part towards the tail, in the superficial lobe. These are classical features of Wardheim's tumor. And histologically, it is papillary cystadenoma lymphomatosum. The sheets of, papilla with multiple cysts, and lymphatic element.
Right,
So,
sir.
see on MRI here. This is the tumor in the lower part of the parotid.
Yes, sir.
Primarily, though it is a big one, but still primarily in the lower part.
Yes, sir.
And they are rarely malignant. If they are small, one can observe. A larger one, yes, there are reasons to remove. Sometimes pain or other symptom, cosmetic reason, fear of malignancy, uncertain diagnosis. That's why they are removed.
Right, sir.
Sir, what are the indications for adequate parotidectomy?
Adequate?
Yes, sir.
Where this terminology has come from, adequate?
Tata, sir. TMS, adequate parotidectomy, extracapsular enucleation.
Yeah, extracapsular is a terminology. European Society has classified from partial parotidectomy to extracapsular to superficial to total to radical to extended radical. Those are the terminologies which have been recognized.
Recently, I attended this webinar, sir, Tata TMS. So, new term, adequate parotidectomy indication is Wardheim tumor.
Yeah, so Wardheim's tumor doesn't need exploration of all parotid areas.
Yes, sir.
Mostly inferiorly, one or two segments of the parotid are involved. That too in the superficial part. It doesn't require a superficial parotidectomy most of the time. It requires dissection of one or two branches of the facial nerve where the tumor is located around, and removal of the tumor with the adequate cuff of tissue around.
Yes, yes.
Maybe people calling it adequate parotidectomy, but this is a sort of partial superficial parotidectomy. Extracapsular dissection is different. When you take the cuff of tissue around the tumor without looking at the facial nerve.
Yes, sir.
That too for the tumor arising in the superficial lobe, mobile tumors, without looking at the facial nerve. That is extracapsular for small tumors. But the gold standard is superficial parotilectomy. Since this is inferiorly dominating tumor, why to dissect the upper branches of the facial nerve unnecessarily? So this is a sort of partial superficial parotidectomy with dissecting of the branches of the facial nerve in the vicinity of the tumor.
Okay, sir.
So it is, I think, what time? 8:40. So here the goal is identify the facial nerve, preserve the branches in the vicinity of the tumor inferiorly, and remove the tumor from the superficial lobe. लोकल लगा दिया क्या? क्या किया? इंसिजन लगाना. ये ब्रांच बचानी है बेचारी के लिए. जल्दी उठो. कैनाल के पीछे से. हेलो. Hello.
Yes, sir.
Yeah, so in 5 to 10 minutes time we'll be with you if you want to see.
Yes, yes, sir. We'll see, sir.
Okay. Yeah.
It's our pleasure, sir.
Yeah. In 5 to 10 minutes, the patient is being prepared. बोल रहे ना.
the Ignite AOICON live surgical workshop, we got to witness an array of cases demonstrated in detail by the magnanimous Dr. Satish Jain, sir. So thank you, sir, for giving us all your valuable time and enlightening us with your knowledge. I would like to thank Dr. Tarun Oja, sir, who is the professor and head, Department of ENT, Mahatma Gandhi Medical College, for organizing this wonderful workshop where we all could witness all the unique cases which we saw today. I would also like to thank all the moderators for their invaluable time and constantly giving their feedback in every case. This workshop would not have been possible without the nursing staff, the audiovisual technicians, the anesthetists, especially Dr. Priyamvada Gupta, and all the residents of anesthesia and ENT of Mahatma Gandhi Medical College who worked hard to make this workshop a success. Thank you all for joining us in the workshop. We are looking forward to seeing you in AOICON 2023, which will be held in 2nd to 5th Feb in Jaipur. Now, I would like Dr. Tarun Oja, sir, to speak a few words.
So we are very thankful to our management, our chairman, emeritus, Dr. M.L. Swankar, Dr. Vikas Chandra Swankar, and Mr. R.S. Soni to provide all the facilities in the institute for this wonderful workshop free of cost, and also the free cochlear implant. I would extend my heartfelt thanks to Dr. Bharti MB, Dr. Kaushal Seth, Dr. Ashwini, Dr. Soumya, Dr. Sunil Samdani, Kapil Sekka, Dr. Monish Grover, Dr. Pankaj Gupta, Dr. Markandeya Tiwari, Dr. Devang Gupta, Dr. Thiru, and Dr. Gautam to be here with us as moderator. And I would again request all of you to come to Jaipur for AOICON 2023 from 2nd to 5th Feb, which is going to be held in Birla Auditorium. This is your conference, and we all have all have to make this a great success. Thank you very much. And there is no need to thank our surgeon, Dr. Satish Jain, because he is one of the hosts. Though he is a guiding force behind all this upcoming conference, AOICON 2023. But still, thank you, Dr. Satish Jain.
Thank you, boss. Tarunji, good night.
No, good night. We are going to demonstrate one more case.
Okay, it's still there. Okay.
Yes. Parotid, superficial parotidectomy, which we have talked about.
तो बाटी खाने से पहले ही चूरमा खिला दिया आपने तो।
हाँ, अभी तो है। अभी आपको दाल बाटी के साथ चूरमा पूरा करेंगे। तो जाना मत।
नहीं, इधर ही है सर।
हाँ, बहुत सारे लोग अभी ऑनलाइन जुड़े हुए हैं।
हाँ, I know.
Yes.
Flap structure is now sub smart.
Huh?
Flap smart flap.
Sometimes. Hello. Hello. What is it?
With you. Hello.
Haji.
Yeah, please going.
Yeah, are you getting picture?
Yeah, but it's static pitch. Yeah, now dynamic.
Okay, clear. So the flap have been raised. Flap is important for many reasons. The thickness of the flap is important to prevent French syndrome. Then the incision behind the tragus, which is more cosmetically acceptable. And third is the preservation of the greater auricular nerve. See this greater auricular nerve? Can you see this now?
Yes, boss.
Yeah, so preservation of the posterior branch of the greater auricular nerve. Though it is more important people who wear earrings because it gives sensation to the lobule.
Thank you.
See this posterior branch.
Yes, sir.
What I can do, knife, to deflect this branch behind. So this branch,
Yes.
I'm deflecting behind with some tissue around. That's the great auricular. See this branch, I'm udhar pakad. This is normal parotid tissue. This way, this branch is reflected behind. See this branch going to the root of the auricle.
Yes.
So that is the posterior branch. This is important for the sensation of the auricle. That is your sternomastoid muscle.
Right.
Now quickly, this surgery, parotid surgery revolves around preservation of the facial nerve, basically.
Yes.
There are many techniques prevalent, many landmarks people take into consideration. Our technique is
Convergence.
convergent technique and it's quite reliable in the sense we'll be using two landmarks which are simple landmarks where the converge is the facial nerve. See, this is the tragal cartilage.
Yes.
It ends medially as a pointer.
That is a tragal pointer.
Yeah, that is one of the useful landmarks.
Yes.
See, the ideal landmark should be the one which is easily identifiable.
Yeah. And constant.
Constant.
The number of landmarks described, but them many of them are themselves are difficult to find.
Yes.
So that is the tragus. I'm skeletonizing it. See tragus ending as a pointer here.
Yeah.
I can feel the pointer. See this?
Yes, yes.
So one of the landmark would be tragal pointer, and the
Yes.
facial nerve, when it emerges out of the stylomastoid foramen, it is generally 1 centimeter inferior and medial to this landmark. Generally in that vicinity, 1 centimeter. And it is quite reliable.
Yes.
But you can't rely on single landmark. That's why
Yes.
we use this as a conversion technique where we'll look for another landmark inferiorly. This will be a superior landmark.
Yes.
Another will be inferiorly.
Posterior brachiogastric.
Yes, because posterior diagnostic is a common landmark. One can easily find.
Yes.
Now see, to identify this this greater auricular, one of the landmark, very important landmark is a branch of the retromandibular vein, which run inferiorly and parallel to it for almost a centimeter distance. Here, here. Now this is the interior border of the
Sternomastoid.
So here I am opening up to see the digastric anteromedially. See the facial plane?
Yeah.
Exactly. Yes.
Very nice plane.
Can you see this muscle?
Yeah.
This is digastric. So this is one of the simplest landmark one can identify.
Yes.
Now this we know in the temporal bone also.
Yes.
Digastric ridge as one of the landmarks with the facial nerve is anteromedial to it.
Yes.
So once you see this digastric, anything lateral to this level,
you can cut.
Safe. It's safe. The facial nerve cannot come lateral to it.
Yes.
See, you can open up this entire area like a book once you remove the tissue lateral to the digastric. All this tissue lateral to it can go. See, all tissue lateral to the digastric can go.
Yes.
So this opens up the space rather than digging a well. Goes there. See this digastric?
Yes, yes, very well. Evan?
Now this digastric gets inserted on the mastoid tip here. Just above the insertion of the digastric and medial to it, just superior and medial to it, is where the facial nerve comes out of the stylomastoid foramen. This is your tragal pointer here.
Yes.
All this tissue lateral to the digastric. So I can reach out, I want to reach out at the anterior border of the digastric here. एक retractor इधर लगाओ, छोटा है यार ये, क्या retractor है? That's the digastric. Okay. And see just about the attachment of the digastric.
Is it a now?
Yes. This is digastric which is attached here. That's the facial now.
Yeah.
Very clear?
Yes, sir.
See the facial now.
So it is just medial to the anterior, this attachment of posterior belly of digastric, right?
Yes, immediately.
Immediately.
Where it emerges out of the stylomastoid.
Stylomastoid. Yeah.
We see the same anatomy in the temporal bone as well.
Right.
Now this is your tragal pointer.
Yes, sir.
1 centimeter, see 1 centimeter inferior, 1 centimeter deep. Where it
Medial.
emerges.
Very nice.
What a constant landmark. Now, once you have identified, we have to follow this, staying lateral to the nerve. And you can see the nerve dividing into two divisions.
Yes.
See that?
Right, sir. Perfectly right.
The divisions.
Yes.
Now, this is the tumor entirely in the superficial lobe. This is, see the upper division.
Upper one, yes. Sir, can I have a question?
And now staying in this plane.
Yes. With
lateral
bipolar.
to the nerve. Yeah. Hold on.
Sir, can I ask a question not related with parotid?
Yeah, please.
It is with the thyroid. It has, I mean to say, in how many patients you see division of recurrent laryngeal nerve, especially medial and lateral division? You saw many times?
No. Majority.
Majority?
Yeah, before piercing the larynx.
Yes.
Majority.
Okay.
See, that's the upper division and this is the superior most branch.
Yes.
That is the frontal branch. temporal branch, whatever.
Temporal. Yes, yes.
That's an important branch. See, branch is going up.
Yes, yes.
You have to stay
Lateral.
just lateral.
Yes, sir.
Now we will round off. Round off. नहीं रुक इससे कर देता हूँ. See, I am keeping a lateral traction on my instrument to
Yes,
keep this away from the nerve.
Yeah.
See, that's the branch going up.
Yes, sir.
We can leave that.
Yes, sir. Carotid.
Yes.
Must have.
Then this
Yes,
looks
master.
like zygomatic branch.
In medical book, they have all they have written only 5 branches. You will search for 9, 10, 11, 12, multiple. Lot of communicating branches.
Lot of. लिफ्ट करके करना है बाइपोलर जब मैं कहूँ वेरी क्लोज शुगर वेन हाँ
There is another branch, I think we can see.
Yes.
Zygomatic or some communicating?
Looks like communicating. Could be. Sometime, because the tumor may be distorted.
Yeah, I think it's a main branch, zygomatic.
Yeah, could be. Quite big one.
Yes, sir.
क्लीन कर इसको रिट्रैक्ट करें. See the tumor.
Yes, sir.
Just lift the instrument up to keep it away from the nerve. See, we are rounding off the tumor.
Yes, sir.
Scissors.
Satish boss.
Yes, yes.
On a lighter note, a lot of people are telling.
See, this is yes.
Lot of people are telling, like in many surgeries now, stimulator has made our life bit easy.
Which is nerve stimulator?
No. It's just a saying that now stimulator has made our life easy in many cases, many surgeries.
Nerve stimulator.
No, sir. My sentence is not completed yet. A lot of people are telling you have a, this now magnet. Wherever you pierce your artery, now comes out. Now these are some communicating, sir.
Yes, and see this, the cystic component.
Yeah.
Cystic component are dangerous in terms
Yes,
of,
sir.
removal. They are close to the nerve, adherent with a thin wall.
Yes, sir.
Separation is always possible.
One, two main branches.
See the cystic part.
Yeah. Yes, sir. Yes, sir. Very well seen.
So
It is
this was
engulfed into the
zygomatic only.
branches.
See? This was zygomatic only going there.
Yes, sir.
See this? It
Yes,
is,
sir.
little distorted because of this mass lesion,
Mass. Yeah.
which has pushed the nerve.
Yes, sir.
See, this is all clear.
Right.
Now going to the lower division. See, this is lower division.
Yes. Yes.
I'm opening up the space. This is normal tissue around.
Yes, sir.
See this? Opening up the space.
Yeah. Bit adherent, na? Bit adherent.
Cystic lesions, it is expected.
Okay.
See the walls of the cyst, if they are close to the nerve, you have to be extra careful.
Okay.
See the nerve?
Yes, sir.
And this tissue is lateral to it.
Yes.
See that's the nerve. So our nerve is within the divisions, or the tumor is within the divisions of the nerve now.
Yes, sir.
And soon going to be out.
Still to identify the branches of lower trunk, right? Lower division.
See the inferior branch I have seen which has gone down.
Down,
This
yes.
is the cervical branch.
Yeah, upper cervical. Yeah.
That is the cervical branch which has gone
Right.
down.
Yes, sir.
This is marginal mandibular.
Is it seen?
Yeah, this is marginal mandibular. And see, this is the cystic component. See this?
Buccal.
Yes, coming out.
Yeah.
See this now.
Yes.
See now the branches.
Yes. 1, 2, 3.
Here. And there are lots of intercommunicating rami.
Can we see retromandibular vein just below?
Yeah, it is here.
Yes, yes.
The nerves are crossing the vein, and see this is cervical branch. See this?
Cervical, yes, yes.
Running over the retromandibular. See this is vein, here it is.
Yes, yes. So surgery is almost done, I suppose.
We have to remove the tumor, that's it. Okay.
What do you want?
देखो ये ठीक है yes see the retromandibular
yes
This is marginal mandibular, this is lower buccal. The artery. See, the tumor is now.
Boss, whatever we try to preserve the nerves, no, usually we preserve in almost all the cases. But because of, bit of thermal trauma or stretching or mechanical
Traction is
pressure,
the biggest reason.
it causes
Biggest
some
reason is traction. Biggest reason is traction.
And in what time it comes?
Always don't give traction on the nerve, give traction on your instrument to stay away from nerve.
Yeah.
I told you, I was elevating the artery forceps, not the tumor, not the
Tumor.
nerve.
Yes. But even if we got paralysis, in what time it usually comes? 3 to 6 weeks?
It depends upon the individual's intercommunication.
Recovery and all. Okay.
Yeah.
Right.
But, the minor, things recover.
Right, sir.
Because even if some branch is injured here,
yes,
distally they have numerous intercommunications.
Yes, sir.
Before going to the end organ, there are numerous communications.
Right.
See, this is multiple cystic lesions. See this?
Right, sir. Right, sir.
So I don't know. Classical superficial
Parotidiectomy.
Yes, superficial parotidiectomy is a complete operation, even for malignancies.
Yes. Nothing less is mandate. To desirable.
That is gold standard surgery.
Yes, sir.
Yes. So you can see again all the branches. See this? The main trunk. And see the location. This is digastric.
Yes.
This is attached here. This is mastoid process.
Yes, exactly.
See where my finger is. Attached here immediately anteromedial, superomedial to it.
Yes, sir.
1 centimeter below and deep to the trigger pointer.
Exactly.
It is so reliable. Once you find the facial, now rest is dissection.
Right, sir.
Yeah. So थोड़ा 5 मिनट तू हेमोस्टेसिस करके बंद कर देना. चलो. तो फोन रखे थे ना. क्या बोल रही है? ठीक है मंगाया वो सब तो अपना वो
Hello.
Hello.
There is end of transmission, sir.
Yeah, now officially ending the transmission.
Okay.
We could not demonstrate stapies. One more stapies. We finished the side table.
Right, sir.
So thank you once again for your attention, your time.
Thank you very much, boss.
I think it is too late for everybody. Good night.
Good night, sir.